ஊர் பேரை வச்சுதானே வருது. பெரிய கவலை இந்த சிந்து வீடுகளின் அதோட ஷைன் Super Shaila. Jolly, he is very pretty and ஒரு பெருசு வாயு இது ஒரு மனிதை
Good morning, everyone. Today is day two of our conference, Mpisacon 2021. And myself, Dr. Neha Soni, Dr. Senior Resident, BMC, Sagar MP, and I am the host for the evening today. And today we'll start with our scientific session. And first of all, I would like to introduce you all to our respected chairpersons, Dr. Naveen Malhotra, sir, and Dr. Manish Jain, sir. Dr. Naveen Malhotra, sir. I am going to be his CV.
Thank you for the invite.
Thank you so much, sir. Uh, Dr. Naveen Malhotra, sir, he is the professor, Department of Anesthesiology and in charge Pain Management Center, Pandit BDS Postgraduate Institute of Medical Sciences, Rohtak, Haryana. And he has done MBBS, MD, Diplomat of the National Board, DNV, FICA, MNEMS, and he has done approx 137 publications, in which 47 are international, 90 national, and he has contributed 2 chapters in book on obstetric anesthesia and surgery for dental students, 229 presentations, guest lectures, and 3 papers. He has been an examiner for various institutes like PGIMR, AIMS, University of Delhi, Rajasthan University, SKIMS, and Charan Singh University, Utkal University, and many other. He is the recognized postgraduate teacher, Pandit BDS PGIMS Rohtak. And oh, मतलब आप मेल लिंक तो सेंड कर रहे हैं ना? क्या बोल Yeah. He has won various awards. Okay. He is currently he is the ISA National Honorary Secretary. Thank you, sir, so much for giving us your very precious time. Thank you for joining us, sir. Our next chairperson is Dr. Manish Jain, sir. Please give. Dr. Manish Jain, sir, he has done MBBS, LLRM Medical College, CCS University, Meerut, and he has done his MBA Anesthesiology, SN Medical College, Agra. He has done his senior resident from GB Pant Hospital, 3 months from November 2000 to Feb 2001, GTB Hospital, Delhi, about 2 years from April 2001 to December 2002. He has assistant professor from Shivati Medical College from 2002 to December 2007. Professor Shubharti Medical College from December 2010 to 23rd July 2020, and Venkateshwara Institute of Medical Sciences, Gajurala from 24th July 2020 to 30th Jan. And NCR Institute of Medical Sciences, Meerut from 1st March 2021 to till date. Thank you, sir, for joining us.
Thank you for.
The lecture for today is by Dr. Azam Danish, and the topic is knowledge is power. I'm going to introduce him to Dr. Muhammad Azam Danish, better known as Dr. Azam by his patients, is based in the Garden City of India, Bangalore, and is dedicated to advancing the specialty of anesthesiology and providing the safest and highest quality patient care to all his patients. Dr. Azam is practicing perioperative physician, critical care physician, a pain management specialist. Born in Kota and raised in Sandur, Azam Danish has aspirations of becoming a doctor who would be instrumental in saving lives. He got his life, his dream, and passed from Ramaiah Medical College in Bangalore. Dr. Azam then continued his journey to train in anesthesiology and critical care, doing his past graduation in DMD to now work as a consultant anesthesiologist and critical care specialist at Bhagavan Mahavir Jain Hospital, Bangalore. And he had a keen eye on work from M.Y. Ghorpade, a legend of photography. In the year 2008, he got an opportunity to travel and learn from Mr. Ghorpade himself and credits his interest and passion for photography to the legend. Thank you, sir, for giving your time to us. Now we can play your pre-recorded session, sir.
Thanks, Dr. Neha.
Thank you, sir.
I had actually sent you my CV. That's fine, not an issue. One of our ICU patients where a patient was quite obese and she was about 110, 115 kgs. So they thought by giving a pillow underneath the shoulders will create a ramp. So actually the ramp position is what I have shown in the picture, where the triggers of the ear and the sternum comes in one line, right? This is one. And second is, this is a small newborn baby where I was called in for saying that baby was not getting ventilated or not being ventilated. When I did the laryngoscopy, I found the tube was in the esophagus, so I intubated. But after that, I did an ultrasound done just to find out there were two tracheas. So my tube was in the trachea and the tube also in the esophagus. So it creates two tracheas. So right, with this, let's move forward. And at the outset, I'd like to thank the Madhya Pradesh ISA for giving me an opportunity, Dr. Amit Jain, Dr. Neha, and the entire team of ISA Madhya Pradesh for giving me an opportunity to be a part of this. So I have been asked to speak on knowledge is power. I hope I do some kind of justification. And whenever you see the star, that means it's important take-home points. Right, I am Dr. Azam. I'm a consultant anesthesiologist and critical care specialist at Bhagwan Mahavir Jain. hospital. So with this, let's get started. I do not have any disclosures, but however, this is completely a personal opinion on my personal experience. So please, ladies and gentlemen, take points that suits you. Uh, Whatever is good to you, you take home. Rest, you can trash it. Right. Now, what does really knowledge means? Knowledge is means understanding of something like such as facts, information, and description of a skill. Now, knowledge does not always come with power. Knowledge is the state of awareness or understanding and learning specific information about something, and it is gained from experience or study. The David Bailey said, the best advice I ever got was that knowledge is power and to keep reading, which is very true. Now, this is the biggest problem with the new generation of postgraduates. I may be wrong in saying that, but however, the greatest, as Stephen Hawking says, the greatest enemy of knowledge is not ignorance. It is the illusion of knowledge. What it means is the theory of I know and I know better is probably the first roadblock in the growth of budding anesthesiologists. I should understand what are my limitations. I should know what I don't know, right? I should be able to tell myself, okay, I don't know this. I may not be able to do this procedure, or I don't know this. I may not be able to do this case. So the worst thing is not knowing anything and still thinking I know is something that may lead to a disaster. So one must be very careful. As Rahul Dravid, the famous Indian cricketer, he says that if you try to grow bamboo on a patch of land, these slender, tall shoots don't grow for about first 5 years. And then suddenly they grow from tiny shoots to tall, full-grown trees in about 6 months. So what does the ignorant feel? The ignorant feels that the bamboo grew in 6 months, but we know that they were growing their roots in the first in the first 5 years, and its cumulative effort of 5.5 years to reach to where it was. And this is how patience and training works. Because Rahul Dravid, if you see the amount of training that he's undergone, nobody has seen. So we feel he's a very great player. It is just his luck. No, it's not like that. It's the hard work that has gone in. Now, the Robin Sharma says, run your own race. Who cares what others are doing? The only question that matters is, am I progressing? Now, what does this mean? I keep hearing postgraduate students saying, sir, she is working, she's not doing her duties. She's working very less. She's taking more offs. Fine, that's fine. That is she. But then you should decide what is good for you. She's a loser. If she's taking more off, she's not working hard, because post-graduation is something that you need to work very hard, because that is a time that you put in all your 100% and get the most of it, because that is a time where you've been taught, you've been criticized, you've been put on the right path, so that you become the best possible anesthesiologist. So please do not care about what your peers are doing. What is important is what you are, or how are you progressing, or how much efforts are you putting in, right? So this is what exactly it means. Now, just quickly, how to approach postgraduate training program. We all know that there are DNB, MD, and DA courses available, and we have primary candidates and secondary candidates. And advantage of secondary candidates of doing DNBs, they are post-diploma anesthesia students who are coming in for DNB secondary position. Now, they have an extra edge over the primary candidates because they have already been exposed to the foundation that has been laid on during the diploma courses. They know some amount of basics of anesthesia when they come to the DNB. And now these secondary candidates should fine-tune your procedures. Whatever you have learned, you should just fine-tune your procedures in your DNB. Now, post-graduation has a structured approach. Identify the areas of interest that you like, research, probably genuine research, and give your best and receive the worst. I'll come to each one of this when I come into my other slides. So when we say structured approach, it means the structured program for a trainer, not the training. So that is one thing. Second, we have primary DNB, MD. We have primary DNB students where they have to go through 3 years, and same as MD candidates, where again first year, second year, and 3 years course. But as far as there should be a structured approach. What I mean by this is we cannot expect a primary DNB student or a newly joined MD student to go and do a cardiac case, or go and do a cleft lip and cleft palate not even knowing about it, or do an epidural not knowing about it, which is not acceptable. So by first year, or in the first year of postgraduate training, PACs should be done. Now all components of PAC should be done. They should learn how to have an asepsis, and basis and the basics of spinal anesthesia, basics of airway management is necessary, right? And all the routine drugs that are being used, we should know about that. And before you actually do a procedure, one must do is observe carefully. Whenever your seniors or your consultants or your teachers or your professors are doing a procedure, observe carefully the way they hold the needle, the way they hold the laryngoscope, the way they insert the endotracheal tube, because observation will lead you to a different level when you're doing a procedure, because half the teaching is done if you observe carefully. That is one. Make sure you have adequate knowledge before you do a procedure. You cannot simply come and do a spinal because you like doing a spinal, because nowadays the DNP students feel, or anesthesia is just, they feel that it's just about the procedures. Okay, I have to just, anesthesia means I give spinal, I give epidural, maybe I give a block, and I'm done. No, it's not like that. It's much beyond that. So have a good knowledge before you do a procedure, good knowledge about the case, good knowledge about the spinals, good knowledge about intubation you do. Make sure you keep your egos where you leave your footwear, right? When you enter the OT, we remove our shoes, we get into our OT footwear, and we walk in. So leave your egos there and walk in. If egos are not good for you, it will not help you grow anywhere. Whenever required, please call for help, right? These are the few things that you should be doing in first year. Ensure you know everything. For example, you have a patient, say you would like to give a spinal who is posted for appendicectomy. Make sure you know everything about that patient, every single bit, every single investigations about that patient. Now, there are few stars here, which means that you should know about these things. One, as I said, master your PACs. Pre-anesthetic checkup is one thing where things can go wrong if you don't see the patient or don't carefully examine the patient. So make sure you know about that. Must know basic instruments like laryngoscopies, endotracheal tubes, and you should be able to interpret basic investigations like blood, ECG, X-rays, right? And all the basic drugs used in day-to-day anesthesia practice must know drugs. You should know about them. Now, when I say basic drugs, see, we use thiopentone, we use propofol, we use ketamine, we use succinylcholine, we use atrazine, we use vecuronium. So all these drugs should be known thoroughly, dominate. You have cisatrazine. And the dosage of all the drugs, and in the form of mg per kg, you cannot say ml per kg, mg per kg. So these are the drugs that you should by heart them, and these are the drugs that you will have to know before you do a case or before you get into the actual procedures. Always refer standard textbooks. You have Collins for regional anesthesia, because Collins gives you a vast amount of knowledge about regionals. You have Wiley, 5th edition for respiratory system. I'm giving an example. So now you must know the anatomy and physiology of all the basic systems. You can read from Miller's or whichever book, standard textbook, but make sure by the end of the first year, at least you will know these things for sure. One is whatever I said, the basic of your equipments, your pre-anesthetic evaluations, interpreting the interpretation of the blood investigations, few X-rays, ECGs, yeah, and by hearting of all the drugs according to the mg per kg dosage, and refer all the standard textbooks. Now, what you're not expected to know is, like, if you know, it's well and good, but definitely not specialized drug. We don't expect you to know what is levosimendan. But if you know nothing like it, we don't expect you to know the higher end drugs, or we don't expect you to manage ASA in grade 3 and grade 4, because that time will come for you after second year and the final year, or during the second year period. But if you know, it's well and good. And one should be able to perform spinal anesthesia and intubation during the first year of post graduation. Right at the end of first year, before your juniors come in, you should be thorough with your spinals, with your intubations. There is no doubt about it. By the time you clear your first year, you should be almost be you should be able to do your procedures on your own. Then what you should also be doing is, cases you have been allotted. For example, tomorrow you're going to the OT, you know that you're going to OTA or OT1. You have been given few cases. Please read about that day prior to it. So read and be well prepared, have a plan of anesthesia, because as a junior, the first 3 months in anesthesia, when you have come post MBBS, you have no idea what is happening. We give some gas, we give some injection, patient go to sleep, we do something, we keep them on maintenance of some gases, and we reverse the patient, and the patient wakes up. So everything is going to be new for the first initial 1 or 2 months. Don't get disappointed, don't get disheartened. That is the way everybody goes through. And not to forget, you must know about your anesthesia workstation or anesthesia machine. There is no shortcuts for that. So these are the few things. By the end of first year, you should be knowing this. Now I will play you some videos, like how a bad knowledge or bad skilled can do. Now we all know that there is hypoepiglottic ligament. What is hypoepiglottic ligament? Basically, it is one of the most important ligaments, and the ligament that connects the hyoid bone to the epiglottis, and the function is primarily to it's primarily during swallowing, to allow the epiglottis to close over the glottis so that it doesn't enter whatever we eat. And in airway management, whenever your valvula is there, you're very close to the hypoepiglottic ligament, right? That is how you should know about it. Then play you some video here. See the way they have done this. I'll just play this here. The way we are doing laryngoscopy, video laryngoscopy, the epiglottis gets inverted and gets into the vocal cords, that's not the right way of doing. And just see the other one here. This is valvula. That is where the hypoepiglottic ligament is there. You see this person, not just able to pass a tube. The problem is, you should know about, before doing a video laryngoscopy, you should know about a little bit of video laryngoscopy. We are using a deep blade. It's a Strauss blade. When you are using a deep blade, no point in going fully into the valvula. You need to come out a little. It will come out and give some cricoid pressure, and then passing the tube. So that is what it is. So multiple attempts have been taken to pass the endotracheal tube, which you should not be doing it. Right. Now, this is the other way of not to do the video laryngoscope, where just see, they're just not able to retract the tongue. See how difficult. That is when you're lacking knowledge, you're lacking skills, you're not doing it properly. So again, taken it out, again reinserting the laryngoscope. Again here, if you see the way we are doing, there are already vocal cords here, just not able to negotiate the blade. So this is definitely not the way, to be doing, somebody doing this laryngoscopy. These are the things that you need to read up. You need to observe properly. If there's a video laryngoscopy in your institute, please use that. Right. So this is what it is. Now, once he finishes final first year, he comes to the second year. Now here what happens is, the basic knowledge you've got, now you have read about the anatomy and physiology of all the basic structure, important organs. That is one. And here you should be, you should be able to perform difficult spinals. At second year, you should be able to do spinals, because at this point of time, your first, you would have finished first year, and your juniors would have come into the operating theater. They will take over the spinals, straightforward spinals. So you should allow them also to do the spinals. At the same time, whenever he or she is having a difficulty in performing spinals, you should be able to do this. Then start interpreting the documents document the cases for thesis. Now, you would have, you would have given a thesis, or you would have been allotted with the thesis. Now you start collecting the cases, start already accumulating the data for that. What is your aim of the study, and start doing that. Now, you should also be able to fine tune your procedures and spinals and use it. Many a times I hear, sir, it's okay whether I do like this or I do like this. The ultimate aim is CSF. No, it's not like that. Even when we are doing ultrasound guided nerve blocks, many a times we don't see the needle and we are giving the drug. Then why do you need ultrasound? Ultrasound is something like where we need to see the tip of a needle before giving a drug. So it's not acceptable and it is not okay. So please keep this in mind. Now, other thing that you need to know is you will be starting your cardiac and neuro anesthesia postings during your second year. So this is a time where you need to also get into these specialty postings. You need to read up those specialty postings, and good for you. And from second year onwards, you should be able to perform epidurals by now, because first year spinals, and maybe in the end of the first year, you'll be doing your epidurals. So you should be able to do your epidurals very easily. I'll give you a small example about, a postgraduate. I was just discussing about Goodell's airway. So the first question normally asked is, when was this Goodell's airway introduced? The answer was, sir, it was introduced long time back, which is, I felt very funny. So it is okay. With us, it is okay. But in the exam, can't answer something like that. So you should have a good knowledge about everything. Now, this is one more video. If somebody can tell me what is missing here, what is missing in this picture. So we are doing a pediatric case where there is a Jackson-Ridge saccade. It's connected. If you see here, the ETCO is not connected here. This was one of the postgraduate students which had some family issues or family problems, where she's just ventilating. Even the bag is not getting filled, she's trying to ventilate. Then, without even realizing, because her mind is elsewhere, or he or she, whoever it is. So the mind is elsewhere. So she's not forgotten to put the end-tidal carbon dioxide tubings to this. So you need to be always aware of what's happening. Now, another thing here, if you don't know what is this here, there's a patient with preeclampsia. You do a deep pendant reflex, that is the knee reflex, and you see this exaggerated response. You know that this patient is on either magnesium sulfate or complications, or getting into the complications of that. So once you finish your second year, you come into final year. Okay. Now in final year, you should have completed all your standard textbooks, reading about all your standard textbooks. There is no excuse for that. And there are a few other series like Race series, or if you have written your own notes, you can read those. And the Race series, very good information is there, and you can also read about few very good topics, right? Then you have, when you come in final year, you should be able to manage cases individually, because by now you would be very thorough with all this, and you should be able to manage cases on your own. You should also be able to do ASA grade 3, grade 4, obviously under observation. There'll be somebody backup for that. But when I say individually, so you should have completed. Always remember, this is another mistake where all the students are doing. You should complete your thesis at least 6 months before the exam. You need at least 6 months to get into a proper frame of mind, to sit in a place, to start reading about it, right? The most important take-home point is develop a skill that you can start preempting the events. Like, for example, I'll give you an example. You have a patient. You should get into a ability to catch a cardiopulmonary arrest even before the patient arrest. There's nothing great in doing CPR of the patient arrest. Even the technician knows how to do it. But then you are trained. You have a critical thinking, or start preempting. Obviously, that will come with the experience. Once you start preempting things, you can definitely prevent this happening, right? And by now you would have had an idea about the topics of where to read, which topic to read from. Now, the other problem when you enter third year or final year, we start feeling that we know everything now, right? Now, I'll just give you an example. Patient under general anesthesia, patient is bleeding, he gets into hypotension, and there is sevoflurane, full-blown sevoflurane about 1.5 to 2 MAC. First thing you need to think is patient is having hypertension. Yes, bleeding is the cause, but apart from that, let us not add on to anything that causes hypertension. So cut off your inhalation agents. That should come into your mind. What I see nowadays is there is hypertension going on, there is sevoflurane going on, or whatever desflurane or isoflurane is going on, which is not correct. So that is one thing you need to anticipate things or preempt things. So if you can develop this skill of anticipating events that can happen and you can prevent them, you will be a different level of anesthesiologist. You must be able to take your individual decisions, like in the sense, now you're doing a case, you should know that, okay, now I am the in charge of this case, I should know everything about the case and I should be able to manage. Yes, if you can't manage, there are backup teams, there are consultants, there are your senior postgraduates who will come and help you out, but otherwise you should be able to take your own decisions. Right now, I would like to tell you about this a small thing about this video. Watch your celebrations. So humility is an asset. I'll just play this video. Now, humility is an asset. What I mean by that is, if you sorry, if you have that in your arsenal, will always remain victorious. Most anesthetists will know how humbling anesthesia is. And if you are an established anesthetist, anesthesia sometimes may get complicated in the form of difficult airways, or a patient is bleeding, or a patient is in severe hypertension, etc. And with times you will be able to come out of these complexities, and it brings humility automatically. That is one thing that you need to learn from this. That is why it says watch your celebrations, right? So when you run the first few miles, don't start celebrating. Let me play this video again. Don't start celebrating as this gentleman is doing here. The finish line is not in sight yet, and your personal best is never is. So what this gentleman did was he started celebrating it much before, thinking that he will, but there's somebody else who overtook this. That should never happen. Now, we all know that there is, I think we know who is Oprah Winfrey. She said the reason I have been so successful, financially successful, is my focus has never ever for 1 minute been money, right? She said, she quotes, she never saw daylight. She used to come to work by 5:30 in the morning and go back when it was dark in the evening by about 7 or 8. So this is what is, make people big. And Sachin Tendulkar, we all know him, and how, that's why they say humility is an asset. He was playing his last one-day international, and he knows that that is the last match that he'll be playing. So a day before he said he practiced about 20,000 balls on the net, in the nets. So why? Because he wanted to do very well in his last match. That is what it means. Now, I have written a small seminar on airway. One of my friend presented a seminar on airway, a very good friend of mine, and he read everything of a seminar, A to Z about a seminar. And what he did was, when he was reading A to Z about seminar, he was very perfect, and he knew everything about airway. Unfortunately, after that, he presented his seminar on Friday, and for 1 week, he was not even able to intubate a ASA grade 1 patient. I mean, Malampati grade 1. So he was just not able to intubate. So he went crazy. So again, it brings down his egos, and he will realize where he stands. So these are the few things that I want to bring it to your notice. One important thing is, try and avoid dramas in life and at work. Please, ladies and gentlemen, for example, Bill Gates, I worked most nights until 10 p.m. while he was floating his own company. Only 2 weeks of off he took in 7 years. Of that, 1 week was for his marriage. So when I say avoid dramas in life and work, nowadays at a knee-jerk reflex, we have WhatsApp. We are lucky. We did not have WhatsApp. We did not have Facebook, so we never got distracted. But now, the present generation, just a WhatsApp message, I am not well, I'm not coming today. That's not going to happen. And it's so easy nowadays to just shoot a message like this, which is not done right. Now let's come into the different learning methods. There are many different learning methods which I felt which are easier, and I thought I should share with you all. So one is, how can you gain knowledge is by reading. By the best way is to teach others. Any difficult topic, just read and come, catch hold of a technician, whether he understands or not, that's not important. What is important is how much I can recall what I have read is more important. That is one. So start teaching others. Be curious. Suppose in first year you start doing this. I mean, in the first, as soon as you enter your anesthesia post graduation, that is in as a primary candidate, on first day you do spinals, you do intubations, you do epidurals. There is nothing there to be curious about. So be curious of what. So don't ever do a procedure without knowing it. Always have a discussion. Have a small group, 1 or 2 or 3 maximum. Have a small group discussions. You can discuss a difficult question and answers or a case, whatever you feel. You start learning even more. The most important is learn from the study. Learn from the failure. So this is very important. Whenever you fail, think that you're learning something. Never ever get disappointed. Never get disheartened. Whenever you fail in a procedure, you take it in a positive sense that yes, today I have learned something that you will avoid tomorrow. Today, I failed in spinal. So sit back and think, why did you fail in spinal? And that will take you to a different level. Always observe what others are doing, because most of your mistakes can be avoided by observation. Now, a lot of people say, or a lot of postgraduates says, sir, we are working from morning till evening, we do not have time for studying. Yes, we do understand you do not have time, but then you need to take out some time, read a topic, come to the operating theater, catch hold of your colleagues or catch hold of your consultants and start discussing with him or her, so that you will realize it's more important than you will realize how much you are able to recall. So these are the few methods. I'll come to this critic in my later slide. Now, to give you an example, the study tips and tricks, learning by writing. What I mean by saying this is, there are something called mind maps and flowcharts. Now, it has been proved beyond a doubt that mind maps are the easiest way of learning and easiest way of getting the data out and easiest way of absorbing into the brain and easier to produce in the exam. So there is no doubts about that. That is one. Second, I'll give you a small example. Create grid for all the questions. What do I mean by grid? Now, imagine there is a question, just an example. A question is asked on briefly discuss the anatomy and physiology in pediatric patients. So these are my following headings. I should remember these following headings. Body surface area, that is body size, 0.2 meter square average. Airway anatomy, yes, I shouldn't remember. CVS, I should discuss. Respiratory system, I should discuss. Renal, I should discuss. Hepatic system, I should discuss. CNS, hematology, body composition, thermoregulation. So if you know the side headings, then it will be easier for you to write the paper. Now, when I said mind maps or flow chart, this is exactly what I mean. I will not go into this detail, but this is how they say, try this. If you create mind maps like this, it is much easier for you to learn and easier to reproduce and easier to remember for a long duration. Again, these are the examples of mind maps. Again, it is much easier. It is very fun. Write like this particularly in DNB exam, you will get better marks. Now, how do we decode your own procedures? Now, how to decode your own procedures are, first thing is, after a procedure, sit and think how could you have done this better? In the sense, say you get spinal in first shot. Okay, fine. You're lucky, or you know about the procedure, fine. But don't stop at that. Sit and think, how can you make it much better? So start criticizing your own procedure, critique your own procedure. That is what exactly I mean. So suppose I do spinal, wow, I got a spinal, and don't get away or carried away by this. So sit and think back. So what best we can do? Or you can ask your colleague to record the procedures that you're doing, keeping the patient's profile hidden. Then you repeatedly see the procedure that you've done. That is the other way of learning. It is important to critique yourself rather than somebody else critiquing criticizing your procedures. So it's better I criticize my own procedure, see where I've gone wrong, and come back and do in a much better way, rather than you doing it, thinking that you have done the best. So then I thought, I came out with these my own notes, that is Dr. Azam's notes in anesthesia. I never have recommended people to study this, and because Dr. Amit Jain requested, I am just shooting this on my slide. And this has been e-published. The first edition was 2008, first edition, 10, second, third is 2013. Now I should be coming with my fourth edition. There are so many downloads in so many different countries. This is one thing I should tell. What's the problem in anesthesia is there is not one book where you get everything, answers for all the questions. So you need to refer multiple books. Whenever you're given a topic on seminar, ladies and gentlemen, please refer. Suppose a topic is on airway, refer at least multiple books, create your own notes, create your own slides, and bring it out so that it stays in for your long time. You make notes and keep it so that during your exam time you just have to revise them. So knowledge overcomes fear. Knowledge breaks down barrier and facilitates communication. It helps reveals the reasons behind the action. So suppose you know how to treat hypertension. If you have knowledge, you will know. Knowledge leads to intelligent decisions. Knowledge is motivation and empowering. Knowledge encourages involvement and breeds a feeling of ownership. Like you feel good about when you know about a subject. Knowledge creates opportunity, but at the same time, you need to be very humble as well. So again, ladies and gentlemen, this is a complete personal opinion on personal experience. Please take home what is required for you, what is good for you, and which will help you in your post-graduation. Rest you can trash it down. Now, before I end, I would like to say, knowledge is the key success. You could gain respect, power, position through knowledge. And knowledge is something, a treasure that cannot be stolen. And knowledge inside you will guide you through any obstacle that you come across. Right? So thank you for your kind attention. And if any questions are there, I'm happy to take. And once again, thanks ISA Madhya Pradesh for giving me an opportunity on such a wonderful topic. It is the need of the hour and a very well chosen topic. Thank you. And a special thanks to Dr. Amit Jain for inviting, and the entire crew of ISA Madhya Pradesh for putting up such a great show. Thank you so much once again.
Thank you so much, sir. It was an amazing lecture, and what valuable session it was, especially for the postgraduate students, and what wonderful quotes you have put in your slides. So I'm sure all the PG students will benefit a lot from your lecture. So the question and answer round will be after the second speaker is done. Okay. So I'll thank you so much, sir, for the session.
Thank you.
It's a great honor to share screen with you. Our next lecture is by Dr. and Professor Dr. Sandeep Sahu, sir, Update in Management of Traumatic Shock. Here's the scene. Dr. Sandeep Sahu, sir, he is MD, DNB, PDCC, MAMS, FAC, FICCM, and ICMR Fellow Trauma and Emergency Medicine from USA. He is Professor, Department of Anesthesiology, Intensive Care and Perioperative Medicine, Consultant, Transplant Anesthesiology, Emergency Medicine and Trauma. He is Honorary Secretary, Faculty Forum, SGPGIMS, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And he's the course director, SGPGI, Cardiac Resuscitation, ETLS, Focus, ETCM, ETDM, for state emergencies, instructor of ATLS, ACLS. Thank you, sir, for giving your precious time to us. Let's start the pre-recorded lecture, sir.
नमस्कार, मैं डॉक्टर संदीप साहू और मैं धन्यवाद देना चाहूँगा Mpisacon Organizing Committee 2021 and my chairperson, and we are going to discuss management of trauma hemorrhagic shock and update. So as we know, what is different we should do or what we are doing. So what are the evidence? So this talk I have keep like we will discuss hemorrhagic shock is not hypovolemic shock, means it's not diarrhea or dysentery, nausea, vomiting leading to dehydration. Because usually it's a misconception that we consider it's broader in category of hypovolemia, not hemorrhage. What is the ideal way of management of hemorrhagic shock? What is damage control, resuscitation, damage control surgery? Role of multiple blood transfusions and its protocol. What is the role of, we will just touch what is the role of colloid in hemorrhagic shock, and what is the role of tranexamic acid, and should we use vasopressor in hemorrhagic shock or not? So we are going to discuss a lot of controversy that is practiced in hemorrhagic shock. So as the slide shown, the trauma, if it is happening outside OT, road traffic accident or fall from height and leading to hemorrhagic shock and leading to bleeding inside the body, inside the chest, abdomen, pelvis, long bone fracture, this leaded to hemorrhagic shock. And whatever we are practicing in the OT under anesthesia, the bleeding is same like hemorrhagic shock. And sometimes ICU patient also bleed, whether it is a DIC or it's liver dysfunction. So things are same. All hemorrhagic shock due to trauma or other causes leading to bleeding outside or inside body, and patient go into shock, and shock is a circulatory failure leading to decreased peripheral tissue oxygenation, and it presents as hypotension. And usually for this hypotension management in OT ICU, we give either too much crystalloid or we use vasopressor. And my dear friends, मैं ये कहना चाहूंगा कि अगर आप किसी पेशेंट को शॉक में पा रहे हैं जिसमें ड्यू टू ब्लीडिंग ब्लड प्रेशर कम है, we will discuss this is a category 3 or category 4 shock. So category 3 or 4 hemorrhagic shock, अगर आप उसको crystalloid दे रहे हैं तो crystalloid we should use pre-warm 41 degree centigrade temperature. Never use more than 1 liter in 24 hours, because if you are giving fluid, we are replacing whole blood with crystalloid or colloid, and our blood is not crystalloid or colloid. We have something for oxygen carrying capacity, we have platelet and coagulation factor and other proteins, and this cannot be a replacement by crystalloid or colloid. And we can't increase the blood pressure on the cost of only the severe vasoconstriction, especially when the patient in shock. So role of vasopressor that we are usually using in bleeding patient in OT or ICU by use of vasopressors like mepinephrine or noradrenaline is not the choice. It is not practiced worldwide. अगर हमारे शरीर में प्लाज्मा और प्लाज्मा के अंदर जो ब्लड प्रोडक्ट हैं, जो सेल्स और WBC, RBC और कोगुलेशन फैक्टर प्लेटलेट अगर वो लॉस हुए हैं, तो हमको सिमिलर फ्लूइड को रिप्लेस करना पड़ेगा, because we don't want our patient goes in coagulopathy, because that is if the blood we have replaced with too much crystalloid, hypothermic fluid or colloid, and the chances of coagulopathy is more. And trauma is itself leading to systemic inflammatory response syndrome, and this is the cause of delayed mortality after trauma patients treated in emergency and came in ICU and leading into multiple organ failure. Because shock leading coagulopathy, and during resuscitation, if the temperature is below 36, the core temperature, the hypothermia, and shock leading to peripheral tissue, decreased tissue perfusion, cellular tissue perfusion leading to acidosis. This three combination is we are producing lethal triad, and its name is already said. Lethal means 90% of death in hospital during treatment in a trauma patient is because of this, either one or all three component. So our resuscitation should focus on these three issues. Because if we see the classification of hemorrhagic shock, this is clearly says that if class 1 shock means less than 15% of blood loss, my patient can have no hemodynamic change. Only 15 to 30 degree blood loss, my patient can have only slight tachycardia, no hypotension up to 30% of blood loss. But if the blood loss is more than 30 to 40 or more than 40, or we should consider it's not 40, it can be 100%. So from 30 to 100%, then only my patient will have hypotension. And the management for this category, class 3 and 4 shock, is use of blood product in form of massive blood transfusion, not the PRVC, not the crystallite, not the colloid. This is as per the latest ATLS guidelines that is practiced worldwide. Whatever the guidelines, CTLS, ATLS, ALS, all type of guidelines for hemorrhagic shock say limit the crystallite 1 liter, not give more than 1 liter, because if I have to give more than 1 liter means my patient has lost more than 50% of blood loss and plasma and coagulation factor and platelet. Then I can't only transfuse the ringer lactate or normal saline, and colloid is a big no in guidelines, because I am discussing this thing for severe injury or polytrauma patients, especially when the age is more than 60. The score is like that, patient depend on patient age, patient blood pressure. If ultrasound showing bleeding in the chest and abdomen and the pelvis, patient has pelvic fracture, or in ABG the lactate is high, then there is depend trauma bleeding severity score, or TASH, that is trauma associated severe hemorrhage. If it is depend on the gender, blood pressure, hemoglobin level, pulse, tachycardia, higher base axis in negative side, positive fast, unstable pelvic, or long bone fracture. This is also modification of, we can say, traumatic bleeding score or injury severity score. So depend on either of one of these three score. If my patient is coming in this category, this is a severe injury or polytrauma, means 2 or more than system, and patient is hemodynamic stable, having definitive injury that leading to different physiological severe changes in form of hypotension in the body and decrease more bleeding, decreased coagulation factor, and decreased tissue perfusion in the periphery. And it has effect on almost all vital organ, on the brain, lung, and peripheral organs like kidney and even liver. So what I should do when I got a trauma patient? We should try to stop, see if you are seeing blood on the floor, see 4 more. If any bleeding on the floor, that can be because of bleeding wound. So any bleeding wound should try to stop bleeding, because once अगर मैंने अपने पेशेंट का ब्लीडिंग को मैं से समझूं कि पानी की टंकी, अगर मैंने अपने घर की सारी पानी की टंकियां बंद कर दी, अब अगर मैं मोटर से उसके इंट्रावास्कुलर वॉल्यूम को भरूंगा, जो भी ब्लड प्रोडक्ट मैं दे रहा हूं, तो वो उस टंकी में स्टे करेंगे, टंकी भरेगी। अगर टोटियां खुली हुई हैं तो टंकी नहीं भरेगी। हम एनेस्थेटिस्ट क्या कर रहे हैं कि हम टंकी भरने की कोशिश कर रहे हैं, लेकिन एनाटॉमिकल इंजरी जो एब्डोमेन, चेस्ट, पेल्विस और लॉन्ग बोन में है, उसको स्टॉप करने के लिए मुझे सर्जिकल अपने फ्रेंड्स की जरूरत पड़ेगी, ताकि पेशेंट को जल्दी ऑपरेशन थिएटर ले जाके डैमेज कंट्रोल सर्जरी की जा सके। अगर लिम्ब की सर्जरी, लिम्ब में ब्लीडिंग है, लिम्ब मतलब हाथ या पैर की, जो कि लाइफ थ्रेटनिंग है, जो डायरेक्ट प्रेशर से नहीं रुक रही है, तो टूर्निके यूज करना चाहिए। अगर पेल्विक फ्रैक्चर है तो पेल्विक बाइंडर यूज करना चाहिए। अगर लॉन्ग बोन फ्रैक्चर है तो स्प्लिंट यूज करना चाहिए। अगर वी हैव हायर सेंटर एंड वी हैव फैसिलिटी फॉर एंजियोएम्बलाइजेशन, नाउ डेज कोई भी लीवर रिसेक्शन या स्प्लीनिक इंजरी को नहीं निकालता या किडनी इंजर्ड को, एंजियोम्बलाइजेशन करके भी हम जाके उस वाइटल ऑर्गन में स्मॉल कैथेटर डाल के ग्लू डाल देते हैं ताकि ब्लीडिंग बंद हो। तो करना है हमको DCR, मतलब डैमेज कंट्रोल बैलेंस्ड हीमोस्टैटिक रिसक्सेशन, ना कि मैं कहूंगा यो हनी रिसक्सेशन का, जहां पानी 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 हम दिए जा रहे हैं या फिर हम वैसो प्रेशर देके हम ब्लड प्रेशर बढ़ा रहे हैं। लेकिन वैसो ब्लड प्रेशर किस कॉस्ट पे बढ़ा रहे हैं? सिर्फ SVR बढ़ा के, पेरिफेरल वैसो कंस्ट्रिक्शन करके, ना कि हम ब्लीडिंग रोक के, ना उसमें ऑक्सीनेटेड ब्लड PRVC देके, ना कोगुलेशन फैक्टर प्लेटलेट देके, ना हम फाइब्रोजन बढ़ा के। तो जब हम ये सब नहीं करेंगे तो डेफिनेटली पेशेंट DIC में जाए। सो अगर आपने ऐसे ब्लीडिंग कंट्रोल किया, मोर चांसेस है पेशेंट की लाइफ बचेगी, उसकी फिजियोलॉजी ठीक होगी, सो दैट ही कैन अंडरगो डेफिनेटिव सर्जरी। और पहले ऐसा होता था कि पेशेंट प्री हॉस्पिटल से आया, हमें स्टेटस नहीं पता था, बहुत सारा वॉल्यूम दिया, सीधा ऑपरेशन थिएटर में गया, लंबा ऑपरेशन चला, पेशेंट अंदर OT में ब्लीड करता रहा, बाकी वो पहले ही ब्लीड कर चुका था और पेशेंट की डेथ हो गई। बट नाउ डेज वी आर मूविंग फ्रॉम क्लासिकल डैमेज कंट्रोल सर्जरी और इंटीग्रेटेड अप्रोच ऑफ डैमेज कंट्रोल और डैमेज कंट्रोल रिसक्सेशन एंड डैमेज कंट्रोल सर्जरी। सो ये जो इंटीग्रेशन है सर्जरी और डैमेज कंट्रोल रिसक्सेशन का, वो शुरू हो जाता है प्री हॉस्पिटल से। इसको कहते हैं रिमोट डैमेज कंट्रोल रिसक्सेशन। यहाँ पे प्री हॉस्पिटल में हमें क्या करना है, वर्ल्ड वाइड सब लोग कहते हैं कि हमें स्टॉप द ब्लीड करनी है, एयरवे मैनेज करना है, ऑक्सीनेशन देखना और पेशेंट को स्कूप और रन जितनी जल्दी हो सके ब्लीडिंग स्टॉप करते हुए अस्पताल ले जाएं। वहां पे नॉट ओवर जिलस वॉल्यूम रिसक्सेशन, 1 लीटर, अगर हमें 1 लीटर से ज्यादा वार्म क्रिस्टलाइट देना पड़ रहा है तो पेशेंट को डैमेज कंट्रोल रिसक्सेशन का पार्ट बनाते हुए हम उसको पहले OT में ले जाएंगे, जहां पे हम ब्लीडिंग पेट में, चेस्ट में, पैर में जहां भी ब्लीडिंग है उस ऑर्थोपेडिक या सर्जिकल इंटरवेंशन करके पहले ब्लीडिंग स्टॉप करेंगे। घंटों लंबी सर्जरी नहीं करेंगे ताकि और ब्लीडिंग ना हो। उसके बाद ये पेशेंट फिजियोलॉजी रिस्टोर करने के लिए ICU में जाएगा। ICU में यहाँ पे हम पेशेंट को हीमोडायनेमिकली, मेटाबॉलिकली और कोगुलेशन फैक्टर ब्लड प्रोडक्ट देके बिल्डअप करेंगे ताकि पेशेंट की डेफिनेटिव सर्जरी बाद में ICU से जाने के बाद पेशेंट ICU में से निकल के OT में दोबारा जाएगा जब वो लंबी सर्जरी टॉलरेट कर सकता है, जब उसके बेस डेफिशिट ठीक हो गई है, लैक्टेट ठीक हो गया है, कोगुलेशन फैक्टर नॉर्मल आ गए हैं, ब्लीडिंग स्टॉप हो गई है, और फिर उसकी डेफिनेटिव सर्जरी जो भी लाइफ सेविंग कर चुके हैं पहले हम ऑपरेटिव, उसको अब डेफिनेटिव सर्जरी करके करेक्ट करेंगे। और इस इंटीग्रेशन से हम रिस्टोर कर सकते हैं मोस्ट ऑफ द लाइफ एंड वी कैन सेव मोस्ट ऑफ द लाइफ। सो डैमेज कंट्रोल रिसक्सेशन के 3 पार्ट अगर हम बात करें, वी हैव टू गिव परमिसिव हाइपोटेंशन, minimize rebleed और secondary bleed by avoiding popping of the clot। so इसके लिए हमको 1 लीटर क्रिस्टलाइड रिंगर लैक्टेट यूज करना है, उससे ज्यादा नहीं। कोलाइड के लिए बिग नो है क्योंकि बहुत सारी गाइडलाइंस और बहुत सारी स्टडीज मेटा एनालिसिस ये कह चुकी हैं। ब्लड प्रेशर हम 70 to 80 सिस्टोलिक रखने की कोशिश करें, नॉट मोर देन दैट, बिकॉज इतने ब्लड प्रेशर पे मोस्ट ऑफ द वाइटल ऑर्गन कैन बी परफ्यूज्ड वेरी वेल एंड ऑक्सीनेटेड। अर्ली यूज ऑफ ब्लड प्रोडक्ट करें, सो PRVC FFP प्लेटलेट इन रेशियो 1:1। वार्म IV फ्लूइड दें, हाइपोथर्मिया को कंट्रोल करें, एक्सटर्नल इंटरनल कूलिंग की जो जरूरत है वो हम करें। So phase of damage control resuscitation start from pre-hospital or whenever patient come to you. In emergency and pre-hospital, we have to follow ATLS ABCD principle. Damage control resuscitation अगर pre-hospital से शुरू किया है तो बहुत बेटर है। Balanced hemostatic resuscitation करना है और ये इसको स्टेज 0 कहते हैं। उसके बाद स्टेज 1 मतलब जब पेशेंट को हम ब्लीडिंग कंट्रोल करने के लिए OT में ले गए और वहां पे हमने ब्लीडिंग कंट्रोल और जो कि कंटेमिनेटेड वुंड है उसको क्योर क्लीन किया, आइदर अब्डोमिनल पैकिंग और कंट्रोल ऑफ हेमरेज। उसके स्टेज 2 मतलब पेशेंट वापस ICU में आया, उसका टेम्परेचर हाइपोथर्मिया को करेक्ट किया, उसकी कोगुलोपैथी को ठीक किया, उसको वेंटिलेटरी सपोर्ट देना है तो वो दी, रीएसेस किया, एसिडोसिस करेक्ट की और देखा कि जो हमने एब्डोमिनल पैकिंग करी है कहीं उससे कंपार्टमेंट सिंड्रोम मींस रीनल परफ्यूजन या लीवर को जो ब्लीडिंग जो ब्लड फ्लो जाता है वो कम तो नहीं हो रहा है। otherwise diaphragmatic splinting, decrease venous return, negative effect on the respiration and venous return means cardiac output हो सकता है। उसके बाद स्टेज 3 है जिसमें हम दोबारा ओटी में जाते हैं अगले 24 आवर टाइम के अंदर और डेफिनेटिव रिपेयर और डेफिनेटिव क्लोजर करते हैं जहां भी एनाटॉमी का डिफेक्ट है। So nowadays damage control resuscitation is choice besides the simple resuscitation, and it has a major role in life saving. Worldwide people are doing. We don't need to do more research or Indian experience when the whole world is practicing like this in especially severe injury, polytrauma, hemorrhagic shock patients. So damage control करने के लिए we need massive blood transfusion, and it is well adapted by all the trauma system and modern trauma care. So what is a code red of multiple blood transfusion या massive transfusion protocol? There are 70. Whenever आपको लगा कि आपका patient penetrating mechanism है या उसका blood pressure less than 90 या heart rate 120 है, chest या abdomen में या pelvis में कहीं bleed है, और आपको ये भी हो सकता है कि आपको लगे एक पीआरवीसी हमको मोर देन 3 पीआरवीसी एक घंटे में देने की जरूरत पड़ गई है, या हार्ट रेट और सिस्टोलिक ब्लड प्रेशर का रेशियो मोर देन 1 है, एक्टिवेट द टीम, हैव a trigger plan, team is activated, use of early tranexamic acid, what test to be done hourly, and how to transfuse and what to transfuse and how to target transfusion, how to manage temperature and how to terminate this code red. This 70 to be considered. So whenever massive blood transfusion means more than 5 to 6 units of PRBC and other blood product needed within 4 hours, or you have to give more than 3 PRC in 1 hour or combination of that, then you have to activate massive blood transfusion protocol in your hospital with help of your transfusion and blood bank. So you need a team, dedicated team that helps for early transfer from pre-hospital, from emergency to the OT area or ICU area, and the coordinator will help, different coordinator for early bring of blood product. If blood product is taking time, then O negative blood product should be kept in all area where in all hospital where we are receiving trauma patients. So छोटा hospital है 5 बेड का या 500 बेड का, O नेगेटिव ब्लड प्रोडक्ट हम सेफली रख सकते हैं अपनी इमरजेंसी में और पेशेंट्स को दे सकते हैं। सो दूसरी बात ये देखा गया है कि वर्ल्ड वाइड, अगर आप वर्ल्ड वाइड क्या करते हैं, कोई भी ट्रॉमा पेशेंट आता है तो 3 घंटे के अंदर, 3 घंटा तो बहुत ज्यादा, 1 घंटे के अंदर उसको क्लॉट अच्छा बने, उसकी सबसे सस्ती दवा 50 रुपए का एम्पुल आता है, और पेरी ऑपरेटिव लोग इसको वर्ल्ड वाइड यूज करते हैं, ट्रॉमा पेशेंट भी यूज कर सकते हैं, करते ही हैं। ट्रांजिट एसिड इमीडिएट अगर हमने 1 घंटे के अंदर दिया, 70% सर्वाइवल के चांस है पेशेंट के। अगर हमने 15 मिनट डिले किया ट्रांजिट एसिड देना तो सर्वाइवल के चांस 10% डिक्रीज करते, और आपने 3 घंटे बाद दिया तो कोई बेनिफिट नहीं है। तो जैसी आए ध्यान रखना है कि हमको देना है। इवन क्रैश टू ट्रायल 22,000 पेशेंट जिसमें से 20,000 इंडियन पेशेंट डाटा है, वो भी यही कहते हैं कि ट्रांजिट एसिड रिड्यूसेस ब्लीडिंग इन even non-trauma patient in elective surgeries, and it reduces need for blood transfusion to 1/3. So 1 gram bolus over 10 minutes in first hour to be given as soon as patient come to you. Next 1 gram in next 8 hours, or as per the your local protocol. अब blood transfusion आपने ट्रिगर शुरू कर दिया तो कैसे टारगेट करेंगे, कैसे मेजर करें कि हमने कितने देना है? तो 3 मेथड है, या तो लैब ड्रिवन, इसमें टाइम लगता है 45 मिनट कम से कम, लेकिन आपने अपनी लैब में ट्रेन करना पड़ेगा कि मुझे सीवीसी, एचबी, पीटी, आईएनआर, एपीटीटी, फाइब्रोनोजन, एबीजी में मुझे लैक्टेट और आयनाइज्ड कैल्शियम और इलेक्ट्रोलाइट 1 घंटे में चाहिए। 45 मिनट से 1 घंटा, लेकिन अगर आप ट्रेन करेंगे जैसे हमने अपने यहाँ कर दिया तो 30 मिनट से 45 मिनट मैक्सिमम, 30 मिनट में आपको रिपोर्ट मिल सकती है। अदरवाइज आप पॉइंट ऑफ केयर टेस्टिंग करें, ये कॉस्टली है, लाइक टैग और रोटेम, और अगर ये भी नहीं है तो 1:1:1 फार्मूला वेल प्रूवन मींस गिव फर्स्ट एफएफपी not PRVC. First FFP platelet. Then if you have think that अब इसका बॉडी वेट का भी फार्मूला है कि 10 to 20 ml per kg आपको FFP क्रायो देना है। तो FFP क्रायो पहले आप 4 या 5 दीजिए, फिर आप 4-5 प्लेटलेट दीजिए अगर आपकी ब्लीडिंग नहीं रुक रही है, और अगर FFP देने से नहीं रुक रही तो क्रायो का इंतजाम भी करें। और जब ब्लीडिंग रुक जाए तो उसके बाद आप अगर टारगेटेड देना चाहें तो 7 से 8 अगर हीमोग्लोबिन है तो ठीक है, नहीं तो फिर आप उसी रेशियो में PRVC दे सकते हैं। सो जब हमको जनरली 4 या 5 जो रेशियो रखा गया है, नंबर रखे गए हैं कि इतना पहले मंगाना है, सो उसका कारण ये कि देखिए फर्स्ट बॉक्स में 4 PRVC, फिर 4 PRVC FFPN आपको क्रायो और फिर प्लेटलेट। तो ये जो मंगाने हैं, जो मैसिव ट्रांसफ्यूजन प्रोटोकॉल है, ये बिल्कुल ठीक है, क्योंकि अगर आप 20 ml per kg बॉडी वेट से भी देंगे तो 4 to 5 ही आता है अराउंड 50-60 kg में। आपको टारगेट करना हीमोग्लोबिन 7 से 8, INR 1.5 से 1.8, फाइब्रोजन 100 से 200 ग्राम, और प्लेटलेट मोर देन 50,000, और आयनाइज्ड कैल्शियम 1 to 2, and this is as per all the European or WFSA Ontario guidelines, whatever guidelines you want to follow, what they say target should be this. And always being an anesthetist, measure core temperature and peripheral temperature, prevent hypothermia even in OT and ICU, target more than 30 degrees centigrade, because every 30 minutes if you are not doing this, the patient can have more bleeding because of this hypothermia, because coagulation factor need a certain temperature to act, otherwise they will not act. So actively prevent and treat hypothermia, we know how to do it. And code red can be terminated once our patient is resuscitated, stabilized, vital are normal, left target are reached. So massive blood transfusion, we need either cross match type or we need O negative blood product. You can give lab investigation, or you can give 1:1 ratio FFP platelet or PRVC. Or if bleeding is not stopping, always arrange cryoprostate and give similar form like FFP platelet and PRVC 1:1. Keep calcium more than 1 to 2, and give calcium chloride to maintain this level. Use turmeric acid as soon as possible. Some patient need iodine, especially they have thrombocytopenia on antiplatelet drug. And always review patient antiplatelet or anticoagulant history, and avoid acidosis, hypothermia, and maintain a mean arterial pressure of 65 or systolic blood pressure 70 to 90. That is come in this massive transfusion protocol. So now after we have given less fluid, we have keep our target. Now we have given sufficient of blood product. What is the evidence on rules of vasopressor? Do they have any role in hemorrhagic shock? And this review article on Indian Journal like JOCP, they say traditionally vasopressor are contraindicated in early management of hemorrhagic shock due to their deleterious effect. So vasopressor is not recommended as per all the trauma guidelines like ATLS that is practiced worldwide. And the role of vasopressor remain controversial and no clear guidelines. So if there is no role clear, why we are using in every patient? Because severe vasoconstriction is not going to solve any shock. It's not septic shock, it is hemorrhagic shock. And we have to think of oxygenation and bleeding, and we have to save our patients. This article, vasopressor in trauma, it is a meta-analysis recently published in Anesthesia Analgesia. They also said it's because pathophysiology traumatic shock is different. Initially, it is sympatho-excitatory, means initially vasoconstriction in the patient. To preserve the mean arterial pressure, if body fail to do this compensation, then it goes in sympatho-inhibitory vasodilation. So all patients not needed, especially initial resuscitation hemorrhagic shock, should not use vasopressor. Only if patient have spinal cord injury because vasoplegia, because of sympathetic blockage, because of spinal shock, because of neurogenic shock, patient go in vasodilation. Or if your patient is having multiple organ failure, or if a patient has component of vasodilation because of general anesthetic, lekin it's not on presumed basis, till then you are not seeing the SVR. So if you have hemodynamic monitor that give you SVR, that you can see where is my patient SVR index, then only based on seeing this, we should use this, not in every patient. What's the role of colloid in trauma? Because perioperative, we are using like anything. If we have nothing, means we don't have blood product, and usually blood product come in 1 to 2 hours, and patient going to bleed, and we have to maintain the intravascular volume, and we have, because this colloid, they do coagulopathy, they adversely affect they can have anaphylaxis reaction. So in head injury, albumin is contraindicated. Has or other starches are not recommended in TBI. So colloid not to be used routinely in OT, ICU, or in emergency for hemorrhagic shock, because they can cause different coagulopathy and renal impairment. So it's not routine use till you don't have anything. जब आपके पास कोई तीर ही नहीं बचा है और आपको लगता है कि आपके पेशेंट की लाइफ नहीं बचा पाएंगे, तभी शायद, लेकिन not has. Balance, gelatin, ham some role. So we have to be watch that in which patient we should use, not in every patient. So my dear friend, it's very clear that we need a trauma team and trauma concept from pre-hospital, hospital, emergency, OT, ICU, so that we can implement damage control resuscitation. That is a part of anesthetist, and we need our surgeon friends, damage control surgery, and for damage controls surgery, we need to shift patient in OT early. Only cross-match hemoglobin is needed, without PAC, without think of full stomach, without think of the patient multiple medical problems. Because if we take this patient early in OT, we change our list and we take this patient early, and from no anesthetist we become yes anesthetist, then only we can be part of this trauma resuscitation team. And we have to target this damage controls resuscitation and surgery early to target lethal triad. We should not lead lethal triad to come in over to our patients. We should do balanced hemostatic resuscitation, not use colloid, crystallide, more than 1 liter. Don't use colloid. Permissive hypotension, systolic blood pressure 70 to 90. Early use of blood product 1:1:1, or as per your local protocol, but please use FFP cryoplatelet first. When bleeding stops, then please give PRVC, because that is not having any coagulation factor. And we should part of early bleeding control and definitive surgery, because that is not alternate to any resuscitation, any type of resuscitation you will do. Bleeding control and definitive surgery is a must to save life. And colloid and vasopressor routine use is not recommended, and it is very controversial. Thank you so much for active listening, and I am thankful to the chairpersons, all the organizer team, and the delegates listening this. And I will be very thankful if you imbibe this and keep in your practice. Thank you. Thank you so much.
Thank you so much, sir. It was an amazing lecture and a very valuable, very informative lecture it was. And it will be really helpful for all the postgraduate students also. And it's an honor to have you here, sir. Now the session is handed over to everyone and chairperson. If any queries are there, please proceed.
Thank you, Dr. Neha and organizing team. We are here to have the questions, so that any discussion or any controversy we can clear. Thank you.
I must congratulate Dr. Sahu and Dr. Danish for excellent lectures and topics, and heartiest congratulations to both of you for
Thank you, sir.
sharing the medicine.
Namaskar, sir, and thank you, sir.
Thank you, Dr. Sahu. Your presentation was very good.
Yes.
So, one thing, as you know, blood components are not easy to arrange immediately in any situation. It takes around 1 to 2 hours for cross matching and the arranging of the bloods. Hello.
Yes, sir. Yes, sir.
And in a small hospital, is it not easy where blood bank is not available? So we can't arrange blood immediately. So we have to send the patient outside and arrange the blood accordingly. And according to the type of the blood, sometimes it is very difficult to arrange blood timely. So according to you, you said colloid and crystalloid is not have to give in. Should we stick to this guideline, or should we practice some practical guidelines for the trauma management point of view? Because in the practice, all we are facing these problems, like in the PPH, although it is difficult, different topic, but in the PPH, we can't arrange the blood preoperatively for every patient. So suddenly we find patient goes into the tonic PPH and we have to do the emergency hysterectomy. Then we can't give blood, we have to arrange the blood. Then उसमें कैसे करेंगे आपकी नहीं पहले blood नहीं देंगे, colloid नहीं देंगे, then tachycardia is there, 170 heart rate, BP is going down 70, 80. Then colloid, you said I can give only 1 liter crystalloid and no
Sir,
colloid.
I understand your thoughts and I respect, because everybody is doing its own way, whatever way he can do best of the patient. But what I am saying, it is a standard worldwide practice. One thing is that in India, 80% we have orthopedic trauma. By default, we don't have poly or severe trauma, means your patient have abdominal bleed and chest bleed. That is very rare, and if it is there, the patient will not reach to hospital in India. It is sure. If this type of accident. Now, if we have orthopedic injury, being anesthetist, what we should change our practice. First, we should think of stop the bleed. So stop the bleed in 80% of orthopedic injury can be very well done by early involving of an orthopedic guy, or applying a splint, or putting a direct pressure. If both are not working, then we can think of inextremative lead of tourniquet in periphery. Because this patient to be go in OT, one thing, to stop the bleed, we should imbibe, because alone, anesthetist alone can do only airway. But we have to learn this, how to stop bleed, so that the blood loss जो हो रहा है उसको stop करना. दूसरी बात सर आपने अगर कही, तो मैं ये कहूंगा पहले घंटे में ट्रांजिक एसिड 50 रुपए का, मतलब 100 रुपए का दवा सब जगह अवेलेबल है. 1 ग्राम आप सब जगह दे सकते हैं. दूसरी चीज आप फोकस करें कैल्शियम पे. कैल्शियम भी सब जगह अवेलेबल है. आयनाइज कैल्शियम, पूरे कोगुलेशन फैक्टर के सारे कास्केड हमने आपने पढ़े एमबीबीएस में, कैल्शियम 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 कैल्शियम. सो अगर आप एबीजी करते हैं, तो मैं अपने पीजीआई में जब एबीजी करता हूं, मैं देखता हूं आयनाइज्ड कैल्शियम स्टैंडर्ड रूटीन पेशेंट का 0.6 आता है, जिसको ट्रॉमा ब्लीड नहीं है. तो वहां पे आयनाइज्ड कैल्शियम का लेवल बढ़ाने के लिए आप 2-4 एम्पुल अगर कैल्शियम दे रहे हो, बॉस आप गलत नहीं कर रहा कोई. तीसरी चीज, ब्लड प्रेशर टारगेट, अगर आप सिस्टोलिक 80-90, अगर आपने उसको 110 के ऊपर ले गए अगर आप, तो वो पेशेंट रीब्लीड करेगा. जो क्लॉट बन गया वो क्लॉट हटेगा. चौथी चीज सर देखिए, जहां बात है 40% से नीचे ब्लड लॉस, 30% से नीचे ब्लड लॉस है, वहां ब्लड प्रोडक्ट देने की जरूरत नहीं पड़ेगी. लेकिन 30% से ज्यादा ब्लड लॉस है, ये असेस करने के बाद हमको कोगुलेशन फैक्टर पे ज्यादा ध्यान देना है. अगर इतना आपने किया, इतना करके रखा है, और पेशेंट को एबीसीडी के फॉर्म में एटीएलएस के हिसाब से मैनेज किया है, तो स्टॉप द ब्लीड करने से ब्लड लॉस और ट्रांजिक एसिड यूज करने से ब्लड लॉस कम होगा. हमें हो सकता है कम ट्रांसफ्यूज करना पड़े. अगर 1 घंटे में, आप सही कह रहे हैं, 45 मिनट से 1 घंटा लगता है, लेकिन कई बार सलाइन मैच ब्लड प्रोडक्ट एक्सेप्ट पीआरवीसी अगर हम बात कर रहे हैं, तो आप एफएफपी क्रायो ये आपको जल्दी मिल सकते हैं, या 1 घंटे में भी आ सकते हैं. लेकिन टिल देन हम इतना करें. और इस पेशेंट को अगर हम छोटे हॉस्पिटल में, अगर वो पॉलीसीवियर ट्रॉमा है, तो रखना कोई फायदा नहीं. अब इंडिया में बाहर एक कमरे के अस्पताल के बाद ट्रॉमा रिसर्च सेंटर लिख देना कहाँ जस्टिफाइबल है?
Definitely.
We should transfer this patient to a definitive, जहां पे मैं मान रहा हूँ ट्रांसफर में हम इतने वेल इक्विप्ड नहीं है, लेकिन शायद 90% पेशेंट को हम बचा लेंगे, क्योंकि ना तो मैं लेप्रोटोमी करने वाला हूँ, ना चेस्ट सर्जरी करने वाला हूँ, ना पेल्विक रिपेयर करने वाला हूँ, ना स्पाइन सर्जरी करने वाला हूँ। तो जो पेशेंट प्राइमरी इंजरी जो हो चुकी है, जो हम सेकेंडरी डैमेज बचा सकते हैं इन मेडिकल केयर सर, अगर हम वो बचाएंगे, सोच बदलेंगे, तो डेफिनेटली हम अच्छा कर पाएंगे।
Can we guide the fluid therapy by the use of ultrasound or central line?
सर देखिए, बहुत सारे इंडिकेटर हैं, आप भी जानते हैं, डायनामिक और स्टैटिक, आईवीसी डायमीटर आप देख सकते हो। अब फिर वही बात है, छोटे हॉस्पिटल में जब वो चीज नहीं है, आप तो सर भारती में है, डेफिनेटली अगर वी हैव देन आईवीसी डायमीटर वी कैन सी इट। लेकिन वर्ल्ड वाइड सीधी बात ये है सर कि अगर हमारा 50 to 70 ml पर केजी बॉडी वेट से मेरा ब्लड वॉल्यूम है, जो कि एक एडल्ट में होता है, सो अगर मेरा 50 kg वेट है तो मेरा 2.5 से 3 लीटर ही ब्लड है वॉल्यूम, नॉट 5 लीटर जो कि एमबीबीएस की किताब में लिखा था अंग्रेजों के लिए। और मैं उस 3 लीटर का 30% मतलब 900 ml ब्लड लॉस तक मैं टॉलरेट करूंगा नॉर्मली। उसके ऊपर मुझे देना पड़ेंगे ब्लड प्रोडक्ट की 1 लीटर। अगर आपने कोलाइट से ज्यादा दिया, और आप जनरली हम क्या करते हैं 2, 3, 4 लीटर, उस समय तो ब्लड प्रेशर 1 घंटे मेंटेन रहेगा। फिर वो डाइल्यूशनल कोगुलोपैथी को कैसे बचाएंगे, उससे इंड्यूस जो हाइपोथर्मिया उसे हम कैसे बचाएंगे? और उस शॉक में भी देखिए तो एसिडोसिस, पेरिफेरल परफ्यूजन कम ही रहता है, हम कितना भी क्रिस्टलाइट देते। तो दैट्स व्हाई लीथल ट्रायल डायरेक्टेड जब तक रिसब्सटेशन नहीं होगा, और इसमें एनेस्थेटिस्ट सिखा सकता है और लोगों को टीम बना के, इवन किसी भी हॉस्पिटल में, कि भाई सर्जन को जल्दी आना है, अगर पेशेंट को ओटी में लेना है तो हमको जल्दी ओटी में लेना पड़ेगा। एयरवे कंट्रोल के हम लोग मास्टर हैं, वो हम किसी भी कंडीशन में, हमारा सेप्सिस वाला पेशेंट होता है, उतना लो वाइटल होता है उसका, तब भी हम लेते हैं। लेकिन विदाउट डिले, विदाउट अननेसेसरी इन्वेस्टिगेशन, विदाउट अनफिट, विदाउट फास्टिंग प्रॉब्लम, वी शुड टेक दिस पेशेंट अर्ली इन द ओटी। और जब ओटी में जल्दी पहुंचेगा और सर्जन जल्दी ऑपरेट करेगा, उसके बाद आईसीयू में पेशेंट जाएगा, वहां स्टेबलाइज होगा, सिनेरियो विल चेंज सर, थिंग्स विल चेंज if we follow this.
Sandeep sir, can I add something with your permission to Manish sir's question?
Yeah, Dr. Azam, please.
Yeah, sir, what Dr. Manish sir was asking is ultrasound. हाँ, suppose say as Sandeep sir was mentioning, trauma patient आ गया हमारे पास, तो हम लोगों ने resuscitate कर दिया। और imagine if this trauma patient has a ischemic heart disease, या his ejection fractions are too low. Yes, it does make a point to check कि हाँ, तभी देखेंगे IVC, क्योंकि आप इसको ज्यादा देंगे तो congestive cardiac failure में चले जाएगा। So in that situation, yes, we do understand that we need to check, but as sir was saying again, it's a quite dynamic that we need to, उसको सीखना भी आना चाहिए। बहुत छोटे हॉस्पिटल में होगा नहीं होगा is a questionable.
लेकिन फास्ट तो सीख सकते हैं, उसके बाद ये फास्ट भी सीख जाएंगे। एंड वी आर चेंजिंग, इंडिया इज चेंजिंग ए लॉट इन लास्ट 10 years। और आज हम फोरम पे हम बात कर रहे हैं, हमारे जो पीजी स्टूडेंट और नए फैकल्टी जो सुन रहे हैं, they are very dynamic, they are learning like anything, and things are evolving in anesthesia. And I believe in next 10 years things will be at par, like we have Mercedes in India now, we will have all this facility everywhere.
Yes.
Dr. Azim, can I ask? I think you have very much interest in the ultrasound. I say,
Yes, sir.
I am seeing. So, do you have any experience on the ultrasound guided intubation or tracheostomy?
Yes, sir. That's what in my talk I had shown one baby where this baby was intubated in esophagus, and we were called for saying that baby is not being ventilated. So, जब scope डाल के देखा तो I could realize that the tube was in esophagus, not in trachea. So, ये एक गलती मैंने क्या की कि मुझे अल्ट्रासाउंड पहले ही कर लेना चाहिए था ट्यूब डालने से पहले। So just to document that, I did an ultrasound later after I intubated, where I documented double trachea or 2 tracheas. So yes, we do ultrasound, but not. अभी problem ये है, patient को जल्दी बुलाना चाहिए OT को. He has to come at least 30 to 45 minutes before. Then scan is, yes, in patients who we are having difficulty airway, it is mandate that you do ultrasound and mark the cricoid cartilage. It is very important. Because in case of can't intubate, can't ventilate, yes, at that point of time we just stab in, and 1-2 cases को हमने किया है sir. Eventually post-op patient died, but otherwise yes.
And do you have any experience on the tracheostomy?
Percutaneous, yes, I have done not many. No, I have done couple, but majority of the times the ENT surgeons do it, sir.
Because I found in my practice, it is very useful for the percutaneous tracheostomy. We can find the intubated patient and we can find out the exact orifice for the puncture for the tracheostomy, because we find very much difficulty in the intubated patient for percutaneous tracheostomy.
G.
And by the use of ultrasound, we can detect the lower end of the endotracheal tube and we can easily puncture the trachea. So you can try for that also.
Yeah, blue rhino can be used. That's a good one. Yes.
This is very good and very easy, because the main difficulty is for puncture. And puncture after ultrasound, it is very simple.
सर एक चीज और ऐड करना चाहूंगा अगर आपकी आज्ञा हो तो, हम अपने स्टूडेंट को, जब मैं स्टूडेंट था तब भी पढ़ता था कि डिफिकल्ट एयरवे है, निडल क्रीको करनी है, निडल क्रीको करके वो जुगाड़ सेटिंग जो हमारे को सिखाई जाती थी कि 2 ml सिरिंज और उसके ऊपर 5 ml का कैनुला और उसे हम मशीन से, इट विल नॉट वर्क, नेवर विल वर्क.
No.
We have to tell that either emergency cricothyroidectomy or surgical cricothyroidectomy in emergency airway. Otherwise, we don't able to ventilate this patient, because needle will not solve. Needle will not able to ventilate. Otherwise, trapping CO2 more और वो जो जुगाड़ technique हम कहते थे, it will never work.
Dr. Sahu, jet ventilation is very good in these situations.
सर आप सही कह रहे हैं, लेकिन वो होना तो चाहिए.
हाँ, तो in your hospital in which we are talking about,
मतलब हमें यही कहा है कि जब अगर हम निडल डालेंगे, निडल क्रीको करेंगे तो जेट वेंटिलेटर अगर नहीं है तो नहीं करेंगे, फिर हम सर्जिकल या इमरजेंसी क्रीको करेंगे.
And we can use the combined approach of the open tracheostomy with percutaneous tracheostomy can be done. I have used in one patient in which ENT surgeon is hopeless, and I give the access to the trachea by percutaneous, and then he give the he done the open tracheostomy.
Great, sir. Great. Sir, time is up. I think they are.
I must congratulate both of you. You have given very good presentation. Thank you.
Thank you, sir. Thank you so much.
Thank you so much, everyone. Thank you so much, everyone, for joining us. Now let's proceed to our next session. And the chairpersons for our next session is Dr. Dilip Kothari, sir, Dr. Subodh Chaturvedi, sir, and Dr. Dilip Kothari. He is professor and head of Department of Anesthesiology, Gajraja Medical College, Gwalior, MP. He has done MBBS and MD. MBBS from GR Medical College, Gwalior, and MD also from the similar college. And he has many years of professional 35 international national publications. He is regular postgraduate thesis guide since 1995 and attended several national and state level conferences, delivered several guest lectures in various CME and academic meetings, chaired several scientific sessions in various conferences. He was a member secretary IEC GRMC and nodal officer walk-in interview committee GRMC, life member of first SOC of anesthesiology, and president of MP State Branch of ISA. And he has won Gwalior Chikitsa Ratna Award 2009 by Akhil Bharatiya Swasthya Sansthan Gwalior, Gold Medal for Anesthesia Awareness Award, and Director of the Year in the 2015 and Times of India Icon of Health Gwalior Award 2019. Thank you, sir, for joining us here. We are very honored to have you here. And our next chairperson is Dr. Subodh Chaturvedi. Dr. Subodh Chaturvedi, he is the chief anesthesiologist in pediatric anesthesia at Mohak Pediatric and Robotics, Indore. And he is MBBS diploma in anesthesiology. Clinical expertise, he has worked as a registrar in cardiothoracic anesthesia at Indraprasth Apollo Hospital, New Delhi from June 2006 to July 2007. Worked as registrar in Department of Cardiac Anesthesia in Fortis Escorts Hospital, Noida, and worked as consultant cardiac anesthesiologist at Vishesh Hospital, and currently working as consultant cardiac anesthesiologist at Gokuldas Heart Hospital from Feb 2001 till date, and has a cumulative experience of approx 3,000 cardiac procedures and independently administered anesthesia for approx 2,500 cardiac surgeries. Thank you, sir, for joining us here. Our speaker for today is Dr. Pankaj Kundra, sir, and the topic is physiologically difficult airway. I'm going to introduce his CV to everyone. Dr. Pankaj Kundra. He is a present academic position as Dean, Professor, Senior Scale, Department of Anesthesiology and Critical Care, JIPMER, Institute of National Importance. And he has got Lifetime Achievement Award, Indian Society of Anesthesiologists 2015, Orations 8, Best Original Research Publications 2018 and 2019, YG Bhojraj Award, Best Review Article 2019, Best Paper Award 7, Academic Appointments and Achievements, WHO Fellowship, Intensive Care and Interventional Pain Management, University Grants Commission Fellowship, Applications of Anesthesia, Hong Kong. Prince of Wales, visiting professor in 2 universities, and ex-vice president, All India Difficult Airway Association, AIDA, associate editor in the Airway official publication, ex-professor and head 3 years on rotation basis, Department of Anesthesiology, JIPMER, professor in charge, critical care, JIPMER, researcher. He has done approx 138 publications and he has approx 12 chapters in books. Thank you, sir, for joining us. And let's start our pre-recorded lecture of Dr. Pankaj, sir.
नहीं बस चार्जर दे देना। नीलू क्या कर रहा है?
Good morning to all of you, dear friends. Thank you very much for giving me this opportunity to share my views on physiologically difficult airway.
नहीं लगा रही।
Now, what is a physiological difficult airway? Well, all of us know that an anatomical difficult airway would be when we face a challenge of passing an endotracheal tube through the glottic opening despite visualizing it with our laryngoscope. On the other hand, when the patient is placed at a higher risk of physiological derangements like cardiovascular collapse with intubation or cardiovascular collapse when we start positive pressure ventilation, this is what would be defined as physiologically difficult airway. Now, life-threatening complications after emergency tracheal intubation have the highest rate, to an extent that cardiac arrest occurs in 4% of patients, that is 1 in 25. And severe cardiovascular compromise or severe cardiovascular collapse can occur in almost 30% patients. But the good side is there are certain predictors, and if we know that the patient falls into a higher category of developing such complications, we can still take some preemptive actions. So the predictors are pre-existing hypoxemia, pre-intubation hypotension, and a shock index which is more than 0.8. The physiological parameters or the physiological complications are likely to be exaggerated if an intubation attempt is made more than once. Now, what are the factors which determine a physiological difficult airway? There are 4 factors. One is hypoxemia, second is hypotension, severe metabolic acidosis, and right ventricular failure. So let's deal each one of them as a separate entity. When we encounter a patient who is already suffering from hypoxemia, we need to figure out what kind of respiratory failure the patient is in. Normally, there are 2 types of respiratory failures. One is type 1, which is also called as hypoxemic or oxygenation failure. The second one is hypercapnic or type 2 respiratory failure, where we also term it as ventilation failure. There can be a combination of both hypoxemic and hypercapnic, but to term a patient suffering from hypoxemic failure, the PaO2 should be less than 60 millimeters of mercury at FiO2 of 0.6. and it can be encountered in patients who have alveolar diseases, ARDS, cardiac failure, and pulmonary vascular diseases. On the other hand, the ventilation failure or type 2 respiratory failure occurs, or it's supposed to be in patients who have a PCO2 which is more than 50 millimeters of mercury, and at the same time the pH is less than 7.3. It can occur when patients have respiratory muscle fatigue, respiratory muscle weakness, CNS depression, or severe chest wall defects. Now, in hypoxemic failure or oxygenation failure, there is likely to be rapid desaturation during intubation. So hypoxemia is likely to worsen when the patient becomes apneic. These patients are likely to go into severe hemodynamic instability. They can suffer hypoxic brain damage, and they can also culminate into a cardiopulmonary arrest. So these are the problems which can occur with hypoxemic respiratory failure, which we have already seen in patients who are presenting to us with COVID. So what can be the principles of management of oxygenation failure or type 1 respiratory failure? First of all, we need to remember that you need to figure out that there are certain patients who are at risk of desaturation. These patients can have limited oxygen reserve, like in acute hypoxemic respiratory failure. Patients where the FRC is compromised, like in obesity, pregnancy, and infants, the diaphragm is pushed up into the thoracic cavity, therefore compromising on the existing FRC. The third parameter is also called as elevated diaphragm, which can occur because of increased intra-abdominal pressures. But remember, apart from the FRC, which is compromised, here the excursions of the diaphragm is also limited. So the diaphragm is almost splinted, and the patient is not able to move the diaphragm as he would be moving with spontaneous ventilation. The fourth one can be a difficult anatomical airway, where repeated attempts can pose a danger of hypoxemia which is occurring during the period of apnea. So what are the techniques which we can use to make sure that the time to desaturation is prolonged and we have a longer safe apnea time? We have always been taught about pre-oxygenation, and the objective of pre-oxygenation was that we do need denitrogenation so that all the anatomical space available in the airways is washed out or replaced by oxygen, which is being occupied by nitrogen. So it was basically defined as denitrogenation. And this was done when the patient was breathing spontaneously before induction of anesthesia. So we term it as an active phase, and the patient is able to take in oxygen with his spontaneous breaths. So that is how we perform pre-oxygenation for a long period of time. Now, the new entity comes in, which is called as an apneic phase. So during laryngoscopy, during intubation, if we can continue to supply oxygen through the nose, then the apnea time is likely to be prolonged. Not likely, it is prolonged, as the studies have shown us. So this is a passive phase, and it is termed as apneic oxygenation. So we do not now believe in only pre-oxygenation, but we believe in continuous oxygenation of the patient till the trachea or the airway is secured by an endotracheal tube. Now, how does this apneic oxygenation take place? Now, if you see, these blue molecules are of nitrogen, the white ones are oxygen, and the gray ones are carbon dioxide. So during the phase of apnea, we'll find that the oxygen goes into the blood and it is removed at a rate of 250 ml per minute that is the oxygen consumption of the body. And in return, the blood adds about 10 ml of carbon dioxide into the alveolus. So if you actually look into the alveolus volume, this volume of the alveolus will decrease because it has lost a lot of oxygen and it has been replaced only by a minute quantity of carbon dioxide. So the alveolar collapses. Once the alveolar collapses, it generates a subatmospheric pressure and sucks in the air from the upper airways to retain or regain back its normal size and shape. Hence, if we would have given continuous oxygen supply during this apnea period, instead of sucking in air from the upper airways, the alveoli would suck in oxygen. And therefore, the quantity of oxygen would be replenished every time the alveolar volume is being lost. And instead of air, you will have oxygen which will be replacing the nitrogen, which will be expanding the alveoli. And therefore, it actually prolongs the safe apnea period. So there's an apneic gas movement or a mass movement which occurs when the subatmospheric pressure is generated in the alveoli by the removal of oxygen and addition of a small quantity of carbon dioxide. Now, is apneic oxygenation always effective? No, it is not. It can only be taken up as a prophylactic measure. If your patient has already desaturated and then you start giving apneic oxygenation, it does not work. The reason is the alveoli which would have lost oxygen because of 250 ml being removed would have already expanded by sucking in air. So the patient is already desaturated. There is already low oxygen concentration in the alveoli. So there will be no significant diffusion because the pressure gradient doesn't exist now. And there is no subatmospheric pressure which will be generated after the patient has desaturated. So if you have to have a good effect or prolong the safe apnea period, the apneic oxygen should start right from the beginning, not when the patient has already started desaturation. So it should become a normal pattern that after pre-oxygenation, when we are performing endotracheal intubation or laryngoscopy, the patient should be on nasal oxygen. So what are the ways to provide effective apneic oxygenation? You require high oxygen concentration. For that, you will need an ancillary oxygen source. Minimum amount of oxygen flow that is required to travel down is about 15 liters per minute. You can use high flow nasal oxygen. But remember, when you use high flow nasal oxygen right from the beginning, your mask fit may not be appropriate. Okay, so your mask fit, if it is not appropriate, then there will be a lot of leak. So you will have to put in the high flow nasal oxygen once you remove the face mask from the patient. And the most important part, the upper airway should be patent. Because if there is an upper airway obstruction because of the soft palate or because of the epiglottis falling onto the posterior pharyngeal wall, the gate is already obstructed. So you need to open up the gateway and you will have to perform jaw thrust. At times, you should also put in a nasopharyngeal airway. If you keep the upper airway patent, then only the oxygen will travel from the upper airways into the alveoli. So this is the transnasal high flow nasal oxygen, nasal oxygen apparatus which is available. All of us have used during COVID times, and COVID has now trained us how to manage hypoxemic respiratory failure and how to overcome this physiological challenge during intubation in our patients who are there with us in ICU. So this is the interface. You will use a binasal cannula. Will these devices work in all patients? Will apneic oxygenation be helpful in all patients? The limiting factors are shunts. They can be anatomical shunts lung parenchymal shunts and pulmonary vascular shunts. If these shunts are present, then these devices are not likely to work. Let us see how. If there is a reduced FRC which extends to the ventilation perfusion mismatch, the FRC falls within the closing capacity and the alveoli are perfused but not ventilated. And this phenomena does not improve with 100% oxygen. This is one of the limiting factors. Now let's talk about the lung parenchymal shunts. Here we have the alveolus, and this is the pulmonary capillary which is going across, and we have the alveolo-pulmonary capillary membrane. Now if this alveolus is filled with fluid, like in pulmonary edema and ARDS, no matter how much oxygen you supplement from above, it is not likely to displace the fluid and provide you better oxygenation. So that's one of the limiting factors. The second aspect is if the alveoli are consolidated. So the oxygen passively would not flow into the alveoli. To expand this alveoli, you will need the pneumonia or consolidation to resolve. Then only these alveoli can be atelectasis, where the alveoli are collapsed. And if the alveoli are collapsed, passive oxygen diffusion will not occur into these collapsed alveoli. You will require some sort of a positive ventilation to recruit these alveoli before they participate in gas exchange. And the fourth one can be bronchial obstruction. So if you have bronchial obstruction, the alveoli or the oxygen is not likely to go into the alveoli. So these are the limiting factors of lung parenchymal shunts where apneic oxygenation may not work. The other kind which you can see is the alveoli are healthy, but there is a diffusion defect. There can be an interstitial lung disease where the diffusion is compromised, and therefore even if you give higher concentration of oxygen, the PO2 will only marginally increase. So yes, oxygenation will help, but it will help only to increase the PO2 marginally. Now what about the anatomical shunts? Anatomical shunts are that from pulmonary vein or a tributary, it goes to the pulmonary artery, bypassing the alveoli, so that there is no gas exchange which can occur to the blood which has bypassed without getting oxygenated into the pulmonary artery. So these are the problems which one can face. So what is the answer? The most appropriate answer for this would be performing non-invasive positive pressure ventilation. Now remember, during this COVID times, our first or the foremost method of treatment for managing hypoxemia was non-invasive pressure ventilation in most of the patients. And when NIV failed, we used to intubate them. Now, non-invasive pressure ventilation increases the mean airway pressure, helps in airway recruitment, and therefore decreases the shunt fraction and improves oxygenation. So that is how NIV will help us to reduce the shunt fraction, not completely, but to some extent. But at the same time, if you initiate NIV, we must make sure that the person or the clinician is bedside. But at times, the patients may not tolerate NIV, and you have to intervene in an emergency situation. There were patients where NIV was inadequate because the patients were delirious. They were not keeping the mask. They were moving in and out of the bed, and they need to be controlled. We cannot physically restrain these patients. So in such patients, what we can do is take some sort of a pharmacological assistance in the form of ketamine, and this process or phenomena is termed as delayed sequence intubation. So with ketamine, you allow the patient to tolerate the mask and NIV for some time, improve the oxygenation before we attempt intubation in such patients. The second category is hypotension. Now, at the mid-inspiratory level, you will find that the diaphragm has gone down and it creates a negative intrapleural pressure to expand the alveoli at the basis. The alveolar pressure is also negative. But at the peak of inspiration, that is when you reach the peak of inspiration, the alveolar pressure comes to near atmospheric pressures. So there is no airflow from the alveoli from the mouth to the alveoli because there is no pressure gradient now. But at this time, the intrapleural pressure is maximum. So this intrapleural pressure helps to expand the lungs in the best possible manner, which IPPV cannot do. So the venous return to the heart is determined by mean systolic pressure minus the right atrial pressure. That determines the venous return. Therefore, the venous return is likely to be increased with spontaneous ventilation and it is likely to fall with positive pressure ventilation. So when you initiate positive pressure ventilation, some of the patients would develop hypotension. So if there is hypotension after intubation, what are the predictors? Like I told you, if the patient is already having hypotension before a planned intubation, this is likely to be exaggerated. If the shock index is more than 0.8, the causes of hypotension after positive pressure ventilation can be that the patient is volume depleted, there is existing capillary leak, and there is loss of systemic vascular resistance when you give some sort of a sedation or an induction agent to the patient. So what should be the treatment? The treatment is to treat the cause. If the patient is fluid responsive, then give fluid resuscitation. But if the patient is not fluid responsive, you will need to start with a vasopressor, and the vasopressor of choice would be norepinephrine infusion. So we start this before we plan or embark on intubation. If there is an impending cardiac arrest with bradycardia, then you will have to give boluses of epinephrine before you start the process of intubation. If the patient is without shock, that is hypotension occurs after intubation, then phenylephrine doses of 50 micrograms can be given because it is probably the loss of SVR which has caused the hypotension after intubation. The third cause can be metabolic acidosis. So the take-home message is, before we embark on intubation, make sure you do a blood gas analysis. Because if the patient has severe metabolic alkalosis, he would definitely have some sort of respiratory alkalosis because he's breathing at a very high minute ventilation. So if you look at the patient, he will be breathing at a very high rate. The rate and depth of the ventilation will be high, and you will be able to make out that he's trying to compensate for existing metabolic acidosis. And even a short period of apnea in such patients can cause precipitous fall in pH. So the pre-intubation plan should be, give a short trial of NIV, try to maintain spontaneous ventilation, use sedation, try not to paralyze these patients. You can spray the glottis and the larynx and attempt intubation. Or if it is totally mandatory, use short-acting muscle relaxants. But be careful, you have to be prepared for an impending cardiac arrest. The fourth cause can be right ventricular failure. What are the causes of RVF? They can be because of right-sided failure predominantly, which is pulmonary artery hypertension, right ventricular or tricuspid pathology, and diseases of pericardium. There are different types of pulmonary artery hypertension, but the one which we need to look at is the one which is caused by the left heart disease. Therefore, Pulmonary artery hypertension is broadly classified into two categories. It can be pre-capillary, that is before the blood enters the lungs, and that is because of right ventricular problems. But if it is post-capillary, then it is likely to be because of left heart disease. So in left heart disease, the PCWP is going to be high, but in right ventricular failure, the PCWP is likely to be low or normal. How do we make sure, or how do we determine whether there is RV diastolic dysfunction? We need to perform a 2D transthoracic echo, and the simplest way is to look at the right ventricular dimensions. Normally, RV is smaller than the LV. And if you look at the ratio of right ventricular end diastolic area to the left ventricular end diastolic area, normally it is 0.3 to 0.6. But if it is more than 0.1, then the RV is severely dilated. So this is a picture. This is the normal dimensions and size of LV and RV. This is a apical 4-chamber view. And if you see an LV and RV enlargement, you will find that RV is almost the same size as an LV. So we will have to trace out the markings of the RV and the LV. It will give you the area, take the ratio, and if it is more than 0.6, then there is RV dilatation. What are the other ways apart from looking at the RV size? The most commonest one which is used is called TAPSE, or tricuspid annular plane systolic excursion. This is a common terminology is used for determining RV systolic function. How do we do the TAPSE? Now, TAPSE means annular plane systolic excursion. That means the annulus here of the RV would go up and down with the contractions. And the excursion of this annulus, the amount of motion which is occurring at this annulus, determines the RV contractility. So you will have to have a 4-chamber apical view, and then this cursor, if you look at this dotted line, is placed at the tricuspid annulus. So just at the annulus part, we have placed the cursor. So this is the way the RV is contracting. Remember, the RV contracts up and down, and we have placed the cursor at the annulus. Then we switched over to the M mode. In the M mode, you will find that you get a undulating waveform, which is the graph which I am showing you below. All you need to look at, you need to determine the peak and you need to determine the baseline. The distance between the two is what determines how much excursions or how well the RV is contracting. If it is more than 0.15, the RV contractions are good and it is normal. But if the excursions are decreased, that means the RV contractility is compromised, and it can be mild to moderate if the TAPSE is 1 to 1.5, and if it is less than 1, then there is severe RV dysfunction. So it is a very simpler way of determining whether the RV in a patient is dysfunctional or in failure. Another part of it is to determine whether the patient has pulmonary artery hypertension. If the patient has pulmonary artery hypertension, there will always be some sort of a TR or tricuspid regurgitation. So you take a color Doppler, again a 4-chamber apical view, and here if you see the blue jet which we are getting, this is the TR. So this is a tricuspid regurgitant flow which we can make out in the color Doppler, and all you need to do is place the pulse Doppler window or the cursor at the regurgitant flow at the part of the aperture of the tricuspid valve. You will get a waveform like this, which is depicted here. From the baseline, just determine to the peak. And this is the RV systolic pressure amounting to 33.1 millimeters. This corresponds directly to the pulmonary artery pressures. Therefore, in this patient, you can say that the patient has moderate pulmonary artery hypertension, right? So that is how you can actually determine the RV systolic pressure, which directly correlate to the pulmonary artery pressures by using a pulse wave Doppler, and also look at the RV function by determining the TAPS. So the action plan is first to differentiate whether you have only RV dysfunction or the patient is having RV failure. Because if it is RV dysfunction, you can still give some sort of a cautious fluid resuscitation. But in RV failure, you can't. Continuously supply oxygen. The mainstay of treatment is inhaled nitrous oxide through a nasal cannula. If it is RV dysfunction with hypoxemia, inhaled nitrous oxide of less than 30 parts per million is satisfactory. But if it is without hypoxemia, you'll have to give about 30 to 80 parts per million of inhaled nitric oxide. Unfortunately, this form of therapy is still not available in India. What should be the induction agent of choice? Etomidate and fentanyl. And please have norepinephrine infusions ready to treat any sort of hypertension. So to summarize, the physiological abnormalities should be looked into before we plan intubation in high-risk patients. If it is a hypoxemic failure, the mainstay would be NIV with continuous oxygenation. In delirious patient, consider delayed sequence intubation. If the patient has hypotension or the shock index is more than 0.8, consider fluid resuscitation in patients who are fluid responsive, and otherwise norepinephrine infusion in patients who are non-fluid responsive. If the patient has severe metabolic acidosis, you can just look at the patient. If the patient is breathing at a very high rate and the depth is also quite adequate, then you need to preserve spontaneous ventilation. Try to distinguish between RV failure and RV dysfunction. The mainstay would be inhaled nitrous oxide.
Thank you so much, sir. That was a very fruitful lecture, especially for all the PG students, and you have very well explained, sir, and all the slides were very good. Now, since we are running a little late, let's move on to our second speaker, Dr. Tushar M. Chokshi, sir. Just a few minutes. Can we wait for a few minutes? Dr. Tushar M. Chokshi. He is a national origami teacher, and his current position is a consultant private practicing anesthesiologist in Vadodara, Gujarat, India, and affiliations Sterling Hospital, Eurocare Hospital, Dhavni ENT Hospital, and Baroda Hospital. And he is having areas of expertise in TIVA, OFA, NORA, Euro anesthesia, labor anesthesia, ENT anesthesia, and pediatric anesthesia, and 30 years of experience he's having. And he's the founder of TIVA and OFA, Facebook groups in India, national and state level speaker, started smartphone and tele-anesthesia practice in India, and started infographics in anesthesia. So we are so lucky to have you today here, sir, and thank you for giving us your precious time, sir. Now I'm going to start your pre-recorded session, sir. काम पे भूल गई।
Good morning to all, and I am very thankful to organizer for allowing me to give this lecture. Today's my lecture is opioid-free anesthesia, or I am doing opioid-free total intravenous anesthesia. I call it is a future modern anesthesia. So my disclaimer is I have no financial relationship with any commercial interest related to the content of this presentation. I will discuss many medications with my experience and recent developments in OFA. OFA is one of the technique for providing anesthesia, and OFA is a scientifically based and systemic treatment to the surgical patients in perioperative period. This is my disclaimer. So what is my lecture outline? Introduction, history, definition, why and how OFA started, opioid epidemics in medicine, opioid risk, use, abuse, side effects and complication, opioid epidemics in anesthesia, OFA goals, OFA benefits, methods of OFA, opioid-free anesthesia, indications and contraindications, multimodal and intravenous drugs for OFA and their infographics, standard OFA induction and maintenance, how we are giving OFA, my experience and technique of OFA and Optiva with economics, conclusion, your take-home message, my verdict on this lecture, cartoons, thanks, and join Indian Society of Opioid-Free Anesthesia on Facebook. So let's start with my lecture. On introduction, the practice of anesthesia requires a full spectrum of the drugs we learned in our anesthesia residency program, and from which an anesthetic plan can be implemented to achieve the desired level of surgical anesthesia, analgesia, amnesia, and muscle relaxations. And opioid is one of them drug from giving anesthesia. And the epidemic of opioid abuse is increasing, and the number of deaths secondary to opioid overdose is also increasing. So for patient safety, anesthetists have started developing protocols centered to minimizing or even avoiding opioids for their patients altogether in their practice. So opioid-free anesthesia is a technique where no intraoperative, systemic, neuraxial or intracavitary opioid is administered during the anesthetic period. And the new normal came. OFA became possible because of the alternative to opioid anesthesia. Other drugs are available, providing benefits to selective group of patients. It facilitates the post-operative analgesia and no opioids without opioids. And major thing is it enhances the recovery after surgery without post-operative nausea and vomiting. You know how the history started in opioid. Opioids are since millennium. Up till 50, it was not reported. But from 50 to 1960, history of synthetic opioids started, and Belgium was the first country to use fentanyl in 1962. And from 2002 to 2020, in last 20th century, many studies have questioned this practice, highlighting the many unknown side effects of the opioid. So opioid-free anesthesia were developed in parallel with the better understanding of perioperative pain and has emerged as a new technique and branch of anesthesia. So OFA is not far away. It is just last 20 years it was developed. By definition, OFA is a technique in anesthesia portfolio with the simple cocktail of the drug without opioid. In other words, it is multimodal anesthesia and analgesia without opioid in perioperative period, not pre, post or intraoperative, but throughout the patient's admission. Why and how OFA developed? Because of the slowly progressing opioid epidemics in medicine and anesthesia. Opioid epidemic started, and people started thinking the opioid-free medical practice or opioid-free anesthesia practice. How opioid epidemic came in the medicine? Because destructive consequences of the opioid epidemic were included the opioid misuse, related overdose, and rising incidence of the opioid use and misuse during the pregnancy also, during labor pain. Opioid overdose accounted every year more than 1 lakh deaths, and estimated 40% of the opioid overdose deaths involved in the prescription period. And healthcare providers begin to prescribe opioid at a greater rates. You won't believe that even one surgical patients are given more than 50 fentanyl or 50 morphines during her stay for 10 days. So since 2000, increase in opioid use, misuse and overdose started, an opioid crisis or opioid epidemic began in the USA, spread to Europe, and then extended into Asia. even in our country also. So increased prescription of the opioid medication led to widespread misuse of both prescription and non-prescription opioid in medicine. So because of this opioid epidemic, opioid overdose deaths increased, and you won't believe that every day 128 people are dying because of the opioid overdose. These are the only US data. So consider the whole world. And more than 50,000 deaths are occurring in USA only because of the opioid epidemics. So there are three waves in the opioid overdose. First wave came in the 1990s, second came in 2010, and third came in the 2030. In 1990, it began with the increased prescription of the opioids with overdose death. They involve the prescription opioid, semi-synthetic or synthetic or natural. This increasing since last 1990. You see all this fentanyl, then remifentanil, sufentanil, alfentanil, all became available after 2000 millennium. So 2010, the second wave came, begin with the rapid increase in the opioid overdose involving heroin. And in 2013, begin with the significant increase in the overdose death involving synthetic opioid, particularly involving fentanyl. And these are the list of the morphine derivatives that are called opiates or narcotics. And what are the opioid risk benefits? Because how opioid gives these complications? They cause respiratory depressions, need for post-op ventilation with ventilator-associated pneumonia. It causes addiction. Most important complication is nausea and vomiting, gastrointestinal dysfunction, most particularly ileus, pruritus, urinary retentions, opioid and cancer. Dozens of publications are available concerning opioid use in anesthesia causes cancer growth, recurrence, and metastasis. So in onco surgery also, I want to tell you that avoid the opioids. And one of the major factors is opioid-induced hyperalgesia, most common even in single dose. I will come with the hyperalgesia means. What is the hyperalgesia? Hyperalgesia means abnormally heightened sensitivity to pain. Once you are given the opioids, then you have to give the opioids. And if you withdraw the taking opioids from the patient's routine treatment, then patient started highlighting the more pain without opioids. So we have to give again opioids, or we have to give other drugs for pain eliciting. So misuse, abuse, and overuse started. And these are the from textbooks. These are the main complications. So what is opioid-induced hyperalgesia? It is a state of nociceptive sensitization caused by the exposure to opioids. Patient becomes more sensitive to certain painful stimuli. Patient have a prolonged period of hypersensitivity to pain. It occurs even after single dose of opioid. And ketamine reduces opioid-induced hyperalgesia. Here I want to tell you my own story. 1 month back, I went for the spine surgery of L1, L2 because of the acute disc prolapse. And after operations, I was prescribed the Contramol, means this is the Tramadol 50 milligram thrice a day in a TDS. And I had taken that tablet for 7 days. And when I went for the stitch removal, means I have taken 10 days. Then when I went for stitch removal, then surgeon told me, my spine surgeon told me, just now stop the Contramol taking. And on the second day, I started an excruciating pain in my body because of thigh pain, back pain again. So I was nervous. At that time, I told my surgeon, then I'm getting pain. So he told me, you start again this tramadol. But instead of that, I started my mocha ice cube, means ketamine ice cubes I started. And you won't believe that 2 ice cubes I have taken on empty stomach. And literally, I got 100% pain relief within 2 hours. So that is a ketamine reduces the opioid-induced hyperalgesia. I will come to mocha ice cube later on in my slide. So, but some opioid benefits also are there. It is not like that opioids are totally gone drug. First, why we are using it? It gives the hemodynamic stability. It gives the analgesia and little sedation. But anesthesiologists are also responsible for the overdose. First, in pre-operative period, exposure to opioid, we are prone to give 1 or 2 doses of the opioid in our OT. And acute tolerance and hyperalgesia increase the opioid requirement even post-operative period. So we prescribe in post-operative period also 2 opioids to our patients, surgical patients. So we are responsible post-operative also. Even post-operative, when patients are discharged at home, there were no control of the opioid taking by the patients, and patient takes himself this. Spinal causes the abuse and sometimes death. An opioid epidemic in anesthesia gives because of the three features in anesthesia. That is, opioid analgesic overdose can have life-threatening toxic effect in multiple organ system. All organs are involved. Normal pharmacokinetic properties are often disrupted during an overdose and can prolong the intoxication dramatically. And the duration of action varies among opioid formulation, and failure to recognize such variation can lead to inappropriate treatment decisions, sometimes with lethal results. We are just giving like somebody is giving fentanyl, it gives good result. Somebody is giving contrama, it gives good results. So we are following that criteria. That is very bad. Why opioid are or were used in anesthesia? Because opioids are primarily used initially because of their safe intraoperative profile. That is minimal cardiac depression, blunting of pain transmission to provide post-operative pain control. But side effects are more and lethal with opioids, and uses are for pain. So alternatives are available. So why to opioid avoid? Because it has got a negative side effect like respiratory depression, nausea, vomiting, pruritus, urinary retention. It suppresses the immune response. It causes cognitive or sleep dysfunction. It increases the addictions and chronic pain. It increases chronic pain when the opioid is administered or withdrawn. Now change the habit. We are not telling to give opioids in your practice, no compulsion. Now we know the problems with opioids. We know there are alternatives and effective modalities are available. So you don't have to be perfect to be amazing. Start opioid-free anesthesia practice in your patient. Common misconceptions are using OFA. Sometimes people are asking me personally that they need multiple infusion. No, there is no requirement. Patient will be in pain, not at all. If you are not using opioids, then patients are given some another medication which will decrease the pain. Expensive multimodal anesthesia without opioid is never expensive. So why should we administer opioids? Why should we administer opioid? Safe alternatives are available. So start OFA practice. $1,000,000 question is, what are the alternative to opioid? Replacing opioid with other analgesic will not only reduce the development of opioid addiction, but also lead to better perioperative outcomes and enhance patients' recovery after surgery. So that is why I recommend to start opioid-free practice. Just start in your 10% practice of the opioid-free anesthesia practice from your full practice. And new paradigm came in the market, that is opioid-free analgesia and anesthesia. So first concept came of OFA in 1990, and the main goal of the OFA in 9 words only. And this Barry Fredberg from USA, who was invented ketofol in 26 March 1990, he is grandfather of OFA. He has done 26 years only this OFA practice. So what are their 9 goals? Measure the brain through BIS, preempt the pain through ketamine, and emetic drug abstinence, not using opioids. No much anesthesia, no less anesthesia, only brain fog. BIS value should be around 50 to 60. So main aim in OFA is to anesthetize brain should not come to know about the pain during skin incision. What else you require? And we have learned that components of anesthesia in our residency, that amnesia, analgesia, sleep and muscle relaxation. And this OFA gives a complete anesthesia circle, that is hypnosis, sympatholysis, amnesia, hemodynamic stability, homeomobility, and neuromuscular blockade. Every drugs are given without OFA, they give total anesthesia circle. So OFA benefits: stable hemodynamics intraoperatively, no respiratory depression, no addiction except for ketamine, less need for post-op ventilation, no nausea and vomiting, no gastrointestinal dysfunction and ileus, no pruritus, no urinary retention, and it prevents the chronic pain also. And European Society of Perioperative Care of the Patients, they also mention advantage of OFA: less PONV, earlier recovery, less sedation, less opioid post-op. Patient like it, surgeon like it, less pain, nurses like it. So what else you require? Anesthetists also should like it. There are 17 benefits of OFA written in the textbook. These are that. Mechanism of OFA drugs are either through the NMDA receptors, either through the GABA receptors, or PG, prostaglandin inhibitors. These are the 3 main mechanisms where the OFA drugs are working. How it works? Method of opioid-free anesthesia. One is management of central sensitization, management of peripheral sensitization, prevention of opioid-induced hyperalgesia, and weight-based dosing of the OFA drugs. Particularly, ideal body weight. So what is management of central sensitization? Which drugs are using? Propofol, etomidate, substance P inhibition, either through clonidine or dexmedetomidine. They are adrenoreceptor agonist, either with the glutamate antagonist like ketamine and N2O that are NMDA antagonists. And most particularly, we are using now magnesium sulfate, NMDA antagonist, or gabapentinoids, that is pregabalin and gabapentin. What are peripheral sensitization? Either with the local anesthetics like peripheral nerve blocks, lidocaine infusion, we give dexamethasone, and NSAIDs like diclofenac sodium and paracetamol. So OFA indication with its advantage. What are the indications? Narcotic abuse history, acute and chronic opioid addictions, opioid intolerance, morbidly obese patients with obstructive sleep apnea, hyperalgesia, history of chronic pain, immune deficiency, oncology surgery, and inflammatory. Most of the surgeries we can do under opioid-free anesthesia. And their advantages are less analgesic requirement postoperatively, enhanced recovery, decreased postoperative nausea and vomiting, decreased postoperative pulmonary morbidity, decreased histamine release, and patients satisfied. Patients are always satisfied. Some OFA contraindications. Coin has two sides. Absolute, only one if there is an allergy to any adjuvant drugs, and relatives are disorders of autonomic failure, cerebrovascular disease, critical coronary stenosis or acute coronary ischemia, heart block, extreme bradycardia, non-stabilized hypovolemic shock, acute bleeding with significant blood loss. You should avoid giving OFA. Elderly patients and ASA4 patients, very reasonable by giving OFA. So new paradigm came. Older way, opioid way is the main drug to give anesthesia practice. Now new way is that either you avoid opioids, or don't give opioids. So that is the way. Now these are the multimodal drugs OFA with their advantages. Majority. So which are the drugs we are using in OFA practice? Majority of drugs are used for OFA, including benzodiazepine, propofol, ketamine, etomidate, dexmedetomidine, muscle relaxants, and other adjuvants are easily available in almost all OT and outside OT. And all these drugs can be given to any subset of the population from geriatric to pediatric in any surgical procedure without opioids. And in last 175 years, these are the 68 drugs are invented in our anesthesia armamentarium. And out of these, 55 drugs are in still use. And if we remove these 7 opioids, then we have still 48 drugs to use in our OFA practice. And these are the OFA drugs toolbox: propofol, ketamine, dexmedetomidine, beta blockers, all muscle relaxant, magnesium sulfate, dexamethasone, lidocaine, clonidine, diclofenac, paracetamol, which I have told earlier. So we will go very little for the individual drugs. Dexamethasone, I called it is a universal weapon for the anesthesiologist. Why? Because it gives antiemetic, anti-nauseatic effect, anti-inflammatory, analgesic, anti-severing, increase the quality of recovery, and no effect on sepsis and sugar in single dose. So these are the infographics of the my drugs. MgSO4, I called it is a intravenous oxygen for anesthesiology. Believe me, I am giving this magnesium sulfate each and every patient of my short GA or long GA, or even in spinal anesthesia, because it has got a 32 effects in anesthesia practice. But majors are antihypertensive, bronchodilator, antiarrhythmic, analgesic, anti-seizures, anti-severing, anesthetic adjuvant, antacids, and mild sedatives. I will request you to give magnesium sulfate each and every patient without any fear. This is the MgSO4, this infographics, versatile drug for the anesthetics. My third drug is lidocaine. It is best companion for the anesthesiologist. Why? It is analgesic, anti-hyperalgesic, anti-inflammatory, reduce the opioid analgesic consumption, anti-arrhythmics. It improves the patient's outcome and decrease the aerosol and droplet during extubation. I always combine my reversal agent with this lidocaine. Now, best drug available for the OFA practice is the ketamine. It is my first weapon in OFA practice. I call it as a Brahmastra. Why? Because most popular drug for the anesthesiologists across the globe since last 50 years. It is NMDA antagonist, key role and main drug in OFA. Without this drug, OFA is incomplete. Best analgesic, amnesic, opioid sparing effect. Dose less than 0.5 milligram per kilogram reduces the postoperative analgesic needs, and especially seen in the opioid tolerant patient. It has got an anti-hyperalgesic and anti-tolerance effect. This is ketamine infographics. Another drug is propofol. Propofol is a switch on switch off anesthesia, and it has changed the practice in last 30 years from the anesthesia armamentarium. And each and every case, each and every institute, each and every anesthetist have used this propofol. Fourth drug is dexmedetomidine. Dexmedetomidine is a newly came drug since last 10 years. It is an alpha-2 agonist. Dexmedetomidine has hypnotic, sedative, and analgesic properties, and estimated to 7 to 10 times more potent than clonidine. I call it as a most ideal anesthetic agent, IV agent. Most ideal anesthetic agent. Has got opioid sparing effect. Ketodex or Dexket combination is becoming very popular in pediatric opioid-free anesthesia practice. Nowadays, before this dexmedetomidine, we were giving ketofol. Now we are giving Ketodex. Patients are sedated but arousable, alert, and response without uncomfortable, because patients feel that they are under physiological sedation. Conscious sedation is like natural sleep. This drug is becoming widely popular in all parts of the world, in all anesthesia practice. Those who are not using dexmedetomidine, I personally request use this molecule. It is a very good agent. These are the dexmedetomidine infographics. And those who are not using, I have prepared one dexmedetomidine prayer. Hey buddies, I am dexmedetomidine. My pet name is Dex. I am your complete friend to play with you in all games like IV, IM, oral, spinal, and nasal. Now people came with the sublingual dexmedetomidine. But my favorite game is intravenous with all stages like sedation, hypnosis, analgesia, anesthesia. I love to play with small babies to old age players, but during playing with me, be careful. I am very delicate and fall down with the weak players. I can also play in the indoor stadium like ICU patient continuously for 48 hours. I am always available to play with you and allowed me to play with others. Let us play and enjoy with me. Don't neglect me, though I am a new player. Clonidine is like a dexmedetomidine. Now I'm not using clonidine in my practice. Other drugs in OFA practice is paracetamol and diclofenac sodium. Paracetamol is a very good molecule. It goes a preemptive analgesic. It has got an opioid sparing effect. Loading dose is 30 to 50 milligram per kilogram. Maximum is not up to even not exceeding 2 gram. Means give up to 2 gram. Very innocent drug in OFA and can be repeated at every 6-12 hours in the dose of 1000 milligram. Excellent adjuvant in pediatric OFA. Diclofenac sodium. Diclofenac sodium is a powerful NSAIDs in OFA with analgesia and anti-inflammatory action. Now this aqueous solution available, so we are now very much benefited with the IV treatment with the diclofenac. Base is given in a single dose of 1.5 milligram per kilogram IV slowly, and maximum is 150 milligram. Caution with renal, hepatic, pulmonary, and heart failure patient. Here I want to tell you one thumb rule. Always give both drugs before surgical incision to inhibit the prostaglandin receptors. So before you start your anesthesia practice, before you start your anesthesia induction or surgical incision, you give this. If surgical incisions are there and then you give these molecules, then there is no effect on these PG receptors. My favorite drug is esmolol. It gives a opioid sparing effect. It gives a central analgesia, and I called it as an emergency front the anesthesiologist. Why? Because it is highly beta-1 selective and appears to be safe in patients with pulmonary disease. It can be given in pediatric OFA also, and using esmolol during anesthesia maintenance significantly decrease the analgesic anesthetic requirement. This is esmolol infographics. So I was telling you about my Mocha ice cube. In my pediatric OFA practice, I developed this Mocha ice cube 10 years back. Now it is very much beneficial in this practice. It's a novel combination of 4 drugs, that is midazolam, ondansetron, ketamine, and atropine. I combine all these drugs and put all this solution into deep freezer to form ice, and I give 1 hour before oral I give before induction, means 1 hour before the anesthesia to all my pediatric patients. And after 1 hour, when I go to see these patients, then they are calm, cool, quiet, sleepy. There is no crying, rowdiness, injection fear, or anxiety in both parents as well as in patients. That is, they will allow to give you IV line administration. So in short, OFA is beneficial by without using OFA drugs, means opiate drugs. So OFA gives fast recovery and fast track in enhanced recovery with good safety profile like early recovery, excellent cost efficient like decreased hospital stay, user friendly, easily accepted by all patients, better outcome, early ambulations, and early oral rehydration with minimal parenteral fluids. If you are not using opiates, then there is no need to give an antiemetics. So I called it is a minimal invasive anesthesia. But some OFA risk with these drugs, bradycardia with dexmedetomidine, hepatic damage with paracetamol, bleeding, hallucination, tachycardia, addiction with ketamine, tinnitus, seizure, and cardiac arrest with lidocaine, sometimes sedation, over sedation with dex, hypertension with magnesium. Once you start with your OFA practice, then you will come to know how to use these drugs. What methods do you use to reduce? The OFA society, means European Society has given a fantastic article. They think that they came with the additives combined with regional, combined with local infiltration, monitor, increase the propofol or inhalation. Like that, there are some methods of giving this type of the OFA practice. And which additive they were using in OFA? NSAIDs, paracetamol, clonidine, ketamine, lidocaine, magnesium, dexamethasone, dexmedetomidine, gabapentins. We all have discussed. So I have developed one standard OFA inductions. 10 minutes before induction, you give sympathetic block. Either you give propofol or dexmedetomidine. 1 minute prior to induction, you give hypnotic or rapid stress block, or you give lidocaine. And for induction, again you give propofol. For rapid period reduction, you give magnesium sulfate. And for pain relief, anti-inflammatory agent like dexamethasone, diclofenac sodium, paracetamol. And on maintenance, sometimes you give NMDA antagonist or like ketamine or propofol. So anticholinergic, antiemetic, and antacids are as per choice of the anesthetist, and neuromuscular blocking does if needed for the surgery. If you are intubating that patient, then muscle relaxants, you can use it. And maintenance, sympathetic block, dexmedetomidine or clonidine. For local anesthetic, lidocaine, magnesium sulfate, inhalation agent, propofol infusion, NMDA block with ketamine. You can give IV paracetamol. And for post-operative analgesia, you can give lidocaine, ketamine. You can give nerve blocks or local infiltration. I will tell you about my Optiva, means opiate-free TIVA practice. My base pre-medication in this COVID pandemic to our aerosol and droplets before IMPA induction is dexamethasone, magnesium sulfate, and lidocaine. I call it as a DML mixtures, and I combine in 10 ml syringe. I give very slowly, at least for 5 minutes. Then I give intravenous diclofenac sodium 1 milligram. I put this diclofenac sodium in the paracetamol 1 gram infusion, and I give always before surgical incision. And one of my another invention is KPD-TIVA. I give it for the induction as well as maintenance. Means ketamine, propofol, and dexmedetomidine combination. That is a 1 milligram, and 1 microgram per dose. And combination of all these drugs permits lower dose of the each individual agent. And they are giving excellent analgesia and anesthesia. Decrease the dose of individual, stable hemodynamics, decrease airway complication, rapid recovery. For maintenance, either I give dexmedetomidine 0.7 to 1 microgram or propofol 6 to 8 milligram per kilogram per hour. And I stop this infusion drip 15 minutes before at the end of surgery. And for post-operative pain relief, I am not giving any opioid post-operative. First, I give local infiltration or respective no blocks. I have developed one catechane drips, that is a ketamine and lidocaine drip for 12 to 24 hours and depends upon surgery. Usually I give ketamine 0.1 to 0.2 milligram per kilogram hour plus lidocaine 1 milligram per kilogram hour with monitoring in syringe infusion pump or in the pint. I give paracetamol 1 gram every 12 hours and diclofenac sodium 1 milligram per kilogram every 12 hours IV. So if you tell my patients post-operative up till 42 hours and then there is a no pain, means is almost 0 or less than 10%. So pulse of my OFA practice, I am doing since last year only exclusive OFA practice. In my 90% practice, I use KPD mixtures. I am a maximum users of Dex and ketamine in my area. More than 1,000 cases done in last 2 years. I use nitrous oxide and volatile agents only in my 10% of practice, and I give opioid-free anesthesia to all my patients. For intra-op maintenance, I use dex infusion, propofol infusion, depends upon surgery, surgical time, and vital parameters. So my economics of drugs in OFA, for 2-hour surgery with intubations or with LMA or supraglottic airway, only 1,500 rupees for. I'm not using volatile agent. So practically surgical procedure done under OFA is from OT to outside OT under NORA situations, from pediatric to geriatric, and from any surgical to medical specialty. So practically all the procedures, all the surgeries done under OFA practice can be done under OFA practice. But some people are not using the OFA practice because of insufficient guidance, no training, outcome not improved, limited data, just started newly. They consider it is expensive and they are not aware of the OFA practice. So my tips for starting OFA is do not administer opioids, and if you want to start OFA practice, so at least you avoid giving OFA in 90% patients, you start in 10% patients, or opioid sparing anesthesia you start. Communicate in doubt. You ask your colleagues if they are doing OFA practice. Educate yourself by learning some mechanism, these procedures, and keep update with latest. There are now 200 articles on the net about OFA practice since last 5 years. So my conclusion, do we really need opioid in anesthesia? My answer is no. Opioid crisis, epidemic become a known reality since 1990. So the concept of OFA reduced and eventually opioid-free anesthesia will has started. Opioid-free anesthesia is the future of anesthesia. Believe me, in 2030, opioid-free anesthesia will be the king in this anesthesia technique. It is slowly but surely being considered the best way to give GA. There are very few contraindications for opioid-free anesthesia. Multimodal anesthesia with no bed is becoming popular and new normal method in OFA and Optiva. Replacing opioid with other analgesics will not only reduce the development of opioid addiction, but it also lead to better perioperative outcome and enhance patient recovery. My take-home message: opioids can be replaced by multi-drugs. Post-operative pain management without opioids are viable. Ketamine is the main drug. No bolus of propofol more than 2 mg per kilogram in OFA. You don't have to be worried. If your OFA is perfect, then better outcome without pain and PONV. To reduce intra blood pressure, use esmolol in your OFA practice. And all this dexamethasone, MgSO4, and lidocaine are main friends of in OFA. So my verdict is, by reducing opioid-related adverse effect, OFA aims to enhance optimal perioperative analgesia through reducing pain scores and enabling earlier mobilization with enhanced rehabilitations, faster discharge, and improved patient satisfaction. So OFA will be a game changer in high-risk patients, especially in geriatrics and COPD and obese patients. So let's begin opioid sparing or opioid-free anesthesia with technique of multimodal anesthesia and analgesia. You tell your patients about this, I'm not using OFA in your practice. So nocebo to placebo. You tell them positively. So start opioid anesthesia. It is an insanity doing the same things over and over again and expecting different results. Albert Einstein told this. In this era, patient wants opioid-free anesthesia. If not, then start opioid-sparing anesthesia. Start talking with OFA. So 1846, surgeon John. So my appeal to all this in 2021, my friends, OFA is not humbug. Which steps you have, friend? You reach today, my friends. I won't use OFA to I will use OFA. Join Facebook group of the Indian Society of Opioid-Free Anesthesia. Thank you.
Thank you so much, sir. It was a very wonderful lecture, very informative, and all the slides were very good. And I'm sure we learn a lot from your lecture, sir. Thank you, sir. Tushar, sir. Now, since we are running very late, I would like that the question and answer session can be discussed in the chat box with the speaker personally, so that we can move on to our next section. Okay. So next session, will be of the chairpersons are Dr. Shikha Mehrotra ma'am and Dr. Nilima Tandon ma'am. And our first speaker is Dr. J. Divatia sir. Dr. Shikha Mehrotra ma'am, I'm very honored to introduce her as she is my guide and she is my mentor and teacher, and I have completed my post graduation under her guidance. She is professor and head of department, Gandhi Medical College, Bhopal, and she has many achievements like past honorary secretary ISA City Branch Bhopal from 2005 to 2008, honorary secretary ISA MP chapter from 2005 to 2011, honorary secretary of ISA West Zone from 2007 to 2009, delivered guest lectures at various national, zonal, and state level conferences, coordinator ISAS MP State, president ISA Central Zone from 12 to 13, president ISA MP State Chapter from 2011 to 12, and she has various fields of interest like pain management, pediatric anesthesia, obstetric anesthesia, and regional anesthesia. And she is having two publications, two in international journals and five in national journals. Thank you so much, ma'am. We are honored to have you here and to share screen with you, ma'am. Our next chairperson is Dr. Nilima Tandon, ma'am. Dr. Nilima Tandon is a professor and head of Department of Anesthesiology, SSH GRMC Gwalior, ma'am. We are very honored to have you with us today. And the speaker for today is Dr. J. Divatia, sir. And the topic is waveforms in ventilators. Dr. J. Divatia, sir, has done MD, FIS, CCM, and FCCM. He's professor and head Department of Anesthesiology, Critical Care and Pain in Tata Memorial Hospital, Mumbai. Past president of Indian Society of Critical Care Medicine, past editor-in-chief, Indian Journal of Anesthesia, and over 158 publications in national and international journals, and presentations in several international, national, and state conferences. Thank you so much, sir. And we are playing your pre-recorded lecture now. And ma'am, the question answer sessions will be held at the after the two speakers. Thank you.
Thank you very much for inviting me to speak at this meeting. I will be speaking on ventilator waveforms. Now, the ventilator waveform is an extremely important tool, and it's almost like the ECG of a patient on a ventilator. And it helps you do a lot of things and get lots of information about respiratory mechanics, about complications that are happening in the patient, the ventilator settings, what the ventilator is doing, and so on. And therefore, although it looks very intimidating to have these waveforms and graphs flashing across the screen in a sick patient who's being intubated and ventilated in an ICU, it is extremely important to understand the basics of how the ventilator graphics can be interpreted. So I will be focusing on the essentials or the fundamentals of the graphics. I will not be going into complex details, but most of this talk, or from this talk, we will cover almost 98-99% of all the information that you can gather from ventilator graphics. Now, before we move on to the graphics themselves, please remember that a ventilator, for all the sophistication and all the gadgetry that seems to be involved, it's actually a very basic and simple machine. All ventilators only push air into the patient in inspiration. Okay? So gas is pushed into the patient during inspiration by the ventilator, and the flow of gas is controlled by valves. Right? There's an inspiratory valve which opens. So in inspiration, the inspiratory valve opens, the expiratory valve is closed. And that's when gas goes into the patient. During inspiration, if you close the inspiratory valve, so if you close the inspiratory valve in inspiration, the flow rate comes down to 0 because the inspiratory valve is closed. Expiration has not started because the expiratory valve is also closed. So at this phase, there is no flow going in or out of the patient. And this phase, where the inspiratory valve is closed in inspiration, is called the period of the inspiratory pause or the inspiratory hold. Then the expiratory valve opens, and that allows exhalation to start. So the inspiratory valve is closed, the expiratory valve opens, and gas goes out to the atmospheric pressure, or to the pressure which may be set in expiration, which we call as a positive and expiratory pressure. So essentially, that is all that happens in inspiration and expiration on a patient of ventilator. So please note that the ventilator controls only the inspiratory phase of ventilation. Expiration is a completely passive process. It is not controlled by the ventilator. All that the ventilator does is it opens the valve and allows the gas to exhale. So the expiratory phase is independent of the mode or type of ventilation or ventilator, and all it does is a completely passive process, entirely dependent on the patient's own respiratory mechanics. Okay. Now, there are two types of graphics, right? One is called a waveform, and which plots either flow rate or airway pressure or tidal volume versus time, right? So flow or pressure or tidal volume versus time, these are called waveforms, where these parameters are plotted against time. Time is plotted on the x-axis, the other parameters are plotted on the y-axis. And then you've got loops which plot pressure versus volume or flow rate versus volume. And in this talk, we will focus again largely or almost exclusively on the waveforms, and that too the flow time and the pressure time waveforms. Again, because these are two most important waveforms, and they give you 95 to 99% of the information that you need to know. The pressure time graphic is a classic graphic, and it gives you all this information which is listed on the slide, and we'll go over all these parts one by one. Okay, so like I said, the pressure time curve for this graphic plots the pressure, airway pressure on the y-axis versus time on the x-axis. And by looking at the shape of the pressure volume, pressure time curve, you can identify volume controlled ventilation and pressure controlled ventilation. In volume controlled ventilation, the airway pressure is not constant, it varies throughout the period of inspiration, right? So this is inspiration. And in pressure controlled ventilation, the pressure waveform is rectangular. In other words, a constant pressure ventilation. The airway pressure rises to the set limit, and it continues at that same pressure throughout the inspiratory time before it changes over to expiration, right? So this is the pressure controlled ventilation. This is volume control, where the inspiratory pressure varies throughout inspiration, and in pressure controlled ventilation is held constant throughout the inspiratory time. So this is constant pressure, and this is variable pressure in volume controlled ventilation. Now, if you look at the pressure time graphic during, say, volume controlled ventilation, now in this picture, what you're seeing is this is the gas going towards the patient. This is the inspiratory limb, inspiratory valve, expiratory limb, and the expiratory valve. So when the gas inspiration begins, the inspiratory valve opens and gas rushes into the patient, and it has to overcome the airway resistance as well as the stiffness of the lung. And for that, it needs to exert a pressure which we call as the peak inspiratory pressure. So the peak inspiratory pressure occurs when during inspiration, when the gas overcomes the airway resistance as well as the stiffness of the lung. Now, if you close the inspiratory valve in inspiration, which is a period of the inspiratory pause, now there is zero flow and the pressure falls. The pressure does not come down to zero. The pressure falls. The pressure which is recorded is now the pressure of the inflated lung. Remember, the gas has already gone into the lung when the inspiratory valve was open. And so now the inflated lung exerts a pressure which when we close the inspiratory valve equilibrates with the airway pressure. And this pressure is called the pause pressure or the plateau pressure. So the plateau pressure is the pressure which is seen during the phase of the inspiratory plateau or the inspiratory hold and reflects the pressure of the inflated or the distended lung. And this is an extremely important pressure because this reflects the amount of volume inside the alveoli. And over distension of the alveoli, which determines ventilator-induced lung injury, is determined if the plateau pressure exceeds 30 centimeters of water. So 30 centimeters of water implies alveolar over distension, and so the plateau pressure is an extremely important pressure to keep in mind. And one of the goals of lung protective ventilation is to maintain the plateau pressure less than 30 centimeters of water. Now, The plateau pressure, because the flow rate is 0, because the inspiratory valve is closed, there is no airway resistance involved in the plateau pressure. The only thing that determines the plateau pressure now is is a volume inside the lung, and this is therefore an estimate of the compliance of the lung. So the peak pressure depends on the airway resistance as well as the compliance. The plateau pressure depends only on the compliance of the lung, and the difference between the peak and the plateau pressure therefore reflects the airway resistance. So again, just going over this again, peak pressure is influenced by resistance as well as compliance. Plateau pressure is not affected by airway resistance, it's only affected by compliance. So the difference between the peak inspiratory pressure and the plateau pressure is the measure of the resistance of the airways. Okay, so this is a very important relationship, and we'll come through this again. Then the expiratory valve opens and the flow goes out and cycles, and this is the beginning of expiration. Okay, so this is a very important diagram which explains the concepts of peak and the plateau pressures. Another important information you get is whether it's an assisted breath or a controlled breath. In an assisted breath, the patient first takes a breath and then the ventilator takes over and assists the breath. So you will detect a patient breath which is diagnosed by a small negative pressure deflection, because remember the inspiratory spontaneous ventilation starts with a negative pressure which is created in the airway with inspiration, with spontaneous breathing, and so you get a slight dip in the airway pressure below the baseline, which is a negative pressure, and then the ventilator takes, so that's an assisted breath. So this is the trigger. This is the patient triggered breath, and here there is no negative deflection below the baseline, so this is purely a controlled breath which is given by the ventilator without any trigger by the patient. You can also see the baseline pressure or the expiratory pressure, which we call as a positive end expiratory pressure. Here it's 0, and here the baseline is at 6. So this patient is getting ventilated with a positive end expiratory pressure of 6 centimeters of water. The next important graphic is the flow time graphic, and if you combine the information from the pressure time and the flow time graphic, you really get lots and lots of information about the respiratory mechanics. Now, this is again the second most important slide that I need you to focus on. Right now, this pattern of ventilation is called square wave ventilation or constant flow ventilation. This is a classic pattern which you see in volume controlled ventilation. So when the inspiratory valve opens, gas flows into the patient, it reaches the flow rate limit that has been set to determine the tidal volume, and it remains at that flow rate throughout the inspiratory time, right? And then the ventilator cycles over to expiration. Now here, please notice that on the y-axis, you've got the flow rate, on the x-axis, you've got time. Above the x-axis is inspiration, and below the x-axis is expiration, right? So this is exhalation, and so this is the beginning of exhalation, and exhalation proceeds like this in this exponential smooth pattern. Okay, so please remember, constant flow ventilation is a volume control ventilation is usually associated with a constant inspiratory flow rate. This is called a square wave pattern. Okay, this is volume control ventilation. Pressure controlled ventilation or any pressure limited breath is always has this decelerating flow. So the flow rate increases when the inspiratory valve opens, rises to the set pressure, and then it decelerates throughout the inspiratory time, right? So this is a decelerating waveform. So no matter what your mode is called, no matter what your manual says, if you've got a decelerating flow like this, this is a pressure controlled or a pressure limited breath, right? So please remember, a decelerating flow rate is pressure controlled ventilation. And here you can see the expiration, and remember the expiratory waveform is identical in volume controlled as well as pressure controlled ventilation, because expiration is a passive process not controlled by the ventilator. The inspiratory waveform will change depending on what the ventilator is doing. Okay. So now this is a volume controlled breath, and you can see the different phases of a breath which you talk about in the modes of breathing, the different phases of a breath. So this is the flow rate and this is time. So here this is inspiration, the inspiratory valve opens, flow goes into the patient, reaches the limit, the flow rate which is required to deliver the tidal volume, right? And then it continues throughout that flow rate, at that flow rate throughout the inspiratory time. And then the inspiratory valve closes and the flow rate drops down to 0. This is the period of the inspiratory pause, right? And then the expiratory valve opens over here and gas flows out, and you get this nice initial gush of gas is rapid because the lung was full. So the gas flow rate is extremely fast initially, and then it slows down exponentially to reach the baseline, right? So this is and this pattern of expiration is the same in volume control as well as pressure control ventilation. This is a peak expiratory flow rate, which is over here. Okay. Now, based on the ventilator waveforms, you can sort of identify the mode and pattern of ventilation, identify problems, asynchrony, and fine-tune ventilation. So now, again, a fundamental slide. In volume control ventilation, the flow rate is square wave and the pressure is variable. In pressure control ventilation, the flow, inspiratory flow pattern is always decelerating, and the pressure waveform is a square wave or a constant pressure waveform. And the expiratory waveforms are identical in both volume control and pressure control ventilation. So again, you can find out assisted breath because you got a negative deflection in the airway pressure when the patient breathes, and then you get the ventilator taking over with positive pressure. Controlled ventilation, you will not see this dip over here. So now based on these sort of this knowledge, we can identify modes of ventilation just by looking at the ventilator graphics. So here you can see the flow rate is constant flow. So this is a volume controlled breath, right? So this is a volume controlled breath. You can see that all the breaths in this slide, in this screen, are started by the patient because of this negative deflection in the pressure and then taken over the ventilator. So these are all assist control breaths. Every breath is started by the patient and then taken over or assisted by the ventilator. So this is assist control ventilation. This is volume control, assist control ventilation, right? Or assist control in a volume control. Now here you got, this is again a square wave pattern. So this is volume controlled ventilation. And here again, you've got pressure dips which are going down. So again, this is volume controlled or volume cycled, patient triggered, assist control ventilation. Now this is a very interesting mode. Now here you can see this is a pressure limited breath, right? This is a pressure controlled breath because this is a decelerating flow. This is a spontaneous breath. And this is again a pressure control breath delivered by the machine. So some breaths are delivered by the machine, they are ventilator breaths, and some are spontaneous breaths, which the patient is breathing, which are not assisted by the ventilator. Okay, so this is obviously an intermittent mandatory, some form of intermittent mandatory ventilation because some are ventilator breaths and some are spontaneous breaths which are not assisted by the ventilator. Now you can see that every ventilator breath is triggered by the patient. So this breath is taken by the patient and then it's assisted with the ventilator. This is a patient breath which is not assisted by the ventilator. This is a patient breath which is patient starts the breath and the ventilator takes. So these are synchronized mandatory breaths. So these mandatory breaths are synchronized with the patient effort. So this is, and they are intermittent because all breaths are not supported. So this is synchronized intermittent mandatory ventilation or SIMV. So this is a pressure control SIMV. And you can see the tidal volume is higher with the volume ventilator breaths and low with the spontaneous breaths. So this is pressure controlled SIMV or SIMV with pressure controlled ventilation, right? So you can identify this mode of ventilation as well. Pressure support ventilation, again, a very interesting mode of ventilation. You can see over here that what is happening over here is that this is inspiration, right? The patient start, the flow rate reaches the peak flow and then the flow rate starts decelerating. Now, when the flow rate has decelerated to a certain proportion of the peak inspiratory flow rate, say 25% of the peak inspiratory flow, the ventilator changes over to expiration. So here the cycling or the changeover from inspiration to expiration is not occurring with time or volume or pressure. It is occurring when the flow rate has decelerated to a certain proportion of the peak inspiratory flow. And this is flow cycle ventilation. And this is a hallmark of a pure spontaneous mode like pressure support ventilation. So the pressure support ventilation is flow cycle. And you can see over here, the patient initiates the breath, then the patient is supported to the set pressure support level, and then it changes over to expiration. And it changes over to expiration based on flow cycling. So this is pressure support ventilation, which is patient triggered. It's a pure spontaneous mode, patient triggered, pressure limited, pressure and flow cycle. So this is a very important way of diagnosing or determining that this patient is on pressure support ventilation. This again, now you can see over here that this is a pressure controlled breath. This is a pressure support breath. Can you see this is a pressure? There is a rise in increase in flow rate, and then the cycling changing to expiration when the flow rate has decelerated to a certain proportion of peak inspiratory flow. Every breath is started by the patient, initiated by the patient, and supported and pressure supported. So this is pressure controlled and this is pressure support. So this waveform is of pressure controlled SIMV with pressure support. In the previous SIMV I had shown you, this was without any pressure support, right? But this is, some breaths are supported by the ventilator by pressure control, and some breaths, the patient's spontaneous breaths are also supported now by pressure support ventilation. This is SIMV, pressure support, and all these are pressure controlled SIMV breaths. Okay. Now you can also diagnose important problems. For example, whether the compliance has dropped, say because of pneumothorax or pulmonary edema or a bad pneumonia, or if the airway resistance has increased, say because of bronchospasm. Now, like I said, the airway, when the compliance falls, right, the peak inspiratory pressure as well as the plateau pressure will rise, because the compliance influences both the peak pressure as well as the plateau pressure. So the fall in compliance, both the peak and plateau pressures increase. When the high resistance increases, airway resistance increases, remember the plateau pressure is not influenced by airway resistance, but the peak is. So what will happen is the peak inspiratory pressure will rise, but the plateau pressure will be unchanged, and there'll be a wide gap between the peak pressure and the plateau pressure. So this gap between peak and plateau is determined by the airway resistance, right? So as the airway resistance increases, this gap will increase. As a bronchospasm gets better, this gap will come down. So you can see over here, the other thing that happens is when airway resistance increases, the expiratory airflow resistance increases. And that is manifested by a decreased peak expiratory flow rate and a prolonged time to exhalation. In other words, the same amount of gas takes a longer time to be exhaled because there is an increase in expiratory airflow resistance, right? So this is another way in which you can make out that there is a resistance problem. And you can see over here that this is a normal breath. With bronchospasm, you find this is, and now this is a volume controlled breath. Can you see this? This is a constant flow ventilation. So volume controlled breath, and you can see the PEFR has reduced, the expiratory time has prolonged, and when you give bronchodilator, then the flow rate returns, the expiratory flow rate returns to normal, as well as the emptying of the lung. The other thing that happens when you've got expiratory airflow obstruction is, if the next breath comes in before the expiratory flow has had time to return to baseline. In other words, if the next breath comes in before the lung has emptied completely, you will get trapping of air, right? So this reflects the amount of gas which is trapped in the lung because the expiration is not completed and the next breath has started before this flow has reached the baseline to zero. Okay, and this reflects air trapping in the setting of high airway resistance. Now, this does not mean that there is this. So this suggests that auto PEEP is occurring, intrinsic PEEP is occurring, and this is a pressure exerted by the air which is trapped inside the lung at the end of expiration. You can't see it normally unless you close the expiratory valve in expiration. In other words, you perform an expiratory hold. Now, when you close the expiratory valve in expiration, then the gas inside the lung, the pressure which is exerted by the gas inside the lung equilibrates with the airway pressure. And once you give an expiratory hold over here, you will see that the PEEP is rising, right? And this is the sum of the set PEEP as well as the auto PEEP, right? So you can quantify the amount of auto PEEP or the pressure exerted by trapped air inside the lung at the end of expiration by giving a expiratory hold and seeing what is the PEEP pattern. So you can make out a lot of these things by just looking at graphics. You don't have to make measurements, you just eyeball and you can see what's happening to the patient and the respiratory mechanics. There are lots of other things you can do. We don't have time to go into it, but it's a very interesting thing to read and learn. And I urge all of you to sort of pay more attention to ventilator graphics, and you will really be helping both in your own understanding of mechanical ventilation as well as in helping patients and diagnosing problems in patients who are being mechanically ventilated. So thank you very much for your attention. I'll be happy to take questions if there are any.
Thank you so much, sir. It was a much needed session, and seeing the recent COVID pandemic, and since we have to work with ventilators and ICU, it was such a needful session and a very fruitful session for us. Thanks for imparting your knowledge to us. Um Now we would like to move on to our next speaker, Dr. Mullidhar Joshi, sir. Question and answer session can be discussed in the chat box. And if any discussion is there, we'll do after the next speaker. Hmm. Dr. Mullidhar Joshi, MBBS, MD, DNB. He is currently the President ISA National, and he is the Director in Pain Management Center, Virinchi Hospitals, and he has done his DNB in anesthesiology, MD in anesthesiology from PGIMR, Chandigarh, India, and MBBS from Government Medical College, Bellary. Invention and development of equipment, instrument, device, procedure, and development of special teaching aids and forums. He is having 3 international publications. And in 2015, first fellowship program on acute pain and chronic pain in Asian continent from World Federation of Societies of Anesthesiologists. And in 2012, introduced first Android application in the world. And in 2010, initiated an international program, overseas doctors training program in pain management at Kamineni hospitals for women anesthesia residents. And 6 international, 2006, started first fellowship in pain management course in the country in collaboration with Dr. Rich Hospitals, Hyderabad. In 2005, performed first epiduroscopy in South India. In 2005, presented the new technique of percutaneous epidural and adhesolysis by selling this technique in failed back surgery syndrome, and started an innovative website www.jipindia.org. He has published first textbook of pain management in India, and he is having many authorship, editorship, reviewership of textbook chapter journals. He is a member editorial board, Indian Journal of Pain, Indian Journal of Anesthesia, and Anesthesia Editorial of the Week, editor-in-chief in 6 books, and contributing author in 6 books. And he's having publications of original research article reviews, editorials in index journals, 4 in international journals and 6 in national journals. And he has presentation of original research work, orations, guest lectures, workshops, and in many medical conferences. And he is the recipient of award for outstanding contribution to medical sciences, social cause, or in the scientific congress academic achievements. For example, in 2010 was awarded academic excellence for the year 2010 by the Indian Society of Anesthesiologists, National Body, Lucknow, and in 2005 for the percutaneous epidural adhesolysis by Seldinger technique. Thank you, sir, for being there with us. And it's an honor to share screen with you today. And it's very honorable to today listen to your lecture. We'll play a recorded video, sir. Thank you, sir.
Respected chairperson and my friends, at the outset, I would like to thank the organizers of Mpisacon for giving me an opportunity to share my thoughts about pain management and the emerging analysis in that segment. Then, as an anesthesiologist, one of the biggest challenge for all of us happens to be how to handle the pain. Because that's the most important thing, especially because if you just look at probably the even birth of anesthesia, also the idea was to make the surgery as painless as possible. So in this context, it becomes important the tools which we have to achieve the analgesia is very important. And currently, what are we using probably as an anesthetic purpose or maybe post-op pain management? The common analgesics, if you just recollect your own thoughts, maybe you can have something like paracetamol, maybe diclofenac, or something like maybe somebody might take ketoprofen or something. Basically, NSAIDs. So you can say about NSAIDs and probably paracetamol, then maybe opioids, and maybe local anesthetic as wound infiltration, or for that matter, I would like to say some nerve blocks, maybe peripheral or central nervous system. Apart from that, if you just look at that, maybe sometimes we might use steroids and other medications for managing the chronic pain. That could be anticonvulsants, or could be, I would like to say, maybe antidepressants also using chronic pain. So many are there. But if you just look at the picture, if you just look at the cycle, how probably I would like to say, just look at what is called as the origin of the pain and how it goes in propagating things with respect to signal processing and other things. And it becomes very important for us to understand. If you don't understand the physiology properly, you may not be able to get the good result. So that's the bottom line, what you should be having. In this context, I will show you a picture, probably you'll get a much better idea than probably what we can discuss. This is a picture, very important one, which probably all of you might have read during your pathology days. This is called a primary and secondary activation of the pain impulse. If you just look at the primary activation point of view, you can see whenever the primary activation, it could be a small injury or it could be as good as, I would like to say, the surgical incision. The first thing that can happen is the release of potassium ions, and then subsequently prostaglandins, the hydrogen ions, the bradykinin comes from the blood vessel. That will stimulate the free nerve endings, which are there in the epidermis. And of course, that will propagate its impulse further to secondary activation. If you just look at secondary activation, the free nerve endings release substance P at the end, which stimulates platelet release. Again, that leads to here and and one patient has good relief with diclofenac in post-op, but other patient doesn't. Why is it so? Possible he may not be predominant to prostaglandin secretor. If he was a prostaglandin secretor, probably prostaglandin inhibitor would have helped. Maybe he is why then they segregated humans into different alleles. People had this property. So, like if you say, as I was discussing about the diclofenac, like one person responds, other person doesn't respond. Those serum level might be same. It's because some of us might be missing the transporter, which can take the diclofenac, which is given intravenously or probably intramuscularly, to the site of action, because the transporter was missing. So that's what they segregated people. So that's the reason why one person same medication works and one person same medication doesn't work. So the best example, like imagine if you give atropine, some people have to increase, some people doesn't increase, where you land up. So that would say that will be so. So as I say, like one person responds to diclofenac, other did not respond. Possibly the other person might be predominantly leukotriene secretor or maybe interleukin secretor or a complement. But if you just look at that, we don't anti-leukotrienes, we don't anti-interleukins, we don't anti-complement. Somebody might predominantly histamine releaser or serotonin releaser. So we have to look at with open mind. So people might be secreting this kind of thing as probably inflammatory mediators rather than prostaglandin. That's where we might be lacking. So in this context, a lot of analytics are being thought about, a lot of work is going on across the world. And if we just think about that, for whatever recent analysis we had, probably after diclofenac, we had aceclofenac, again, nothing special about that one. And then subsequently, we had the other medications which came, and of course, because of the so many, what should I say, side effects like cardiac problems and other things, they had to withdraw those kind of medications. Especially, I'm talking with the coxips. They came and they left. Maybe one or two might be still might be in circulation for different reasons. But apart from that, they came a lot of those after that. So we didn't have anything. Maybe there could be newer opiates. Opiates also oxycontin, alpha-contin, azacontin. We're not able to use extensively in the clinical practice for different reasons. So this way we are lacking about certain things. So that's where people are looking at probably newer mediators or newer receptors. In this context, some interesting observations are there. This part I would like to share with you. So basically, current challenge is there are very few existing classes of analysis, but they have a lot of side effects. And then many failed development programs are there. Non-clinical models poorly predictive of clinical success. For example, driving with respect to maybe the control condition, there is no traffic on the road is totally different from driving when you have regular traffic going on. So basically, in clinical trials also unpredictable. In fact, we talk of what is pragmatic clinical trials. That in the real scenario, like somebody with a diabetes patient having probably a pain, you tend to give the diclofenac versus somebody who's in hypertension, comparing these two. So this is a problem. This is a pragmatic clinical trial. Rather taking the class A1 fit patient, dividing the male, female, and then trying to do that looks nice. So basically, sometimes clinical trials are also unpredictable because what is the role of the comorbid conditions on the patients? So that was becomes an issue. And in fact, some of the trials which are done, there's like which they showed earlier good results with a particular medication. Now they do not show same result. Now that speaks volumes about it. Look at the statement. A number of pharmacologic treatments examined in recent randomized clinical trials have failed to show such statistically significant superiority to placebo in conditions in which their efficacy had previously been demonstrated. Earlier, they had good results, but now the same molecules are not showing the same result. So this is the crux of the problem. So what exactly might have happened? You can understand what I won't have to elaborate. So basically, how do we fix this problem? One is a better study designs, because so we as clinicians may not be directly involved in manufacturing the product and all those things. Product we can share what might be good for the patient if it can take certain probably adverse effects from the medication, like abuse deterrent opiates, especially guidance for industry. We can say some of the approved particularly can take out dependence part inducing kind of property, especially synthetic opiates. We have an option like this. Future products you have to look at it and identify the new drug classes as per the inflammatory cascade, whatever newer the agents are, like newer receptors are being detected. So you'll have to work for something which can block the receptor, hence patient can get a good result. So these are some of the emerging analgesic compounds. Anti-nerve growth factor antibodies that's being worked on. Sodium channel blockers like NAV 1.7, NAV 1.8, NAV 1.5, and the voltage dependent calcium channel blockers. That's one more group which they are working on. Transient receptor potential vanillide 1, that is TRP1 and TRPV3, like receptor antagonists are also being thought of. NMDA antagonists and partial agonists are also being worked on. And all these things are probably in coming 5 years, you might be seeing this kind of products in the market. Maybe probably that might be probably good news for all of us at this stage. And some of the other emerging analgesic compounds are like fatty acid amide hydrolase inhibitors, nitric oxide synthase inhibitors, cannabinoids. Instead of brain produces so much of cannabinoid, in fact, we are a mobile factory of cannabinoid. Kappa opioid agonists, central and peripheral, delta opioid agonists, and of course, newer targets along the inflammatory cascade can be detected. You never know. That is the newer piece. What have been identified is a selective reversible inhibitor of microsomal prostaglandin synthase 1 enzyme and PGT production. So these are inhibitors which are being thought of. Basically, even the prostaglandin we talk of, we have to use a molecule which can take out GI side effects and polyrenal side effects. So those kind of things they're working on. And the interleukin 6 IL-6 antagonist that also being thought of. So all of them in the research process, various stages and all. Maybe in the coming 5-6 years, they might be hitting the market. Of course, don't forget a molecule to come into the market from the time like its concept has been floated, it almost takes 15 years. Of course, one exception for if you look at certain things is probably the COVID vaccine, which came almost within less than a year. It just came in. That's an emergency permission and all this. But these are all medications for different purpose. So, but that's what is being expected. But you have to see how it goes. Coming to the topical analysis, what is happening in this particular field? The main categories of topical analysis include rubefacins, like traditional formulations based on salicylate and nicotinate esters, capsaicin and capsicum extraction derivatives and all. In fact, capsicum, which was there What we in India is roughly 0.2 to 0.0 to 0.03%, and what was available in UK was around nearly 8% they were using and all, and in fact, of late they have stopped using that particular because of the a lot of side effects, like people had a lot of dysesthesia even after the discontinued medication and all, so it has been kept on hold. And there are insights of diclofenac, ibuprofen, ketoprofen, paracetamol, you are aware of that one. A miscellaneous group which has come is a benzoamine, which is where it's a benzoamine polysaccharide polysulfate, salicylamide and cooling space, where it helps in penetrating the topical medication into the skin. So that is one thing basically. So all these times we are talking what is called as newer emerging analysis. Now we are looking at the conductive media, like the devices which are being used, what modification is there, or how to make the drug more penetrable compared to the other molecules and all. So something, these things are also being worked upon. Some of the projects which are being lined up and which are being, a lot of work is going on, is something like, like you have the post-operative wound, you have the incisional pain and all those things. So what we do normally is probably from inside something on the opioid to try to first 48 hours, subsequently put some unique opioid or again maybe, how should I say, some analgesics to counter the pain. Imagine if you get a mesh like this or some beaded fur like this, and if you do a laparotomy, you can put it in the wound and muscle layer. And if this is coated with local anesthetics, opioids, diclofenac and paracetamol, and then you just put it there. Pain is from that particular abdominal wall, and that should take care of the pain. Why should you give the entire system the amount of medication what you're giving, so the side effects will be much more. So in this context, the thought is being that like medication doses might be less. The cost is also quite effective. They're looking at pricing it as much that is the current price which is there for the post-op analysis principle, like 7 days if you use, what is the cost? They want to keep it at that level only. Still in the research stage, and we have to see when it's going to hit the market. And this is something like, Vicks Vaporub is a later generation, they remember and all those things. Like, like those days when you used to have a cold and all that, they used to put some vapor, maybe rub it on our chest, or sometimes we used to get patches. Now they're coming with this kind of patches which is impregnated with any of the NSAIDs. So in inhaling, automatic NSAID goes into your breath, and that it's like a personalized delivery of that particular medication that's being thought of. And then how about this one? This is nothing but especially very popular in the younger generation. Like, imagine if you can just probably put the pasta on this kind of food which can melt in your mouth. A lot of people use this kind of sweetening agents these days and all, and wafers and all. So they're looking at impregnating this paracetamol, because this need arose because a lot of these are kids less than 5 years, when they get cough, fever, or something like that. Invariably, what is happening is by the time patient, the baby had the food or something, a milk, something, then doctor says they will give some kind of antibiotic syrup, then he gives paracetamol syrup. Subsequently, child vomits. Now you don't know how much antibiotic is in, how much is out. So to prevent that one, and when you give paracetamol syrup also, at the end of sometimes the child may not like the flavor, or something you have to give some water with that one. So a lot of problems are there. This kind of thing, wafer kind of thing, where paracetamol they can just melt in your mouth. You don't have to swallow it with water, is being worked upon. Interesting, because these are all the newer thoughts. You never know how the in the coming days will make difference for this group of discoveries. I told, like, one group is newer medications which are being tried out. Another group is where newer routes of administration, so that the molecule remains in the body and it's quite effective. Then you have got what is called, what you're seeing over here, this kind of buprenorphine packs which can last for, of course, what I would like to say 6 months, something like that. That's what, especially with a condition like, what I should say is osteoarthritis and all. Some people do not want maybe knee replacement, knee for OA. Those group of patients, these kind of patches would not like this work for 6 months and all. So that's being thought of, but it's good in especially temperate climates like maybe Europe and other places. But a tropical country like India, the patch remaining on the body for 6 months because so much sweat happens because summer and the different seasons and all. I don't know how much it might be useful, but work is on for this kind of situations where it might be useful for cancer patients also. You never know the long-term effects and all. So these are the newer routes of administration which are being thought of for this particular stage. And of course, it's very easy to say that nothing is there, but when it comes to somebody doing the discovery or something, it's not so easy. So to conclude, I would like to say we have to move from empirical therapies to a mechanism-based approach. So that's one thing what we have to think about it. Newer drugs targeting specific receptor subtypes. So that's one thing we have to understand, because what are receptors we have, what are medications they're matching, but there could be some receptors we are missing, probably mechanism also. But look at that one. Treat acute pain promptly and aggressively to possibly avoid chronic pain. That's most important, because one of the reasons, because now the also rest of the centers in the world, nearly 70% of the patients suffer from moderate to severe pain the post-operative period. Because 70% best of the best centers in the world. So unless you treat the acute pain properly, the aggressive, that will avoid the chronic pain. Otherwise, they'll end up with what is called as a chronic post-surgical pain, that is CPSP. So cyanide uses a combination drugs to target multiple points of conjugate pathway might be advantageous. It can limit the side effect of the each molecule to a particular, because you're using 50% dosage. So that is one more thing you can consider. Of course, it looks like multimodal management of pain can provide better efficacy with reduced side effects. That seems to the order of the day at this stage. Hopefully, we get newer molecules which can be more effective and with the less side effects, so that we can use it more liberally. Especially with the lifespan of human, like in Indians going up, it's very important that we have to have this kind of medication, because as you stay longer in this earth, you're going to have a lot of degenerative disorders, and most of these disorders end up as pain, chronic pain. Definitely, we have to look for these things. These few words, I would once again thank the organizer for giving the opportunity. Thank you, Anand. Thank you so much.
Thank you so much, respected sir. It was a wonderful lecture, and we are honored that you have chose to give the lecture here. Thank you so much. Thank you, Dr. Shikha ma'am, for joining us, and thank you, Dr. Nilima Tandon ma'am, for joining us.
Thank you so much.
Thank you. Now we move on to our next lecture. The chairpersons for the session is Dr. Ruchi Tandon ma'am and Dr. Preeti Goyal ma'am. And the first lecture is by Dr. Vishali Ponde ma'am in regional anesthesia in New Orleans. We'll have her CV. Dr. Ruchi Tandon ma'am. Dr. Vishali Ponde, President, Managing Trustee and Founder Secretary, Academy of Regional Anesthesia India, Director, Children's Anesthesia Services, Mumbai, Program Head in WFSA Children Anesthesia Services, ISA Pediatric Regional Anesthesia Fellowship, Education Committee, WFSA Pediatric Anesthesia, AORA and CS Pediatric Regional Anesthesia 6 months Fellowship, and she's our ASPA, Education Chair and Ex-Secretary, Asian Society of Pediatric Anesthesiologists. Works as regional anesthesiologist and pediatric anesthesiologist in various institutions of Mumbai. 3 editions on illustrated manual USGRA, anesthesia in adults and children. She has presented Indian perspectives on regional anesthesia in various countries, international and national research publications, and Top Docs India Today 2018, 2019, and 2020. And she is a sitar player, performs regularly as a student of Halim Academy of Sitar, Shiv Sangeetanjali and Guru Purnima programs, Bandar Festival and Sangeet Sharda Vidyalaya. Ma'am, we are honored to have you here. And our respective chairmen are Dr. Ruchi Tandon, ma'am. Since Dr. Ruchi Tandon, ma'am, is in Hall A, we are introducing a CV, but she'll shortly join us in a short time. Dr. Ruchi Tandon, MD Anesthesiology, Professor Designate, Department of Anesthesiology, Gandhi Medical College and Associated Hospitals, Bhopal. She has successfully completed basic course in biomedical research 2021, CISP 2 in September 2020, and she was awarded Dr. M.T. Bhatia Gold Medal for research work on pain management at MP State Annual Conference 2011. FCC Instructor Certified by Critical Care Society of India, August 2011. And she has done paper presentation at international conference, that is 9th Congress of SARC countries, Association of Anesthesiologists, presented papers in various conferences, guest speaker at various national, zonal and state level conferences. Work profile, she is a professor designate in anesthesiology, Gandhi Medical College, Bhopal, supervisor and guide for thesis and research work in departmental academic clinical trials. And she has published papers in index journals and external examiner in MD exams. Thank you so much, ma'am, for joining us. Our next judge chairperson is Dr. Preeti Goyal. Dr. Preeti Goyal, she's a designate professor, Department of Anesthesiology, GRMC, Gwalior. Thank you, ma'am, for joining us. And let's start with the lecture of Dr. Rushali Ponde, ma'am, in regional anesthesia and neurology.
A building is on fire. And let's see how it is. It's total chaos. And then comes a superhero. And look at him. And a huge responsibility is on this superhero. And he has to do something heroic and see to it that her baby is safe. And there are ups and downs, and they don't know what's going to happen. The baby does get rescued, lo behold. And yes, okay, the baby is fine. And this is the hero. This is what we are. We are healthcare workers. And if we are anesthesiologists, even more so. If you're an anesthesiologist taking care of babies day in and out, you have a bigger responsibility. Well, not a bigger one, but a very special responsibility for sure. So today, for the next blocks for premature neonate into the definition, incidence of prematurity, we are going to look at the anesthetic implications and common procedures very briefly, though, because the entire anesthesia implications is totally out of scope of this particular lecture. We are going to look properly into why regional anesthesia and what regional anesthesia can be offered through case scenarios, because I think this is the best way we can share with each other the thoughts. Well, so less than 37 weeks of gestation, you call it premature. Less than 28 weeks, extreme premature. As an anesthesiologist, you can be taking care of both for different reasons, which we are going to soon see. At least in India, amongst the total of 27 million babies born annually, 3.6 million babies are born preterm. So the load is pretty large. There are plethoras of implications on this particular age group as such, because anesthesia really can change a lot. So they in any case are very vulnerable to respiratory and cardiac events. Most likely they are going to be intubated and ventilated in the NICU for various reasons. And most importantly, it's going to be a respiratory reason. Occurrence of apnea, even if they aren't ventilated, they are very much prone for apneic episodes in the postoperative period. Airway management is going to be tricky due to their small size, and possibility of neurotoxic effects are hovering around us. They are not totally proved, but yes, a developing brain will be susceptible to neurotoxic effect of the general anesthetics, and this suspicion has changed the premise here, and regional anesthesia is now even in the forefront when it comes to management of this age group. This is a beautiful article written in IJA. I urge you to read it because the most common procedures are hernias, of course, not the elective ones, the incarcerated hernias mostly, or when the child is in the NICU, the baby is in the NICU, baby grows a little and they have an hernia. Rather than going home and coming back for the procedure, our NICU at least has a thought process that let us operate on the hernia, because sooner or later we in any usually bilateral hernia. Then the tracheoesophageal fistulas, the congenital diaphragmatic hernias usually we come to know even prenatally, anorectal malformations, necrotizing and enterocolitis, very notorious condition, atrasias, ileal atrasias, duodenal atrasias, or intestinal perforations. These are the most common surgeries that we encounter as pediatric anesthesiologists. So why RA in this population? Why regional anesthesia? It spares general anesthesia. A whiff of sevoflurane, a good acting regional technique, and then you spare a lot of sevoflurane itself. You spare opioids, most importantly, something that would turn them apneic even more, something that would turn them hyperalgic, because apnea may or may not concern you if they are going to be electively ventilated in the postoperative period in any case, but definitely the ileus that fentanyls would cause, the hyperalgesia that the fentanyls would cause, or any opioid that you use cause, does have an impact here. It reduces prolonged ventilation. Imagine if we give a regional technique, they would need very little to the baby as well, and they would come out faster because the pain would be addressed in a good way, that they will breathe better. Reduces apneic episodes, as we just mentioned, and pain relief. All the negative effects of acute untreated pain would be addressed here. Mind you, in a preterm neonatal central nervous system, which is not much developed, the repercussions and the effects of untreated pain would be rather robust. Well, so these are the benefits of regional anesthesia in children. It's very small. There are many regional anesthetics that can be intubation plus a caudal block. It could be intubation plus ileoinguinal ileohypogastric block. It could be intubation plus a TAP block. It could be intubation plus simply wound infiltration. It could be mask and a very well-placed caudal. The last technique is what we prefer. The anesthesiologist's population can be divided into two, you see. Those who are occasional pediatric anesthesiologists and those who are hardcore everyday pediatric anesthesiologists who do not do any adultery. They do not do adult work at all. So the last technique, just a mask and a very, very good caudal, is something reserved for the hardcore pediatric anesthesiologist. After having said that, to each its own, but let me share how we go. Caudal block, we really need not go into the details. It has a ubiquitous influence in pediatric regional anesthesia. In a preterm, you don't even have to think much, everything just stares at you. So this is the sacral corridor through which you could go by laws of resistance approach. You could put an ultrasound and see what you're doing. So let's see how it goes. This is just to tell you that how small this particular back is. This is a 5.5 glove hand, which is my hand, and the calculated amount of local anesthetic is taken, and this is how we go ahead doing it. This is a 2 syringe taken, and we go through the skin subcutaneous tissue. It's a very, very superficial job, very, very subtle loss of resistance. Mind you, this is not a case to be given to a trainee who's just 1 year old, one month old in pediatric anesthesia, who's come to learn from you, because the sacrum of this age group is so subtle that you wouldn't even know if you have really pierced it. It's going to be that subtle. Well, so now coming to special needles, we adjust the guard so that inadvertent insertion is avoided of the needle inside through the skin and subcutaneous tissue. But if you note the way the needle is inserted, since being short pivot, they're slightly blunt, and you really have to pierce them very hard through that supple skin, and everything else remains the same. But of course, the advantage is you don't get the skin into the epidural space. So these are the needles that I'm talking about. You could use these needles even for a spinal block, and then the surgery can go on like this. They just a whiff of sevoflurane, give a caudal block, and then all that you need is oxygen, air, minimal amount of sevoflurane. Even a vasicostomy, if required at this particular age group, with a deranged creatinine, keep a very, very light level of general anesthesia, such as a mask anesthesia. So you just touch the neonate with your hands and they are going to respond to your touch, but a vasicostomy shall go on because the operability is rendered by a very well-placed, well-calculated caudal block. So now coming to ultrasound caudal block as such, well, prematures have their own story, you see, well, such as this is the posterior and this is the anterior of the patient. This is the caudal and that's the cephalad end, and dural sac as such, and this is the spine of the sacrum. So this is the roof as such of the sacrum, and these are the vertebral body. So this is the body or the base of the sacrum, as it were. So this is the dural sac, and you have this much of a distance for the needle to go in and pierce it. So it is around 1.6 centimeters in a preterm. Form the sacral cornu by giving a proper lateral position, just the position in which you would have inserted the needle to give any block, landmark guided. And here is the conus medullaris, and you can in fact even see at what level the conus medullaris ends. We took around 40 babies, preterm babies from our NICU, and we scanned them by placing them in a position as if we were to give caudal, and this is what we realized. Of the sacral corner to the dural sac and age was not significant, but there was a very, very significant correlationship between the distance of the sacral corner to the dural sac and weight. So this was a statistically significant finding that we thought, well, what today work, this was the regression equation that we could find out to be very, very safe and not go towards dural sac if we don't have an ultrasound. Otherwise, what it tells us is whenever you have an ultrasound, use it, or when ultrasound is not possible and landmark technique is used, then the piercing of the sacrococcygeal ligament, after piercing the sacrococcygeal ligament, the needle should be inserted less than 0.5 centimeters per kilogram in preterm neonates, and to be within 2 standard deviations, but it has to be limited to even lesser, that is 0.3 centimeters per kilogram, to capture 99.9% of 3 standard deviations. So this is what this particular calculation tells us, and we feel that this is significant because most of the studies have calculated distances, cadaveric neonates, or their MRIs. So this is the position given just for the block and hence matters more. Axis. So this is the sag of the posterior dura, a surrogate marker to the fact that the drug is deposited properly in the central neuroaxial conduit. Having said this, now actually is a good food for thought. Listen to me. Can we leave this particular population to a mask and a well-given caudal block? So just our practical experience says that we can. But however, I would say that this has to be thought in a way that if you are an occasional pediatric anesthesiologist, may as well secure the airway and then think of a regional block. But if this is your day in and out work, and if you know your surgeons and they know that if need be any particular second of the surgery, if they want to, if we need to get the airway in control, we are there to get the airway in control, and hence it has to be taken totally by the work culture and the expertise, the fitting expertise that particular person has. By the way, this is not just we who are saying. This is the regional block via continuous caudal infusion as a sole anesthetic for inguinal hernia repair in conscious neonates is published in the pediatric surgical journals. So this is a thought. This has to be tested in your premise, remember, before applying it. Spinal anesthesia definitely is an option, but I have certain reservations towards them, which is as follows. Generally, spinal anesthesia wears off very quickly in this particular population. That is number one. Number two, it is not going to linger in the postoperative period, you see, as a caudal block would. And what if the surgeon, the surgeon always does a bilateral repair, at least in this age group. And what if the spinal anesthesia wears off even before that? Maybe this is how it would go. So you take the space which is the lowest, maybe the S5, S1 and the L5 maybe, and goes under strict aseptic precaution. This is how the needle is inserted. We could use the needle which we had just shown, the special needle which have stillets. They're Vigons or the Pyongs. They are the two companies which make them. And then the calculated dose is injected. The baby can also be in sitting position, but for sitting position, mind you, the neck position and the head position should be very, very carefully held. Otherwise, they can become apneic due to that itself. And once the spinal is given, a very careful monitoring is done. And the most important monitoring to be done is the baby should not be lifted up to keep the cautery pad at its back. This is what is tip 0.8 ml per kilogram of 0.5% heavy bupivacaine. Well, coming to a next case, 800 gram ileal perforation ileostomy. This obviously is going to be intubated. This obviously is going to get a continuous caudal epidural catheter is what my choice would be, unless there are some coagulation issues and DIC is setting in or something like that. So this can be very beautifully seen under ultrasound. So this would be the caudal catheter. Caudal does remain a very beautiful portal in preterms where we could ascend the catheters up to the surgically congruent vertebral levels. And we have looked at it very carefully. Sometimes the epidural catheters go from the posterior side to the anterior side. You can trace the tips, and in prematures the anatomy is very, very beautifully understood, and this is the tip. In fact, sometimes you see it even going towards the anterior epidural space, so they do not really obey your commands. They don't go where you want them to go. Hence it is better to see them if you can, and then give your drug, so you're very sure that it's acting, and you can reduce the amount of drug that can be injected once you are very, very surgically congruent. So does ultrasound guidance add to the accuracy? Yes, it does add to the accuracy. Well, if you want to set up infusions, then we need to set up a team, and after extubation of the pain relief is given through the epidural infusion, then we do not need opioids for that until they breathe better. So maybe if the ventilation is for 36 hours, then you can extend the epidural infusion, say, for 48 hours. And paracetamol in any ways is the only other drug that we can give as suppositories in a dose of 15 milligram per kilogram. Well, caution while placing regional anesthesia in preterms is something that we need to think of, especially when you are using ultrasound and keeping longer catheters. Well, airway. So these are very small babies. You turn them, the tube is waiting to come out. Hypothermia, because the back is going to be open. You are going to prepare probes. You're going to keep the probes. Then we're going to keep tilting, seeing the probes, and then another one is going to put the catheters in. These are practical issues that I'm trying to share with you. But if you can overcome them by proper protocols, by seeing to it that they're wrapped well, you anyway are going to do that. But seeing to it that your position of the warmers are fixed, and seeing to it that they're well wrapped, and seeing to it that the betadines that you're going to use or the cleaning agents you're going to use are slightly warmer, you can help this particular aspect. And venous access, again, while turning the babies, you may lose veins, so everything has to be thought of very carefully. Lumbar epidurals and caudal directions, yes, we have practiced them, especially when the case is such a fitting one. Thankfully, with time, we do not we do not get these cases very often. A 700 grammer for a resection anastomosis for ileal perforation, and as such, they come intubated or we may intubate them, but the weight is such that our NICU would like to intubate them. They give it to us. We extend the anesthesia, very minimal, muscle relaxant, sevoflurane, vagolytic agent, and then of course, go ahead and put an epidural catheter. And then the dial flow of sevoflurane you're going to need is less than even 1%, typically 0.4 or 0.3. Platelet count is less. Well, then we think we do not keep catheters if there are any derangements, but platelet count 1 lakh may not deter us, but anything less than 80,000 of platelets, we do not. And it is always a team decision that we take if you're going to infuse it, or because NEC is something that you need the microvasculature improvement that epidural gives you, you see. This is one particular case that comes to my mind. Maybe premature, of course, PDA, AST, mild pH, esophageal atresia, duodenal atresia, TOF repair was the priority, and exploratory laparotomy. If the intraoperative case scenario was okay, or we would have picked up on the other day. And anesthesia and lumbar epidural was the plan. Well, so the baby was operated on day 2. We could actually do both, but we had a short gap in between so that the ETCO2 doesn't rise much. We repeated the arterial blood gases also, and actually it went very well. What I am trying to emphasize here is the plan, the communication, and the teamwork. It's not that we've not had problems with babies, but then even on that occasion, it is always a team decision that is taken. And in the postoperative period, the NICU head is the team head, but in the intraoperative period, it is the anesthesiologist who really takes the calls and has a very open communication with them. Tracheoesophageal fistulas, this is CDH, this is typically a one-sided work, a unilateral work, and we can take a different take on it. So we can go to the newer erector spinae blocks, or we can go to the paravertebral blocks. Erector spinae blocks, yes, they do work very well in the thoracic cases as such. I have my reservations when it comes to the abdominal cases, because you can't keep bilateral catheters, we can't give bilateral blocks, and even if it is one-sided surgery, say for example, the incision is going to be on one side of the abdomen, but yes, for thoracic surgeries, they have been useful, and it's very easy to decipher the anatomy. So this is the local anesthetic that you can see, and this is the transverse process. We can keep catheters. Here is a good case report which is showing you that, but then catheter fixation, mind you, again, it may come in their incision. We have faced this with paravertebrals as well as erector spinae, and then the catheter inside is very, very little. It's not even going to be 1 centimeter, and the avulsion of that catheter in the postoperative period is very easy. That has been our slight difficulty. And when we put infusions, we see that there is a small bulge that paravertebrals, yes, it's a beautiful block to practice in neonates, as I just described you. Here is the central neuroaxial, an entire transverse section showing. This is the posterior and this is the anterior. In fact, these are the lungs. Well, let me talk to you layer by layer, skin and subcutaneous tissue, the erector spinae. So if you want to give your erector spinae, it's right here. If you this is the posterior dura, that's the anterior dura, vertebral body. Then this is the spinal cord. This is the dentate ligament. The nerve roots would be coming out from here. So here, this particular line, this particular place is a good place for the paravertebral block. This is a transverse process, so you can come here and do the erector spinae. Here would be the trajectory for the paravertebral blocks, as a shoulder abscess or even hip abscess, septic hips, septic shoulders, very common in these babies. So again, here a whiff of sevoflurane, and then you can place a block and they can really drain it, because this is a septic scenario. Well, now we can look at it as a relative contraindication. In sepsis, we may not give block. Regional can be a contraindication. But then if with sepsis, if they are going to go under general anesthesia and sink, then maybe you can take a different outlook over it, then go ahead, give a well-placed interscalene block as such. And in this age group, you really can't say where is the interscalene and where is the subclavian perivascular, where that one ends and another begins, because the gap is so little. You put around, say, even 0.5 ml, you're going to get your block. That's the beauty of it. So this is how we look at regional anesthesia in preterm, and there can be many other occasions that you can think of it. Thank you very much for having given this topic to me, and thank you very much for listening to me. Mind you, there are going to be complications, and any such as, say, last complications due to needle punctures, they all need to be taken care of. So take this technique in preterm with a lot of respect as well.
Thank you so much, Vishali ma'am. That was a very nice lecture, and it was full of, you have discussed very nice case scenarios, ma'am, explained very well, and it was full of pictures. Thank you so much, ma'am. Our next speaker will be Dr. K.K. Arora, and the topic is last should not last. Dr. K.K. Arora, Professor and Head of Department of Anesthesiology, MGM, Medical College, Indore. Teaching experience 32 years. Post held in ISA, and he was past President ISA Indore 2006 to 2008, past Honorary Secretary ISA MP 1999 to 2002, past President ISA MP 2012, CME conferences organizing Secretary WFSA, ISA CME 2020, Organizing Secretary ISACon 2012, Organizing Chairman ISSP Con 2016, and Organizing Chairman AORA Con 2017, and Organizing Chairman in MP ISACon 2019. And he is having areas of interest in obstetric anesthesia, pain, guest faculty, and chairperson in various state, zonal, national conferences and publications in 42 publications. He is having 42 publications. Thank you, sir, for joining us. Let's start the pre-recorded lecture. There's a technical glitch. We are stopping the video and just wait for 2 to 3 minutes. We are seeing the issue and we'll come back in 2 to 3 minutes. Good afternoon, everyone. Since we are having some problem with the video, Dr. KK Arora sir is taking over the session and he is covering live. So thank you, sir, for supporting, for coordinating with us. Thank you, sir. He'll take over the session.
Good afternoon, everyone. Just sorry for the technical glitch. I have to share my presentation. Just a moment.
So you can start from where the PPT was, from where PPT ended. Yes, sir.
Am I audible?
Yes, sir, you're audible.
Yeah. Good afternoon, chairpersons. I take this opportunity to congratulate Dr. Sarvesh, Dr. Satyendra, Dr. Amit, and Team Sagar, as well as Team ISA MP for organizing this conference. I am also thankful to organizer for giving me an opportunity to interact with you on this important aspect, local anesthetic systemic toxicity. Greeting from MGM Indore. In next 20 minutes, I shall be talking on the following headings. Local anesthetic systemic toxicity is a nightmare for the anesthesiologist. It can have catastrophic outcome. Loss is due to excess plasma concentration of the drug. Loss is potentially a life-threatening complication that occurs when a bolus of local anesthetic is inadvertently injected into venous or arterial circulation or into peripheral tissues. Okay. Systemic distribution of local anesthetic leads to loss, which has devastating effect on the cardiovascular and the central nervous system. Last is not a new entity. The clinical presentation of LAST has been known for more than 100 years. After introduction of cocaine as the first local anesthetic in late 19th century, its systemic toxic effects were reported. Lidocaine was first synthesized in 1944. It was the first amide local anesthetic to be used clinically. Bupivacaine was introduced in 1960 by increasing an alkyl carbon chain, increasing its lipophilicity, which increases duration of action, but unfortunately at the same time also increase systemic toxicity. In 1979, the potential fatal toxicity of amide local anesthetics was highlighted. The incidence is 0.27 episode per 1000. That comes out to be 0.03%, though it's rare, but it is fatal. Now, to learn about something about local anesthetic, its structure. It has got two types, ester and amide. Two domains, they are hydrophilic or lipophilic. Greater the lipid solubility, greater is the potency and duration of action. More potency means increased toxicity and decreased therapeutic index. Now, aromatic ring in local anesthetic is connected with tertiary amine by either by intermediate link, which may be either ester or amide. Systemic and local toxic reaction can occur due to accidental intravascular injection, intrathecal injection, or administration of an excessive dose. Now, local anesthetic act by blocking sodium channel. They also block potassium and calcium channel, and the mechanism of loss is due to its effect, the effect of local anesthetics on various targets, intracellular, mitochondrial metabolism, and it also inhibits ryanodine receptor at sarcoplasmic reticulum. So these are the various target where local anesthetic act, and it also explains the mechanism of local anesthetic systemic toxicity. Local anesthetic act on cortical inhibitory pathway by blocking sodium channel, disrupting inhibitory neuron depolarization. Inhibiting these result into excitatory clinical features. As plasma concentration rises, occurs depressive phase. At cardiovascular level, they produce complex toxic feature in cardiovascular system, that is conduction disturbances, myocardial dysfunction, and lability of vascular tone. Also rhythm disturbances, increase in PR, QRS and ST interval, tachy and bradyarrhythmias, and myocardial dysfunction. And calcium channel blockade causes reduced contractility. Risk factor may be drug related, patient related, or technique related. Drug related risk factors are type of local anesthetics. So they may be either ester or amide, or bupivacaine, ropivacaine, levobupivacaine, lignocaine. Now, local anesthetic have different intrinsic vasoactive effect. So levo and ropivacaine have vasoconstrictor properties that may prolong duration of action and slow systemic absorption, and bupivacaine has vasodilator properties and may lead to more rapid systemic absorption. The appropriate dose of local anesthetic should be the lowest effective dose that achieves the desired effect, and patient characteristics need to be considered, and also the site of administration. This is a recommendation of doses of various local anesthetic agent with epinephrine or without epinephrine. Patient-related risk factor. Toxicity mainly depends on increased free plasma concentration. Now, increased perfusion at the site of injection raises the peak plasma concentration by accelerating systemic absorption. Decrease alpha-1 acid glycoprotein titer results in higher concentration of free local anesthetic. Reduction in the clearance leads to accumulation with repeated doses and infusions. Comorbidities also affect. In renal impairment, there is hyperdynamic circulation and reduced clearance of local anesthetic, but an increased ASD concentration, so they are at slightly increased risk of loss. And in liver diseases, as the metabolism is affected, the clearance is reduced, so chances of toxicity is more. In cardiac failure, patients are susceptible to local anesthetic induced myocardial depression and arrhythmias. Reduced blood flow and impaired organ function affects clearance in elderly patient. Thus, the chances of toxicity are more with infusion or repeat dose. Neonates and infants have reduced ASG level and have an increased elimination of half-life of local anesthetic, which in neonate is increased to 2 to 3 times. This increases the risk of accumulation with continuous infusion. Pregnant patients are at an increased risk of toxicity because of reduced alpha-1 acid glycoprotein level and an increased cardiac output. Accelerated perfusion of site of injection results in rapid absorption and a high peak free local anesthetic concentration. Additionally, epidural venous engorgement may increase the drug absorption, thus necessitating the reduction in doses of local anesthetic in pregnant patients. Now, site of block. So, the systemic absorption depend on the site of the block, and also whether local anesthesia is given as a single administration technique or via continuous infusion. Now, conduct of the block. The factor that decrease the risk of toxicity while the block is being performed are frequent aspiration, incremental injection, test dose, whether epinephrine is used or not, and ultrasound guided needle placement. Now, clinical presentation. Toxicity event may happen within a few minutes and up to 60 minutes after the local anesthetic injection. Then presents with signs of CNS toxicity with or without changes in CVS. And under general anesthesia, signs of CVS toxicity appear in the absence of any CNS characteristics. So, the various signs and symptoms are depicted here. Rapid onset presentation may be there. It presents within 5 minutes. Then prodromal symptoms like dizziness, drowsiness, tinnitus, confusion, dysphoria, dysarthria, audible disturbances, circumoral numbness, very important, and metallic taste in mouth. These happens. Then followed by loss of consciousness, seizures. CVS symptoms are characterized by initially by tachycardia, hypertension, followed by white complex, SCT segment changes, bradyarrhythmias, ventricular tachycardia, ventricular fibrillation, and collapse. Now, systemic presentation. In 33% cases, combined CNS and CVS effects are there, and in 24% cases only cardiovascular, and in 43% cases only CNS. A spectrum of CVS, bradycardia and hypotension seen in 16%, cardiac arrest in 23%, conduction delay in 27%, and dysarrhythmias in 34%. Agitation and prodromal symptoms in 6% and 12% respectively, loss of consciousness in 36% and conversion in 47%. Clinical presentation. Now, CNS excitation occurs followed by CNS depression. So, higher concentration of local anesthetic leads to blockade of sodium ion chain, occurs in inhibitory neurons, and there is unopposed action of excited neuron causing convulsion, then followed by global CNS depression and POM. In the initial phase of CVS toxicity, there is hypertension and tachycardia. In intermediate phase, there is myocardial depression and hypotension, and in terminal phase, peripheral vasodilatation, severe hypotension, and arrhythmias such as sinus bradycardia, conduction block, ventricular tachyarrhythmias, and asystole. This diagram again showing all the signs and symptoms of cardiovascular, cardiac toxicity, and cerebral toxicity as per the plasma level. And this also showing cardiac toxicity, cerebral toxicity with the time. Now, CC-CNS ratio. The ratio of the dose required to produce cardiovascular collapse to that required to produce seizure is CC-CNS ratio. And for bupivacaine, it is 2, and for lignocaine, it is 7.1. So, progression from CNS signs and symptoms to cardiovascular collapse can occur more readily with bupivacaine than with lidocaine. So bupivacaine is more cardiotoxic. Now, allergy to local anesthetic. It's a common misdiagnosis after accidental IV injection. Ester local anesthetic agent contains allergens like para-aminobenzoic acid, and preservative added in amide local anesthetic is methylparaben, and symptoms of allergy are rashes and urticaria, and sometimes anaphylaxis may happen. Methemoglobinia can occur with prelocaine due to its metabolite or toluidine. Eutectic mixture of local anesthetic should be avoided in patients with congenital or idiopathic methemoglobinemia. Avoided also in less than 1 year or receiving sulfonamide or phenytoin. Treatment includes oxygen, methylene blue, and removal of oxidizing agent. Now we come to the very important aspect, management. Management of local anesthetic systemic toxicity. So recognition is very important. Any sign and symptom of either cardiovascular or CNS toxicity, you should be vigilant. And we should start immediate treatment. Call for help. Stop local anesthetic administration further. Maintain airway. Establish IV access. Control seizures with benzodiazepine, that is midazolam. Start IV lipid immersion. If there is no circulatory arrest, then conventional therapy for hypotension and arrhythmia, and continue IV lipid immersion. If there is circulatory arrest, then start CPR and ACLS. Epinephrine should be given in low dose. Continue IV lipid immersion. Avoid lignocaine for arrhythmia management, and consider cardiopulmonary bypass. Follow admit in ICU and close monitoring until recovery. Now, we have already discussed all this. Stop giving further drug, call for help, airway management, control seizure, and treat hypotension and bradycardia as indicated. Since lipid immersion. So lipid immersion, if patient weight is less than 70 kg, a bolus of 1.5 ml per kg, 20% lipid immersion in 2 to 3 minutes, followed by an infusion of 0.25 ml per kg per minute. And if patient remains unstable, rebolus once or twice in same or double dose. Do not exceed 12 ml per kg of lipid emulsion. And if patient weight is more than 70 kg, bolus 100 ml in 2 to 3 minutes, followed by infusion of 200 to 250 ml in next 15 to 20 minutes. If patient remains unstable, rebolus once or twice in same or double dose, and do not exceed 12 ml per kg of lipid emulsion. Now, how it act? Lipid act as a shuttle. It shuttles the local anesthetic from high concentration to low concentration organ. So from brain, heart, and kidney to muscle, adipose tissue, and liver. So it reduces its toxicity, it affects. After last, patient's clinical condition and vital sign should be monitored in ICU. Complication of intralipid lipid immersion, IV lipid immersion administration is pancreatitis. So CT abdomen in follow-up should be done, and estimation of amylase, lipase, and other markers should be done. Now, safety guidelines as per Association of Anesthetists of Great Britain and Ireland. So recognition, the number one point is recognition. So signs of severe toxicity, if there is sudden alteration in mental status, agitation or loss of consciousness with or without tonic-clonic conversion. And if there is cardiovascular collapse, bradycardia, conduction block, asystole, ventricular tachyarrhythmia. So local anesthetic toxicity should be suspected, and immediate management should be done. Stop injecting local anesthetic, call for help, maintain airway, give 100% oxygen, confirm or establish IV access, control seizure with midazolam, thiopentol or propofol in small dose can be given. Assess propofol in large dose should not be given. Assess cardiovascular status throughout. Consider drawing blood for analysis, but do not delay definitive treatment to do this. Then treatment. If there is circulatory arrest, start CPR using standard protocol, manage arrhythmia, consider use of cardiopulmonary bypass if available. If there is no circulatory arrest, use conventional therapy to treat hypotension, bradycardia, and arrhythmias. Give intravenous emulsion as per the doses and continue CPR along with that. And in follow-up, arrange safe transfer to clinical area with appropriate equipment and monitor and suitable staff. Exclude pancreatitis by regular clinical review and daily amylase and lipase levels. So, as per NISORA guidelines, this is algorithm to treat last. This is as per ASTRA checklist. Now, prevention. The golden dictum is prevention is better than cure. So primary objective is safety of the patient. So pre-anesthetic evaluation, preparation, complete monitoring before starting local anesthetic, monitoring during surgery, monitoring in the immediate post-operative period. So pre-operative assessment, evaluate the patient for comorbidities, evaluation of risk and benefit of regional anesthesia for the individual should be discussed. Patient should be explained regarding procedure and appropriate consent to be obtained. Preparation, proper selection of the type of local anesthetic, prior calculation of the dose and labeling of all syringes, and all monitoring facilities to be available along with the last rescue kit and resuscitative measures. Intra-procedure, continuous monitoring, method of administration of is very important. It should be administered in incremental doses, say 3 to 5 ml, and wait for 15 to 30 seconds and with frequent aspiration. Ultrasound guided needle placement, if available, should be done, and it reduces the chances of last, and administration of trace dose. And continuous communication with the patient to detect any early sign of intravascular injection is very important. Post-procedure, clearly label all types of catheter like spinal, epidural, or peripheral non-blockade catheter. It should be documented well in the patient chart also. Drug and dose are ready administered to be noted and should be well informed to the medical staff responsible for post-operative care. Continuous monitoring of vital sign in the post-operative period in suspected case of delayed loss to be considered. Now, these are the recommendations as per the for prevention of loss. USG guided lowest effective dose of local anesthetic will be used in incremental injection of 3 to 5 ml, pausing 15 to 30 seconds, aspirate before each injection. Potential toxic dose of local anesthetic, use of an intravascular marker epinephrine. Then caregiver should be aware of additive nature of local anesthetic toxicity and accordingly adjust the dose. Risk of loss with truncal block may be reduced by lower concentration of local anesthetic and or adjunctive epinephrine and observation for 30 to 14 minutes. And patient receiving liposomal bupivacaine should receive same level of vigilance. So we have come to the last slide of last. Last is a potentially life-threatening complication. Risk factor may be drug related, patient related, or technique related. The lowest effective dose of local anesthetic should be used. Chances of loss are more in extreme of ages, in pregnant, and in patients with comorbidities. Technique plays an important role. The site of injection, the conduct of technique, and whether it is single or continuous. Clinical features comprises of symptoms and sign related with CNS and CVS toxicity. CC-CNS ratio is very important. For bupivacaine, it is 2. Bupivacaine is more cardiotoxic. Treatment is supportive therapy, lipid immersion 20%, and seizure management. Prevention is better than cure. Pre, intra, and post procedure precaution and monitoring to be done. Loss should be recognized and managed first. Loss is rare but may be fatal, and I hope, I pray, loss should not last. It should not last with anyone to anyone. On a lighter note,
Thank you so much,
thank
sir.
you, Dhanyavad, Shukriya.
Thank you so much,
Thank you very
sir.
much.
That was a great lecture, and it was fruitful to all the PG students, all of us here. Thank you, Dr. Ruchi ma'am.
Yeah, I'd just like to thank sir personally. Sir, that was such an intense and in-depth deliberation on a very dreaded complication that nobody would like to face as an anesthesiologist. And you have done such a lucid talk on it, that how to face it, how to minimize the risk. And it is going to be very, very useful to not just us, to the budding anesthesiologists of tomorrow. Thank you so very much, sir.
Thank you. Thank you.
Thank you, sir. Thank you, ma'am, for joining us. Now we'll move on to our next session. The chairpersons are respected Dr. G.P. Dureja, sir, and Dr. Rupesh Jain, sir. And the speaker for today is Dr. Kailash Kothari, sir, vertebral augmentation. First of all, we'll introduce Dr. G.P. Dureja, sir. G.P. Dureja. Professor Dr. G.P. Dureja, he is currently Director Professor in Delhi Pain Management Center, New Delhi, 6 pain centers in Delhi and NCR. And he has also been Professor in AIIMS, New Delhi. And he has approximately 217 publications and chapters in books. And number of books written, he has written 7 books. And he's having areas of interest in advanced interventions in neuropathic pain. Thank you, sir. Our next chairperson is Dr. Rupesh Jain, sir. Dr. Rupesh Jain is a course director, Dr. Rupesh Jain, course director fellowship in pain management by Global Pain School. He is a specialist board member for DNB Palliative Medicine, faculty for Asia Pacific Hospice and Palliative Care Network Singapore for CTC program, professor in charge of pain clinic, LN Medical College Bhopal, director care and cure hospital Mandivi, and director Penisha Total Pain Relief Clinic. Thank you, sir, for being the chairperson today for the session. And now we'll introduce Dr. Kailash Kothari, sir. Dr. Kailash Kothari, MD, FIA, PM. He is the president of Indian Society for the Study of Pain, past editor-in-chief in Indian Journal of Pain 2016 to 19, executive committee member, ISSP, secretary, ISSP Mumbai branch, KM Hospital, Jagjeevan Ram Hospital, Fortis Global Apollo. He has published many articles in national and international journals of pain orthopedics, director of fellowship in pain management, organized many conferences and workshops on pain and anesthesia, and he's invited faculty at more than 200 national and international conferences and workshops. Let's start with the lecture. Thank you, everyone.
Hello, thank you for inviting me here. Thank you for having me here. I thank organizing committee of Mpisacon, and it is my pleasure to be here. And on behalf of Indian Society for Study of Pain, as a president of Indian Society, I am very much thankful to include pain management topic here in anesthesia conference. Percutaneous vertebroplasty and kyphoplasty. This is one of the very advanced procedure in pain management, but it is very much, you can say, very rewarding procedure as far as pain relief for the patient is concerned. So in vertebral compression fracture, we have very limited options. One is medical management, like managing the osteoporosis, managing the pain with pain medications like opioids, NSAIDs, and other things. Open surgical management, in some cases where compression of spinal cord is happening and patient is developing motor and sensory weakness. Minimally invasive surgical management like vertebroplasty, which stabilizes the fracture, and we use a bone cement for that. Kyphoplasty, we use a balloon to create a cavity and then inject a cement, which reduces the fracture and improves the height of the fracture. So these are the few techniques which we have. I am going to talk mainly on minimally invasive surgical management. So we have various methods by which non-surgical management can be done. Cements and needle, vertebroplasty kits are there, balloon kyphoplasty, which we are going to talk about. Then there are a few more advanced things like curved needle, biologics, expandable implants, etc. That is beyond the scope of this lecture. Vertebral augmentation is technique for treatment of painful compression fracture of the spine. Patient selection is very important, and we have to work them up very well before we do any procedure. We have to identify the painful level. We have to define the fracture configuration, how the fracture is, whether it is connecting to the posterior wall of the body of vertebra, whether some fragment is actually going in the canal, whether it is compressing the spinal cord, what is the fracture age, whether it is old, new, or old fracture still having some non-union osteoporotic fracture or malignant fracture. What is it? We have to do certain investigation. Most common for osteoporosis is DEXA scan. We have to find out whether the patient is suffering from any myeloma or lymphoma, osteomyelitis, because these are very important diagnostic criteria. When do you treat? So when you take MRI, you will find that there's some fracture, and if you don't take stir image, you might not know whether it is active fracture or not non-active fracture. In stir image, you can see edematous end plate, which can tell you that this is painful fracture and you have to treat it. On X-ray, you can see serial X-rays on different at different time gap, whether the fracture size is increasing, the deformity is progressing. So you can see 31st August, it is 16 degree, it is 25 degree on September 3rd. You need to treat it, otherwise he will have a lot of kyphosis. So contraindications are asymptomatic fracture, improvement with medical therapy, prophylaxis in osteoporotic fracture should not be done. If any infection is suspected, don't do it. Retropulsion of the vertebral body or tumor in the canal, don't do it. Uncorrectable coagulopathy, don't do it. This is an example of metastatic disease with a tumor invading the spinal canal, compressing the cord. Here you cannot inject cement or anything, do anything. This is going to be catastrophic for the patient. We will have paraplegia. Some relative contraindication are significant compromise of the spinal canal, back pain, or known fracture for greater than 1 year, unless chronic non-union is present. If chronic non-union is there, you need to do it to fix it so that patient is relieved of his pain. Vertebral body collapse more than 90 degree or 90% or greater. Radiculopathy in excess of back pain due to herniated disc should not be treated with vertebroplasty. Unstable burst fracture should not be treated with vertebroplasty, and asymptomatic tumor extension into spinal canal. So apart from simple vertebroplasty, where we put a needle and put a cement, we have treatment called balloon kyphoplasty. It was first developed by an orthopedic surgeon, and first case was performed in 1998. Not very old technique, it's a newer technique, but very effective. Primarily used to treat osteoporotic fracture. Now people are using for burst fracture, post-traumatic fracture, etc. And basically we need to do anatomical reduction of the fracture, stabilize the fracture, and control the pain. What is vertebral augmentation? A procedure to correct kyphosis, relieve the pain, restore stability, and treat the osteoporotic and osteolytic vertebral compression fracture. So this is, you can see the compression of the end plate. One end plate is good, but superior end plate is actually compressing, and there's a fracture line inside. You put a needle, either inject cement or put a balloon, and then inject a saline. Inject the cement. There are different injectable materials which are present. One is polymethyl methyl acrylate, which is high viscosity cement, and some cements are RF cured PMMA. What we use normally is high viscosity cement. There are some other biologic cements or materials are also there. We don't have it in India. What we need for vertebroplasty is a bone biopsy needle, which is a diamond cut tip, diamond tip, and this is one of the commonest used needle, which is Cook bone biopsy needle, what I like it. And there's a balloon temp or kyphon by Medtronics, which is used for kyphoplasty, which has a balloon. We have, after putting the needle in the body, we inflate the balloon using this pressure transducer, and then we create a cavity and inject the cement. So balloon assisted vertebroplasty, it is percutaneous, it restores the height, it creates the void, and it helps in low pressure fill of the cement. As against percutaneous vertebroplasty, where we put a needle, we directly inject the cement, which is in semi-liquid state, but we need a lot of pressure to inject it, and sometimes we need high pressure filling. Not sometimes, but always we need high pressure filling compared to kyphoplasty, where we create a void which creates a low pressure area, and we can inject cement with a low pressure. So let's see what are the steps of kyphoplasty as well as vertebroplasty. So we have to put a cannula inside up to the posterior cortex in the fracture vertebral body and the posterior aspect. Once we put cannula here, we have to pass a inflatable bone tamp inside the fracture vertebral body, and the tip usually goes almost up to the anterior part of the body of vertebra. Then balloon is inflated, slowly elevating the end plates and restoring the vertebral body height. The balloon is inflated, and you have to see that balloon is reaching the end plate. Once it reaches the end plate, you stop it. You should not go beyond it, and keep the balloon inflated for a few seconds, 8 to 10 seconds. And then you deflate slowly and withdraw the balloon, and which leaves the cavity within the vertebral body, which is a place where cement can be injected very easily. So this void which is created is filled with surgeon's choice of material, which may be a high viscosity cement or any other cement which is so basically what we create is internal cast to fix the fracture. So kyphoplasty advantages: analgesia, mobility, vertebral body stability, deformity correction, and there are very few leaks compared to vertebroplasty, where the leaks are more. Balloon assisted vertebral augmentation has some issues. So we are not sure mainly about indication, whether it is more of a pain which is indication or deformity should be indication. Timing, it should be best done within 8 weeks of fracture. Biomechanics and method of reductions are very important. How many levels we can treat is issue, because the balloons and the cost of the kit is very high. Patient diagnosis, whether it is osteoporosis tumor, everywhere we cannot use it. There are various void fillers are there, which is best, we don't know. And complication like fat emboli and polymethyl methyl acrylate monomer reaction can be there. So there are a few x-rays. 84-year female, low back pain. You can see a fracture at L1. You can see this without any specific incidence. If you don't treat it at this stage, what is happening is 3 weeks later, you can see this is hardly any bone left here, 80% height reduction. 84-year-old hyperextension view is this little bit increase. So surgical technique, you need to have a proper setup. All the things are set up in proper way. Cement is ready with the contrast. Mixed cement should be there. We have to use C-arm in AP and lateral view. We have to, while we are putting the needles, and we place contralateral both sides. We use balloon, increase the volume in both the side, 0.25 to 0.5 cc increment. Both the balloon are increased in increments, and assess the TAM size and position in lateral and AP view till it is touching the superior end plate. That's the end point. Or you are not you are getting some resistance to inflate the balloon. Sequentially inflate until inflation endpoint is reached. Then we have to inject. Once you deflate and remove the balloon, you inject the cement until 5 to 10 mm of posterior cortex is remaining. So don't go in, the cement should not go in posterior 5 to 10 millimeter of the cortex. Adequate vertebral fill should be assessed properly under lateral fluoroscopy and repeat on the contralateral side. So it gives excellent restoration of the vertebral height. So we use a transpedicular or extrapedicular approach. So we can decide the direction in which the needle goes before we enter the cortex. So we have in kyphoplasty introducer, and then we have to use either osteotome or balloon. So potential complication include minor or transient and permanent, which is less than 1%. So it is good. The complication rate is really low. In my career of 20 years of pain practice, I have not come across a single patient who had very severe or dreaded complication. If you are careful, you will not have complication. You have to use live fluoroscopy, should not be relaxed while injecting the cement, and make sure that the cement is not leaking out. Sometime after taking all precautions, still 1% patient can have some complication, which can be dangerous. But most of the complications are minor. Hemorrhage, post-procedural fever, infection, transient pain, cement embolization of the lung, rib or posterior element fracture, nerve root irritation or injury, pneumothorax. These are the few of the complications which can be managed post-operatively. Permanent is requiring decompression surgery because the cement is extruded. Fracture, you have fractured the pedicle medial border and enter the canal. You need decompression urgent. Repair of the dural tear if accidental tear has happened. If infection is causing some abscess in the spinal canal, you need to treat it by opening it. Pulmonary embolism and death are most dreaded complications. And this is a YouTube video for you. This will give you idea about vertebroplasty, a simple vertebroplasty technique. This is a fracture, recent fracture. There's a marrow edema at L1. D11 fracture is old one. So what we are doing in AP and oblique view, we are identifying the pedicle, and on superior lateral aspect of the pedicle, we are putting the needle. You can see the on X-ray, the vertebral body is so osteoporotic, it is very difficult to see. But if you see it properly, you can identify the borders of the vertebral body, and then using a Cook vertebroplasty needle, you can actually insert your needle in the center of the pedicle. Then once you are on the pedicle, make sure you are hitting the bone, and then do a simple screw movement, create some groove and fix the needle. Don't go too much inside. Once you are in view of C-arm to lateral view, and see what is your trajectory, whether it is going in the area where you desire. In osteoporotic fracture, the needle goes like a knife going in the butter. So we change the direction of C-arm to lateral view to know what is the trajectory of the needle. You can see here, it is somewhere here, we are going in the center. That's good. So once you go in, we keep checking where we are going, keep saving the images. In lateral view, you are in the posterior, your posterior cortex. Once it is hard to counter the posterior cortex. Once you cross the posterior cortex, the body of vertebra is very easy to enter into. So you have to go very slow with the limited pressure. Change the view to AP to confirm whether you have reached the middle part of the body of vertebra. Once you reach the anterior border of the body of vertebra in lateral, change it to anterior and see where your needle tip is. You can see it's the anterior border, already almost reached. Once you are there, then you keep all the 2cc syringes ready. Your cement with contrast is prepared, and till it becomes consistency of paste, you put this cement in the syringes, and under live fluoroscopy we inject it. So we put cement first in the larger, bigger syringe, and through that syringe we fill the smaller syringes. These syringes are lever locked, so there is no spill of the syringe when we are exerting a lot of pressure. Once you fill the smaller syringes, next step is to inject it. So inject under live fluoroscopy and look for constant leak. So you have to go very slowly. The speed at which I am showing the video is 1.5. You can see here the cement is filled. So you should not see the cement leaking in the posterior aspect of the body of vertebra. So filling nicely up to the middle of the body of vertebra. And in AP, you can see the cement is filled properly. And once you are satisfied, then you can just remove the needle. While removing the needle, you have to put a stellate inside under live fluoroscopy. And in AP view and lateral, you confirm and then remove it. Okay, once you remove it, that's all. The procedure is done. Usually, patient gets instant relief of his pain. So conclusion: vertebral compression fracture occur more than hip and wrist fractures combined. Vertebroplasty and vertebral augmentation are treatment option associated with low complication rate for patients suffering from painful vertebral compression fracture. Vertebral augmentation procedures can provide fracture stabilization and correction of spinal deformity. Patients experience significant reduction in pain and improvement in mobility, thus increasing overall quality of life. So I hope you get a good take-home message that Some techniques like vertebroplasty looks very advanced, but if you learn it properly, easy to do and very rewarding. With that, thank you very much and thanks for having me here. Thanks for inviting me. Thank you. I'll be happy to answer any questions if you have. Thank you.
Thank you so much, sir. It was a great lecture, an amazing lecture. And thank you for sharing your precious time with us, sir. To the question and answer, after the second speaker, we'll continue with question and answer. Our next speaker is Dr. Jaideep Singh, sir, and the topic is pain management training as per young anesthesiologist.
Yeah, Dr. Neha?
Yes, sir. Yes, sir. Yes, sir. I can connect to you now. Dr. Jaideep Singh. Dr. Jaideep Singh is, I'm so honored to introduce him as he is my teacher also. I have studied my post-graduation under his guidance. He is DA, DNB, FIPM, FIAPM, MISS, MNDMS, and a present designation is Associate Professor, Department of Anesthesiology, GMC Bhopal. He is executive member of ISA MP State, Vice President of ISA Bhopal City Branch, Secretary ISSP Bhopal City Branch, and he has received many awards like National Level Medical Excellence Award for Outstanding Achievement and Remarkable Role in the Field of Medical by Indian Solidarity Council, National Level Alok Kumar Saxena Award for Original Research on Chronic Neuropathic Pain Management, and Dr. M.T. Bhatia Gold Medal Award for Pain Management in MP. He organized and conducted various national and state level conferences and workshops in chronic pain management. And he has done 1 year fellowship in pain medicine, fellowship training in spine and interventional pain management from Banaras Hindu University, and he is specially trained for specialist lumbar spine surgery for back pain at Mission Spine Hospital. Thank you, sir, for joining us. We are playing the pre-recorded session of Dr. Jaideep Singh, sir. Let's start with the session.
Hello, greetings from Bhopal, the city of lakes. I am Dr. Jaideep Singh, Associate Professor in Department of Anesthesiology, Gandhi Medical College, Bhopal. Today here I am presenting my topic, which is the training about the chronic pain management among the young anesthetists. As we everybody knows, it's a new emerging branch. It's a part of anesthesia. So let's begin with the presentation. Pain itself means poena. The pain is more terrible for Lord of mankind than even death itself. According to IASP, International Association of Study of Pain, the pain is any unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. It's having major three components like motor research reactions, emotional reactions, and autonomic reactions. Pain can be appears in any of the ways. Patient can present in different ways. So we have to identify how to predict the exact cause of the pain and their different presentations. Chronic pain is a massive economical and social problem. This is the reason for nowadays pain is considered as a separate entity, separate specialty for managing chronic pain. I begin my presentation with greetings towards father of pain medicine. This is Dr. John Boinka. As far as history is concerned, during World War II, Bonica and Alexander set up first pain clinic in US in 1946, while in India, Indian Society of Study of Pain formed in Varanasi by Dr. Veer Rastogi and Pramod Kumar sir in 1984. According to MCI, pain management moved from post-operative pain management to chronic cancer and non-cancer pain management. Pain medicine should be justified as a specialty, with its subspecialties being divided into acute pain, chronic spinal pain, and cancer pain. IASP did a survey in 2007 which mentioned that biggest limitation factor for pain management has been a lack of pain education, inadequate training in pain management for undergraduates. Less than half doctors are trained in these sections in most of the countries. 91% said lack of training is the main barrier about the pain management and about the anesthesiologists who are trying to make their career in the management of chronic pain. There are few challenges and hurdles like lack of awareness of this specialty among the patients and medical fraternity. Policymakers don't pursue the need of the hour, acute shortage of the faculty, difficulty in reaching public and professional at remote locations, and economical challenges. Chronic pain is a global health problem, so the concept of chronic pain management and pain clinics are need of the hour. Chronic pain affects as many as 1 in 5 people, causing significant cost to individuals, families, and caregivers, but also to the health system. Public awareness, the dire necessity of today's era is public awareness for chronic pain, centers for treatment, patients organization for information and support, and training in chronic pain assessment and management during their undergraduate and post-graduation duration, which required some special endeavors like dedicated awareness programs, TV and press release, public exhibitions, equipped classroom with more active learning for undergraduates and postgraduates, and teaching should be involved lots of the collaboration models. Immense potential of technology is redefining pain education world over, like e-classrooms, e-books, e-learning, e-journals, e-library, and new gadgets should add it. E-learning program launched by Udemy on the principle of pain management by ISSP in 2013. Right now, they have more than 3,800 students all over the globe. The state of art simulators can make a difference in practicing clinical skills where compared to the real-time patients. Uncomfortable situation can be avoided with the help of the simulators. Human Rights Watch in 2011 reports emphasis on the need of the pain and palliative case educations. MCI has made compulsory demonstration of following abilities in the acute and chronic pain management, practice of acute pain, cancer pain guidelines and WHO treatment ladder patterns, and practice of different modalities of chronic pain management with the help of physical therapy, psychotherapy, neuroablation, neuroaugmentation, spinal opioids, intervertebral neural blockade, and non-opioid analgesic. We are going to discuss each and every points in the coming presentation. Principle of pain management in special patients like elderly patients, children, disabled patients, and intellectually handicapped patients unable to communicate is having a special consideration during the chronic pain management. Awareness of the basic principles of palliative care is the foremost milestone. The time has come to formation of the uniform, high-quality, standardized, multidisciplinary pain education and training frameworks, which would include healthcare providers from the grassroots level to specialized the consultants. Right now, ISSP, which is Indian Society of Study of Pain, is doing wonderful job and established a academic cell, which is mentioned as Indian Academy of Pain Medicine, for standardized practice of chronic pain all over the India. Still, the availability of the pain and palliative care in undergraduate medical curriculum and postgraduate training in palliative care is sparse in India. Though now few centers are coming up, like centers for 1-year fellowship and certificate courses is available at BHU, SGPGI, and different AIMS all over the India. AIMS Rishikesh is recently started DM course in pain and palliative medicine and DM course in onco anesthesia and palliative care from January 2016 session with specialized training in pain management and palliative care. The pain medicine should be justified as super specialty with its subspecialty as we discussed previously. It can be broadly divided into acute pain, chronic spinal pain, and cancer pain. And eligibility criteria should be broadened with the involvement of other medical specialists to harness wide knowledge and for multidisciplinary pain educations, which can include orthopedician, neurophysician, neurosurgeon, psychiatrist, and some sort of rehabilitation physiotherapy. International pain management should be considered with any pain condition. Pain is the most effectively treatment with the multidisciplinary approach. We should utilize all the resources that are available for managing chronic pain of a patient. It's a WHO letter pattern which is clearly mentioned that we can start with the step 1 with the use of opioids and adjuvant. Then after this we can move towards the opioids, and as a fourth step we can move towards the interventions procedures for managing chronic pain. He's Dr. Prithviraj, who's also mentioned as a father of interventional pain medicine. So come to the modern pain clinic. Emergence of the new breed of specialist called interventional pain specialist who rely on evidence-based practice, mandatory use of the fluoroscope or USG for accuracy of the nerve blocks, not based on the anatomical landmarks as previously we are doing. To ensure accuracy, use non-ionic radiopaque dye, use of the implants like spinal cord stimulators and intrathecal implant pumps for chronic pain management. There is short definition which is mentioned the use of the invasive techniques to decrease or eliminate the pain. This is broadly divided into four categories. It's interrupting the pain signals along a neural pathway, minimally invasive procedures, neuro augmentation with the help of spinal cord stimulators and peripheral nerve stimulators, and implantable drug delivery systems. This is the commonly used technique in which we, in a single spine, we are using different landmarks, and at different source of the pain, we are using a needle. Either it's a diagnostic block with the help of local anesthetic and steroids, or can be a therapeutic block with the help of the radiofrequency ablations and using of the radiofrequency generator. Trigger point injections, epidural injections, facet joint injection, and sympathetic chains are the four most commonly used pain intervention procedures which is applied all over the world for managing chronic pain, and it is commonly used worldwide. Injection therapy is usually performed utilizing the fluoroscope, can be therapeutic or diagnostic. Injection therapy is also effective in both the acute as well as chronic presentations. Injection of local anesthetic with or without steroid can be used as a diagnostic block. Epidural injections, as we all as anesthetists perform epidural injections for giving anesthesia, but in chronic pain there is slightly difference between the epidural which we give for the anesthesia purpose. Injection performed to deposit the medications into epidural space in proximity to the spinal nerves, most effective for radicular pain into the arms and legs, and should be performed with the help of the fluoroscope. There are three common approaches for any kind of epidural blocks, like interlaminar approach, which we are very familiar as an anesthetist. Other are the transfemoral approach and caudal approach. Indications for epidurals are like herniated disc, spinal stenosis, spondylolysis, post-laminectomy syndromes, diabetic neuropathy, and post-herpetic neuralgia. In few of the cases of RSD, or we are commonly named as a complex regional pain syndrome, epidural injections are doing wonderful job. So come on the pathophysiology and some pharmacological part, how steroid injections is work. When the spinal nerve is inflamed, it's become edematous. As it travels to the neuroforamina, as we are seeing here, as it's moved from the neuroforamina, it becomes pinched, which maintain the inflammation. After the steroid injection, they reduce the inflammation and decrease the diameter of the nerves, giving it more room for the foramen. Median branch nerve blocks are also mentioned as the radiofrequency lesioning, which is a gold standard treatment for any kind of facetal pain or any kind of back pain or any axial pain. If the cause is of the facet, then radiofrequency ablation is a gold standard. The median branch nerves derives from the corresponding spinal nerves, transmitting sensory information from each joint. Radiofrequency ablation or neurotomy is performed using a specialized machine to produce a radio wave to burn a specific nerve, blocking the transmission of the painful impulses. Condition that may have a facet component. Patient can present with the complaint of headache, neck pain, mid or upper back pain, post-fusion neck or back pain, even after the spine surgery. Sympathetic blocks. These blocks are performed when the pain is of neuropathic origin with the sympathetic component. The blocks interrupt the nerve transmission in a large area of the body. They are performed as gangliomas. As we know, the ganglion is basically covering the broader spectrum of the sensory pathway. So, if there is more than one dermatome which is involved for carrying the pain, we should go for the sympathectomies with the help of the ganglion. It can also be performed with the help of CT scan or fluoroscope. The commonly used ganglionic blocks are stellate ganglion block, which is used for the upper extremities as well as post-herpetic neuralgias and complex regional pain syndrome. Celiac plexus blocks is usually used for the pathology of the abdomen, and lumbar paravertebral sympathetic blocks is usually used for neuropathic pain of lower extremities. These are the few advanced minimal invasive pain procedures which is nowadays very commonly performed by any trained or any specialist pain physician all over the India, and it's really wonderful for giving pain relief without open spine surgery or open massive surgery. We can conserve the patients for the benefit of the financial as well as physical part. Minimal invasive procedures like vertebroplasty, which is very well explained with Dr. Kailash Kothari sir. Kyphoplasty, it's a slightly advanced procedure as compared to the vertebroplasty, in which we are putting a small balloon inside the vertebra and inflate it just like a foam. And after inflation, when the vertebra is getting its height, after getting the height, we are putting a specialized kyphoplasty cement, which is giving strengthening from the inside of the vertebra, and the further collapsing of the vertebra is avoided, and patient can get the equal results or equal benefits as compared to the fusion spine surgeries without any major blood loss, without any major incision, or without any risk of the like general anesthesia risk. Another commonly used procedures are ozone discectomy, which is doing in the content hydrated disc, in which we are putting a small needle with the help of the fluoroscope, and after putting the needle inside the nucleus pulposus, we are putting the ozone gas so that it shrinks the disc. It is very helpful in the bulge disc and in the acute patients. The another advanced procedures is the transforaminal discectomy, in which we are putting a foramen scope inside the foramen and just debulk the disc, which is directly causing compression over the nerve roots. Even there is few more advanced procedures like PSLD, which is mentioned as the used for the shaving of the lamina, which is useful for the patient who are suffering from the canal stenosis because of the hypertrophy of canal or because of the ligamentum flavum hypertrophy. Few things about the neuro augmentations. Spinal cord stimulators and peripheral nerve stimulators are the technologies that are available for the patient who have not responded for any of the modalities which we discussed previously. They require the implantation of the lead and battery generator. It's in the spinal cord, leads are placed inside the epidural space, and in peripheral nerve stimulator, leads are placed in the subcutaneous tissue, and it's worked on the principle on which the pacemaker is working. It's gate theory. It's giving a slow stimulation of the current. In that way, so with the help of gate theory, patient is relieved from the pain. It's the picture of a spinal cord stimulator. A spinal cord stimulator works by having a low voltage electrical stimulation to block the pain transmission via the dorsal column tract of a spinal cord, and it can be utilized for cervical, thoracic, and lumbar symptoms. more effective for extremely than truncal symptoms. Similarly, PNS is utilized to provide pain relief over a peripheral nerve distribution. The leads are placed along the course of the peripheral nerve, may be effective for occipital headaches, inguinal neuralgias, and intercostal neuralgias. Intrathecal therapy is a wonderful therapy. This is used when there's all the modalities is failed. We are medications required have produced intolerable side effects, or patient who cannot achieve adequate pain control even with the high dose of the opioid. In this, we are putting an implant infusion delivery system that delivers a precise amount of medication into the spinal fluid via infusion pump or a catheter. The most commonly used drugs are the baclofen and morphine for the pain management in these kind of patients. Here I like to close my session. Session is now open for any kind of question. You are most welcome. Thank you so much.
Thank you so much, sir. That was a very wonderful lecture, sir. And thank you for giving us your precious time and imparting your knowledge to us. Now we proceed to the question answer session. If any, and the session is handed over to chairpersons. If any queries.
Good afternoon, everyone.
Good afternoon, sir.
I think Dr. Kailash Kothari and Dr. Jaideep has presented their presentation very nicely. And I want to mention that vertebral augmentation is one of the few procedures in pain medicine that have the therapeutic response, and that is on the table. And I would like to mention that we should not forget the contribution of Dr. G.P. Dureja sir and Dr. Gautam Das sir as far as the development of pain medicine in India is concerned. And they did a tremendous job to establish this branch in this country. And there are lots of other fellowship which are 1-year fellowship and university recognized, like Global Pain School Fellowship, which is and Mumbai Pain School Fellowship, and other specialized fellowship which is conducted by Dr. Kailash Kothari, Dr. G.P. Dureja sir, and Dr. Gautam Das sir. They are also doing wonderful job for training these young pain physicians in this country. And I am proud to say that Dr. Jaideep is also fellow of Global Pain School. And I think the development of pain medicine, the all credit goes to Dr. G.P. Dureja sir and Dr. Gautam Das sir for this country. Thank you.
Thank you, Dr. Rupesh, sir. Now we'll proceed to our next session. The chairpersons for the next sessions are Dr. Meena Singh ma'am, Dr. Ranjita Aske ma'am, and Dr. Sonal Awasthi ma'am. And the first speaker will be Dr. Deepti Saxena ma'am. We'll introduce our CV. First of all, Dr. Meena Singh ma'am. Dr. Meena Singh, she has done MBBS and MD anesthesiology, and she is currently working as Associate Professor Neuroanesthesia in Super Speciality Hospital in SCD Medical College, Jabalpur. Thank you, ma'am, for joining us. And our next chairperson is Dr. Meena Singh, Dr. Ranjita Aske ma'am. She is Associate Professor, GMC Ratlam, MP, and she has done MBBS from GMC Bhopal and MD from GMC Bhopal, and she was Assistant Professor in GMC Bhopal from 2012 to 2018 and Associate Professor in GMC Ratlam from 18 to till date, and she has published 10 research publications in international and national journals. Our next chairperson is Dr. Sonal Awasthi ma'am. Dr. Sonal Awasthi ma'am is Associate Professor, Gandhi Medical College, Bhopal, and she has done MBBS in 2008 from GMC Bhopal, and she has done MD Anesthesia in 2011 from GMC Bhopal, and she's currently working as Associate Professor in Department of Anesthesia, and she's currently Executive Member of ISA City Branch, Bhopal. Now the lecture is by Dr. Deepti Saxena ma'am, ketamine as psychiatric drugs, and her CV. Dr. Deepti Saxena, she is a professor and head of department in Department of Anesthesiology and Critical Care at Sri Aurobindo Medical College and Post-Graduation Institute, Indore. She has a teaching experience of almost 12 years, and she was associate professor and professor in Department of Anesthesiology and Critical Care at Sri Aurobindo Institute of Medical Sciences, August 2012 to August 2017. And she was assistant professor in Department of Anesthesiology at St. GS Medical College in KM Hospital, Mumbai for 3 years and 7 months. And she served as assistant professor in Department of Anesthesiology at Index Medical College Hospital for 1 year and 9 months. She was senior registrar in Intensive and Critical Care Unit at Bombay Hospital, Indore in 2006, and guest faculty at various conferences at state and national level. And she's having total 14 publications in various national and international journals. Thank you all of you for joining us. And we'll start the lecture with Dr. Deepti Saxena ma'am. We'll start the pre-recorded session. And the question and answer will be done after the third speaker.
Very good afternoon, one and all. At the very outset, I would like to thank the organizers for giving me this opportunity to talk on this immense platform. My talk involves a very popular anesthetic drug ketamine, but in a very unusual setting, that is in psychiatric disorders. I would be concentrating on the evolution of ketamine as antidepressant rather than delving into its anesthetic effects. It is said that history does not burden the mind, but it definitely illuminates the soul. So I would like to take you down the memory lane. History of ketamine is very pertinent to understand its antidepressant effects. History of ketamine begins in the 1950s at Park Davis Company laboratories in Detroit, Michigan, USA. These are the very premises which belongs to former Park Davis Research Laboratory on Detroit River, now in use as a hotel. So in these very premises, research was going on for an ideal anesthetic agent with analgesic properties. In 1956, Maddox synthesized phencyclidine or PCP. Animal studies were conducted by Dr. Shen and Dr. Domino, which proved its potent analgesic effect with the cataleptic state with eyes open and poor quality muscle relaxation. Human studies were performed under the trade name Cernel. Phencyclidine was considered as the most potent general analgesic agent which had been used in clinical medicine at that time. Its unique advantages were that it caused no depression of cardiovascular and respiratory function. However, its usefulness was limited by the excitation and psychotic reactions which sometimes persisted for more than 12 hours after a single dose. With growing clinical knowledge, phencyclidine was not found suitable for human anesthesia. However, research continued. So in 1962, by Calvin Stevens, a compound was synthesized which produced excellent anesthesia and was short-acting. It was actually a structural analog at 1/10 the potency of its parent drug phencyclidine. It was a ketone together with an amine, hence named ketamine. The first human administration of ketamine was conducted by Dr. Corson, who was the anesthesiologist at Michigan Medical School, and Dr. Edward Domino, who was the pharmacologist, in 1964 on volunteer prisoners at the Jackson prison in the state of Michigan. Now, I have posted the pictures of these two pioneers. They are the real heroes. That is Dr. Gwynter Corson, who was the anesthesiologist, and Dr. Edward Domino. Dr. Edward Domino is still an active member of Michigan Medical School as emeritus professor, although he is in his 90s. He will be reappearing in my talk later on. So Dr. Corson and Dr. Domino observed that patients described their feeling as floating in outer space under the influence of ketamine and having no feelings in the limb with incidence of adverse effects 1 in 3. Domino et al. Published the first clinical studies in 1965. At the time of publication, they were searching for some appropriate term to describe the effects of ketamine. They came up with the term schizophrenomimetic, which was immediately discarded as it would have nipped in the bud the future of the new molecule. Then they coined the term dreaming to describe the peculiar anesthetic state, when fortunately Domino spoke to his wife Tony of the fact that patients seemed to be disconnected. She suggested the term dissociative anesthetic. So was ketamine finally characterized. So friends, it is very important to listen to people around you, especially your spouse. You may create history. In the 1970s, the psychoactive side effects of ketamine were desirable in psychiatric investigation, where the drug was used as an abreactive agent. So ketamine began its journey as psychiatric drug in the form of an abreactive agent. What is abreaction? It is actually defined as the expression and consequent release of a previously repressed emotion achieved through reliving the experience that caused it. So mostly this reliving is done by using a drug or hypnosis. In 1970s, the Vietnam War was fully on and ketamine was being given as anesthetic to the wounded soldiers. So ketamine abuse was also very high at that time. It was found that at lower doses, stimulant effects predominated, which were perceived as euphoria and mild dissociation, with distortion of time and space, known as K-land effect. In higher doses, the immobilizing and hallucinogenic effects, similar to severe schizophrenia, were noted, which is known as the K-hole effect. The psychoactive effects usually resolve in approximately 2 hours after acute ketamine use. However, long-term use can cause more pronounced and persistent neuropsychiatric symptoms, including schizophrenia-like symptoms, cognitive impairment, and poor psychological well-being. The introduction of ketamine in Britain in late 1969 had been described as a disaster from which the drug never recovered, because hallucinations were considered so unpleasant that patient acceptance was much lower than with the barbiturates. So ketamine did not begin its journey as a very auspicious drug. However, in 1980s, Colin Rich discovered that activation of the glutamate N-methyl D-aspartate calcium channel, that is NMDA receptor, was responsible for induction of synaptic plasticity. It became clear that memory, thinking, and consciousness were the result of synaptic plasticity and fine-tuning of glutamatergic influences via NMDA receptor-mediated phenomena. 1980s was also the decade when forays into understanding mental disorders were made. For many years, the dopamine hypothesis prevailed to explain the symptoms associated with schizophrenia. In 1980, glutamate hypofunction hypothesis of schizophrenia arose from reports of low CSF glutamate levels in patients with schizophrenia. Now we know that synergy between the two pathways best explains the positive, negative, and cognitive symptoms of the disease. Discovery of NMDA receptor and its non-competitive inhibition by ketamine was first observed by David Lodge's team in early 1980s, which prompted large advances in the pathophysiology of hyperalgesia, schizophrenia, and mental functioning. So ketamine's possible antidepressant properties were actually described in 1973, some 8 years after its synthesis. However, the first clinical trial reporting antidepressant actions of ketamine was published in 2000, some 35 years later, where ketamine was administered intravenously at the subanesthetic dose of 0.5 mg per kg. The discovery of antidepressive action of ketamine has been described as the single most important advance in the treatment of depression in over 50 years. Now, as I was researching for this topic, I came across an interview of Dr. Edward Domino. At that time, that is in 1960s, he was actually treating a lot of abusers, drug abusers. And he was describing his experiences in treating them. I simply could not omit what he said in that interview. I am simply repeating it verbatim. He says, years ago, Many young people were getting high from the dissociative effect of low-dose ketamine. I remember a few different patients, but one woman I will never forget. She was a young and beautiful lady who had become a ketamine abuser. She was using ketamine every couple of weeks. The psychiatrist that referred her to me asked if I could advise him on how to properly treat the patient. I met with her and went through the history of how much ketamine she was using. She was not using too much ketamine and not too often either. Every couple of weeks, she used the standard dose that will produce a high. So I said to her, "Why are you involved with this kind of funny business with ketamine?" She said, "Oh, doctor, I'm so depressed." I said, "Well, what about some of the drugs that we have for depression?" She said, "Well, the psychiatrist put me on different antidepressants and nothing worked. Somehow I'm resistant and I have a terrible depression. But you know, I got high once on ketamine and after that I was no longer depressed for about a week or two." I said, "What? You mean you're taking ketamine because you're depressed?" She responded, "Doctor, I'm so depressed, I will take anything that works." I said, "Well, this obviously is not good for you in the long run. You can't get high to have an antidepressant effect. This is not a good combination." Well, this is what Dr. Edward Domino says. If only I had listened to that patient, the antidepressant effects of ketamine would have been discovered 35 years earlier. So friends, always listen to your patients. Listening is important. Now we have discussed the evolution of ketamine in psychiatric disorders. Let us brush up our psychiatric knowledge. What is major depressive disorder? It is a medical condition that includes abnormalities of affect in mood, neurovegetative functions like appetite and sleep disturbances, cognition like inappropriate guilt and feelings of worthlessness, and psychomotor activity like agitation or retardation. When it occurs along with episodes of mania, it is termed as bipolar disorder. A substantial proportion of patients experience their first episodes of MDD during childhood and adolescence, so it is no longer a disease of adults. Now, treatment-resistant depression, it is actually a failure to respond to 2 or more antidepressant trials given at an adequate dose for 6 to 8 weeks during a major depressive episode. This is what is known as treatment-resistant depression or TRD. Its pathophysiology is actually multifactorial, treatment very challenging. Current antidepressant medications work by modulating the monoaminergic systems and takes several weeks to establish a clinical response. It is here where ketamine shines. Now, many hypotheses have been put forward regarding ketamine's mechanism of action as an antidepressant, and most of them presume an essential role of inhibition of the NMDA receptor. I won't go into the detail of all these hypotheses. I will be describing them in brief. The first hypothesis is disinhibition hypothesis, which says that selective blockade of NMDA receptor expressed on GABAergic inhibitory interneurons lead to a disinhibition of pyramidal neurons, hence its antidepressant action. Second hypothesis says that inhibition of extrasynaptic NMDA receptors, which are tonically activated by low levels of ambient glutamate, results in antidepressant effect. Third theory says that blockade of spontaneous NMDA receptor results in the inhibition of the eukaryotic elongation factor 2 kinase that prevents phosphorylation. The fourth and the last hypothesis is the only one that does not have an NMDA receptor inhibition dependency. It states that the antidepressant action of ketamine is via the action of its metabolite, hydroxynorketamine. Ketamine, as we all know, is metabolized by cytochrome P450 liver enzymes to the less active metabolite norketamine, which is further metabolized to hydroxynorketamine and dehydroxynorketamine. Ketamine is mostly favored as an antidepressant by 2 routes, intravenous and intranasal. Intravenous route can be used as a single dose or for repeated infusion. Single doses of IV ketamine in a dose of 0.5 milligram per kg over 40 minutes have consistently shown antidepressant efficacy for up to 7 days in most of the studies, with remission observed in 60 to 70% patients. Repeated infusion in a dose of 0.5 milligram per kg twice to thrice a week over 2 weeks have shown rapid effect which lasted up to 41 days. 0.5 to 1 milligram per kg showed better control over 0.1 to 0.2 milligram per kg of low dose ketamine, indicating a dose dependent antidepressant effect. Now, intranasal ketamine is the only route approved by FDA for use in TRD. Intranasal ketamine or S-ketamine is actually an S-enantiomer of ketamine used intranasally, as it is more potent antagonist of NMDA receptor. It is twofold more potent as an anesthetic agent as compared to the rhythmic mixture and threefold more potent than R-ketamine. Intranasal spray with brand name Spravato is used in TRD in a dose of 24, 56 or 84 milligram. The response is again dose dependent, with higher dose causing greater reduction in depression scores. Duration of antidepressant effect with IV and intranasal ketamine is actually similar from day 1 through day 7. And it is found that continued treatment with S-ketamine and a co-administration of antidepressant delays relapse as compared to placebo. Other routes of administration are oral, subcutaneous, intramuscular, sublingual, and transmucosal. All of them have a limitation of poor bioavailability due to first pass metabolism, except of course intramuscular route, which is why it is effective for use as augmentation in treatment-resistant bipolar depression. All routes show improvement in TRD with variable doses. However, limited studies are available to prove their efficacy. A word about post-traumatic stress disorder. There remains a paucity of good quality evidence to fully support IV ketamine in patients experiencing PTSD. However, trials are going on, and one of them has proved that ketamine may reduce symptom severity of PTSD more rapidly as compared to midazolam. Ketamine may be useful in preventing the development of PTSD through the induction of stress resilience. More evidence are required with validated outcomes to ascertain the clinical effectiveness of IV ketamine in PTSD. Now, ketamine is the only drug besides lithium that decreases suicidal thoughts. Anti-suicidal effects of ketamine were observed as early as 40 minutes post-infusion and can last for variable duration. Ketamine not only rapidly helps in decreasing explicit suicidal thoughts, but also mitigates implicit suicidal cognition assessed by implicit association tests. It is effective in the treatment of depressive and suicidal symptoms in cancer patients as well. However, more trials of higher quality that investigate hard outcomes such as suicide attempts and using patients at risk of imminent suicide are required. A word about safety and tolerability. Short-term use has been studied a lot more, and it has been found that the common side effects in the first 4 hours during and following infusions were drowsiness, dizziness, poor coordination, blurring of vision, feeling strange, and transient dissociation. Cardiovascular side effects were the elevations in blood pressure. Cognitive effects included impaired episodic and working memory. However, these side effects were mostly transient, dose-dependent, and benign, limited only for the period of infusion or for a short time following it. Long-term use, however, is inadequately studied in clinical trials, making safety of long-term ketamine use as an antidepressant uncertain, as abuse potential is also very high. However, chronic use of high-dose ketamine for recreational purposes is well characterized, which can actually define long-term use. And it comprises of ketamine bladder syndrome, which includes contracted and painful bladder with lower urinary tract symptoms and male erectile dysfunctions, gastrointestinal side effects like abnormal LFTs, dilatation of common bile duct and polyductal cyst leading to liver fibrosis, and neurotoxicity with cognitive defects. Now, what are the implications that we will face as anesthesiologists? Even though ketamine is awaiting FDA approval, its use in MDD is becoming widespread. Services of anesthesiologists may be needed for IV administration of the drug itself during TRD management or for patients on ketamine as antidepressant posted for surgery. So we should be very thorough with our history and prepared for any mishap perioperatively. Ketamine has come a long way from being known for its psychoactive effects and abuse potential to a drug used to treat psychiatric disorder. To summarize, ketamine has become an established drug in TRD. However, only intranasal route is FDA approved. Its striking features of antidepressant response is mainly manifested within minutes or hours after transient injection, and it is shown to take place in treatment-resistant patients. Ketamine has been found to be useful in treatment of bipolar disorders, PTSD, and suicidal ideation. Excellent safety profile, but long-term effects in low dose are not known, so research is needed. I hope I have given you a low dose of euphoria and not the full anesthetic dose that will keep you sleeping. Thank you very much for your patient listening. Thank you.
Thank you so much, Dr. Deepti Saxena, ma'am. It was a very informative lecture, very fruitful for all the students here and for everyone who is listening to the lecture. Please, now I request Dr. Deepti Saxena, ma'am, to start her lecture, which is ISA Guidelines for Private Practitioner. First of all, let me introduce her CV. Dr. Divya. Yes,
this is Dr. Divya, not Dr. Divya.
Oh, sorry.
It's okay. It's okay. It's okay. It happens. It happens. It's okay. Yeah.
She is a professor, MBBS, DA, MD from Department of Anesthesiology and Pain Management, Himalayan Institute of Medical Sciences, Swami Ramnagar, Dehradun, Uttarakhand. Her major achievements are that she has given guest lectures in many national and international conferences. She has peer reviewer in Indian Journal of Anesthesiology. She has many honors like International Affiliate of Royal College of Anesthesiologists, Scholar of World Federation Society of Anesthesiologists 2021, and Scholar of World Congress Epidemiology 2021, being ECE of IEA, selected for Fellow of International Medical Sciences Academy, member of National Academy of Medical Sciences, an executive member of Dehradun Society of Anesthesiologists TSA. She's President Appreciation. She got the President Appreciation Award of Indian Anesthesiologists DSA, Dehradun 2018, Scientific Committee in charge in Mpisacon 2017, organized by Department of Anesthesiology, Himalayan Institute of Medical Sciences. And she has got various awards, selected in KOPS Award, Pharmacology section category, and second prize in poster presentation in efficacy of glycyrrhizal lozenges on incidence of post in smokers in second annual UK Isocon 2012 Dehradun. And she's got certificate of appreciation by Impact India Foundation. She has got various memberships of ISA, ICA, ADA, IAPA, IEA, ISMS, NIN, INCLIN, and she has many publications, 11 international, 3 national, 3 index, and 43 citations. Thank you, ma'am, for joining us and giving your precious time here. You may start your lecture.
Thank you. Thank you, Dr. Neha, for such a detailed CV of mine. Thank you so much. At the outset, I would like to thank the organizers of Mpisacon City Branch Saga Society for inviting me to give a lecture on ISA guidelines for private practitioners. I will now start my screen. First of all, I would like to thank the organizers of Mpisacon 2021. I want, Dr. Neha, I would like to be on live, please. Thank you.
Yes, ma'am. Yes, ma'am.
Yeah. I'm able, I will just start sharing my screen. Dr. Divya Gupta, Professor.
Yes, ma'am. You may start now, ma'am.
Yeah.
बंद कर दो उनको शेयर करने के लिए।
Are you able to see? Are you all able to see? Dr. Neha?
Yes, ma'am.
Are you able to see?
Yes, ma'am.
Okay, thank you. Thank you, organizers, for giving me this opportunity. And the topic of my talk is ISA guidelines for private practitioners. As she told that I am professor in Himalayan Institute, Jolly Grant, but MP has always been close to me because whatever anesthesia I started or I know today is because of GMC Bhopal. I did my DA from there. So whatever opportunity I get to be in touch with MP or any conference, I never lose that chance. So thank you so much for giving me this opportunity. And at the outset, I would like to get greetings from Uttarakhand, my institute, Himalayan Institute of Medical Sciences, Dev Bhumi, Uttarakhand. So I will be sharing with you the guidelines for practicing anesthesiologists in India. As a disclaimer, these guidelines are being released from our national body, Indian Society of Anesthesiologists. So the aims of these guidelines are to improve working conditions in operating room and perioperative zones, to enhance the patient safety, to safeguard our fraternity in view of increasing litigation against us. And our goal is development of anesthesiology as an independent perioperative medical field, as we are being truly said as perioperative physicians. It has got 4 sections and annexures. Section 1 is minimum mandatory standards in operating room. Section 2 is functioning of city branches. Section 3 is ethical conduct of anesthesiologists. Section 4 is remuneration of anesthesiologists, that is the RVG system. First of all, to begin with minimum mandatory standards in operating room, the surgeon, the anesthesiologist, the physician, and ancillary staff they work as a team to improve the outcome of the procedure. For that, there should be a presence of anesthesiologist throughout the procedure. He or she should do a pre-anesthetic checkup along with investigations, presence of anesthesia machine and workstation along with minimum mandatory monitoring standards, safety checklist, and adequate facility to manage emergency and to transfer the patient if required. They have always also talked about the functioning of the city branches. The aim is to stand united and progress to take our specialty, its honor to new heights. So our national body ISA says that we should have regular monthly meetings so as to keep ourselves updated. We should bring about public awareness. As we are being said as the behind the curtain people are not aware who anesthesiologists are, what is their role. So we have to make them aware that what branch it is. Organizing and attending CMEs, conferences and workshops, and we should have a press releases of all these events. Frequent non-academic meetings and interactions with families as a de-stressor. Ours is a very stressful branch, we all know. They say, what I learned in my diploma anesthesia, I still remember my teacher, he used to say, the physician has asked to save life of a patient. Surgeons have few minutes to save the life of a patient. But we being anesthesiologists, we just have few seconds to save the life of a patient. So ours is the most stressful branch, but we can avoid dealing it by having these meetings and interactions. And they say that World Anesthesia Day is to be celebrated in great pomp and ceremony on a public platform. People should know about it and should celebrate festivals of all communities together. And as it was World Anesthesia Day yesterday, we all celebrated it at a national platform. ISA organized a virtual meeting of all the city branches, and me being the executive member of my Dehradun city branch, even we celebrated it as a gala evening and inviting all the families. So it was great fun yesterday and enjoyed the get together. They say that an office and a grievance cell should be there in each city for better functioning and security of our colleagues. And there should be a disaster management and CPR trainings for the city branches. Today's world is a world of sharing the responsibilities, as nobody is going to give you any medal for the extra risk you are taking. But If anything goes wrong, mind it, if anything goes wrong, you will be fired all alone. So we have to be very cautious to take the calculated risks. Coming on to the ethical conduct of anesthesiologists, we should perform a pre-anesthetic checkup of the patient before taking the patient for surgery and should optimize him before posting him for the surgery, and a valid informed consent is a mandate. The minimum mandatory standards, they say the surgeon should always ask for a PAC before posting the patient for operating room. It should not be like the surgeon has got the patient directly to the OT and just get it done unless it is an emergency life-saving procedure. But still also we have to have a fast PAC, a short PAC before taking the patient to the OT. The necessary investigations, references and optimization of the patient should be done in consultation with us. And ISC recommends a patient questionnaire and the PAC chart which is to be used. Why do we perform a PAC? We say people don't know us. How do they know us then? Their first interaction with their anesthesiologist is at the PAC clinic. So there itself, we have to develop a rapport with the patient and their family members. We should introduce ourselves that we are anesthesiologists and we will be giving you anesthesia to have your surgery pain-free. So it is a platform for all of us to develop a rapport with them. And we know that the key to success in medical legal cases is we have to communicate well to the patient and the attendants. And what we communicate, we have to document it also. So they say communication of the documentation, what we are writing, we should make them aware. And documentation of communication, that is whatever we are saying, we have to document it. Otherwise, we will not be able to safeguard ourselves in a court of law. So what is a pre-anesthetic assessment? It is just like a bhool bhulaiya for a patient. Patient comes, उसे भेज दिया जाता है PAC रूम में, आप जाइए, PAC रूम वाले उनसे गार्ड कर देते हैं कि यहाँ से रेफरेंस कराना है, वहां से कराना है. So the patient is totally perplexed. So ISA has given a questionnaire which is to be filled by the patient in his own handwriting with the help of a relative or guardian or any other well-wisher that he or she relies on. So this is the annexure 1 which has been given by ISA, in which the patient's name, age, details have, all has to be continued. Then in that surgeon's name, anesthesiologist's name, he should write if any medical condition is suffering from, any medications, any comorbid conditions, if he is breathless on walking, if he has had any surgical history or any specific anesthetic details, any drug allergy, how many times he has been admitted, is he a smoker, drinker, or any pan, gutka, tobacco chewer, or has he received any blood transfusion? All this questionnaire is to be filled in by the patient himself, and mind it, he has to sign it underneath, okay? So now comes our turn. Now we have to cross-verify the history. We take up the questionnaire and whatever he has written, we have to verify it. Sometimes we have to ask some leading questions for our safety, and then we have to examine him systematically head to toe. We have to have anesthesia plan in our mind and make him aware, him or her aware, that what are we planning, either regional, general, block, or combined with general and block. And after the patient is being seen and counseled, then we have to sign this form and give it back to the patient. SNDT is always to be followed. That is signature, name, date, and time. The patient will read it as his leisure, and if willing for surgery, he will sign it and come for admission on the appointed time. This is the form which has been released as a PAC chart, which is to be filled by us. As you can see, history, examination. Here it is, the investigations block has also been given, and we have to sign it. Consent, an informed valid consent is a mandate. It is to be taken separately for surgery. Surgeons will take it, and we have to take it separately for anesthesia, explaining him what all we are going to do.
Divya, please unmute yourself. You are not audible.
Hello?
You are not audible.
Not audible? Okay, let me check, ma'am. Now, ma'am, is it audible?
Yes, audible now.
Now is it audible?
Yes, audible now.
Okay, okay. Then the concerns of regional anesthesia, concerns of general anesthesia are to be told to the patient, and the preoperative orders are to be mentioned, that the patient has to be nil by mouth, knowing your anesthetist and anesthesia before surgery, all lipsticks, nail paints, ornaments are to be removed, all valuables are to be handed over to the relatives, no alcohol, tobacco, smoking before and after the surgery, to follow NPO orders post-operatively, and to have an escort for driving down home, because these days most of the surgeries are daycare surgeries. So the patient wants to go back home, but he or she should not be allowed to go alone. He or she should have an escort with him. Coming on to the guidelines for anesthesia record, demographic details are to be filled in. PAC findings, what all examination we have done. Then minimum mandatory monitoring standards like ECG, SpO2, EtCO2, heart rate, blood pressure, temperature monitoring, all are to be mentioned and all are to be monitored all throughout the procedure. Anesthesia checklist, there is a big checklist in Annexure 2 in which the various drugs, the equipments, the machine, table, all has been mentioned. That is to be checked, checklist to be confirmed. Position of the patient during the surgery, during giving anesthesia, all is to be mentioned. Whether we are giving a regional or a block. Airway management, we have to fill in what airway conduit we have used, whether LMA, endotracheal tube, with a bougie, with the stellate, any OELM maneuver. Then what is the maintenance of anesthesia? How we maintain, either with oxygen nitrous oxide or oxygen air, with what inhalational agent, what type of ventilation we maintain, either patient was on spontaneous or on controlled ventilation, control also pressure control or volume control. Then intraoperative monitoring charting, every 5 minutes we have to document it on the chart. So this is the record which is to be maintained. As you can see in this, this chart has been released by the ISA only. The technique is being mentioned, induction, airway, they have mentioned the circuit, the extubation, the regional anesthesia, they have mentioned the drugs, fluids, and these are the signs which are to be used for blood pressure. SBP, SpO2 is plus, then diastolic blood pressure, heart rate is by dot, temperature is by less than sign, and CVP by more than sign. So this is a complete chart which explains everything in itself. This is when the patient is being shifted to the recovery and then to the post-op. This chart is to be mentioned, how much was the SpO2, what was his vitals, what all fluids he or she has got, what has been the losses, and every 5 minutes, this will be filled in by the staff nurse in the recovery and the post-op. We are being rightly called as the guardian of the patients during anesthesia. Our presence and vigilance throughout the surgical procedure is a must. We should ensure safe transport of the patient from the operating room to the post-anesthesia care unit or ICU. And we should communicate with the patient and his attendants at the end of the surgery. Coming on to the last segment, that is the remuneration of anesthesiologists, that is RBG system. As perioperative physicians, we are handling multi-specialities. Our working environment is like the cockpit of an aircraft. More in-depth, vast knowledge, experience, vigilance, and expertise is required. Anesthetist, as it has been said in a weekly magazine in October, that anesthesiologists are a rare breed, barely seen or heard. They work tirelessly, ensuring painless surgeries for patients, but little is known about their work and the pressure involved. So what is RVG? It is relative value guide. This is for our private practitioners, friend. It has been allocated units to the anesthesia services based on 3 parameters. That is the complexity of the surgery, wherein like laminectomy will get more weightage than appendectomy. Time taken for the surgery, like every 15 minutes get counted as 1 unit. Modifiers like age and ASA state. If it is less than 1 year and more than 70, they will get more weightage, and ASA gets 3 and 4 will get more weightage. So complexity, time, and risk units, they are added, and then The total is multiplied by the pre-decided value to arrive at the total anesthesia fee for the said procedure. This system has been applicable in UK, US, and many Western countries. Even our national body ISA is trying really hard to bring the remuneration of our anesthesiologist colleagues to a more dignified and decent level. It endorses RVG as an independent and transparent system to arrive at anesthesia remuneration, and will work towards the implementation of RVG by talking to various stakeholders, including the insurance corporates and CGSS. The main aim is to eradicate rampant exploitation of our privately practicing colleagues in the hands of private hospitals. So how to derive total anesthesia fee of any procedure? The fee is being calculated as the number of base units plus number of time units plus the number of modifying units. The three important features which are to be taken care of, multiplied by rupee value of the unit. Coming on to how the base units are being calculated, it is based on the simplicity or complexity of the procedures, which is pre-assigned and published on ISA website. Time unit 15 minutes means 1 unit. So if it is like 1 hour procedure, then it will be 4 units. Modifying units like add-ons and multipliers. Add-ons like if age is less than 1 year or more than 70, it will be given 3 units. Obesity, BMI 35 to 42 extra units and more than 43 extra units. Arterial central line, any invasive procedures, 4 extra units. Even the post-op visits have been given more weightage. That is 2 units per visit in wards, and in ICU 4 units. Multipliers are like high-risk patients, ASA 3 and 4, 25% extra and 50%, and other risk factors, emergencies during daytimes and late nights, even Mahurats, minded Mahurats, few cesareans, few families, they are like, they get their cesarean done as per the Mahurats. So even it has also been taken weightage. Like these cases are being given extra added 50%. Seniority and experience, most important thing, that also has been given weightage, like add 25 to 50%, depending on the experience of the anesthesiologist. The time unit count will begin from induction and will end at the extubation or stabilization or end of the surgery for regional blocks. And PAC is to be charged separately as per the prevailing visit or the consultation fee. Even for the salaried hospitals, our national body has given like minimum salary for full-time anesthesiologists as per the experience 5, 10 years, more than 10 years, and if the person has done PDCC or super specialty. So to conclude, are anesthesiology superheroes? Scientifically, yes. As we celebrated World Anesthesia Day, this was a rampant pick which was being circulated in most of the groups. Even I picked it up from one of the groups. So the take-home message is stronger teams for better patient care and improved outcomes. But simultaneously, we have to safeguard ourselves from any burnout and landing up into trouble. Anesthesia is quite remarkable. It's lost time and you wake up kind of refreshed. So thank you so much for your patient hearing, and thanks again for the organizers for bearing with me. Thank you so much.
Thank you so much, ma'am. It was a very wonderful lecture, ma'am. It was very fruitful to every one of us here. Thank you, ma'am, for giving your precious time. Now we'll move on to our next speaker, Dr. Kala Iswaran, ma'am. And her topic is how to make private practice competition healthy. Let me introduce her CV to every one of you. Dr. Kala Iswaran, ma'am, she is a consulting anesthesiologist, freelance practitioner since 2 decades. She's associated with multiple hospitals in Mumbai and Thane districts as private practitioner. She received the KOP's Best Paper Award at Mpisacon 2016. She presented to a poster presented at Mysore International, Dubai, and Hall of Fame Award in 2017. And she also received a PV for modified radical mastectomy. Her my experience of 100 cases as a private practitioner. She has published this article. She has published many more articles. She delivered a talk on what we need to know about the uterotonics as anesthesiologist, and she conducts her own hands-on live airway workshops and nerve block workshops. She Ludhiana faculty TS for Live Workshop 2018, and she's the co-author of Pocket Book on Regional Anesthesia Techniques published in 2019. And she is she won the award from Dombivli Brahman Sabha. And as Secretary of ISA Kalyan branch from July 2021 onwards. Ma'am, we are very honored to have you today at Mpisacon 2021.
Thank you so much.
Ma'am,
Thank
you
you
can
so
start
much.
your lecture now.
Yeah. Is my screen being seen? Yeah, thank you, Mpisacon, for having me today. Happy World Anesthesia Day to one and all. How to make private practice competition healthy. Is my video on?
Yes, ma'am.
Yeah, thank you. There was no response from any. Yeah. How to make private practitioner competition healthy. We need to have a lot of positive attitude to say words like competition and healthy in the same breath. But since we are in the business of health, we need to make the competition healthy for good health of our patients, as well as our operating surgeons and ourselves too. If you see, India has one anesthetist per 50,000 population, and that too mainly in the cities, while WHO has recommended one anesthetist per 5,000 population. So you can see where we are lacking. And the private sector, okay, the private hospitals in India comprises around 70% of the hospital beds in India. More than 40%, 40,000, there are such community hospitals or nursing homes, what we say, where I too practice, running from one hospital to another. They are nursing homes. And as anesthetists and freelancers, we shunt between such hospitals, such nursing homes, and that means we cater to around 70% of surgeries in the private sector. Isn't it he or she an important person? Then why a private practitioner always feels less, especially the freelancers, and why the PPF has to fight for a slot of lecture in conferences, major conferences, and I think I'm the last lecture. Okay, but somewhere it's in the freelancer itself. Running between nursing homes and catering to all the emergency calls, in between the elective calls, being on call 24/7, trying to find time for family, kids, the social responsibilities, being a mother, being a daughter-in-law, being a daughter, being a wife, paying the bills, and we have no time for ourselves. And thus we try to strike a balance between work and life, okay, and keeping everyone happy, the surgeons, the staff at work, and the family and friends at home. But what about the anesthetist himself? Okay. In the life of a freelancer, if you draw a chart showing the practice or the earnings as against the number of years of practice, okay, there is an exponential rise in the initial phase. You will see there is a rise. It depends on the number of cases or how we run around, but definitely there is a rise, and in the initial period, and then there is a plateau set. Okay, then there is a plateau set here. Okay, and as depending upon the upgradation and input and your relationship, slowly there is a little up and down, and you reach another plateau in your later period, and that remains so. And it is same for every area of practice, where you practice in the suburban Mumbai or an MP, but you get your ceiling of that particular area, above which you do not very easily go. So how do we go through this journey healthily and enjoy the competition? The main criteria for a freelancer is availability. Being available 24/7 definitely increases and maintains your practice. But this is very much so in the initial start of your career. You cannot be very choosy. But later on, this becomes very difficult. Okay, but then this is the crux or the backbone of a freelancer practice. This is how you can set in a healthy competition. Being punctual. One cannot two time, and it needs to be always punctual. Space your cases such, keeping in mind and keep some extra time for the complications if in case it occurs, and the traffic time. Give your prior intimation to the next hospital or the next surgery place if you are getting some delay. Being punctual shows that you have integrity, you value yourself and you value and respect others' time also. Okay, so that the surgeon does not get irritated and they can plan something else in the time they are waiting for you. And it finally shows that you're responsible. Being punctual goes a long, long way to build up your reputation. Never hurry. Never compromise the safety of the patient. One patient can give you so much trouble that you can, and your reputation, if you are built up after some years, it can go haywire. So never hurry, never compromise the quality of or the safety of your patient. Always settle the patient well. Talk to the relatives before and after the surgery. It is advisable not to ask the surgeon repeatedly how much time will he take to complete the case, which might be very disturbing to him and irritating too. No? And the quality. You have to see that you are giving quality every time. How do you give? It's the 5 tips to deliver quality work is walk the extra mile. First of all, hold yourself in the highest standard. If you do not value yourself, if you do not have quality yourself, you cannot expect others to do that too. Recognize your mistakes and take corrective actions. No, you can go wrong, you can, but then identify that, and the next time you working, you please correct it and work with your team. You may have to conduct repetitive simulation courses, teach your staff regarding the anesthesia trolley, conducting safety measures like connecting the oxygen, checking the oxygen, the suction, the monitors, and you can go further and teach them how to do the CPR, the calls activity, the BLS, ACLS, and even the insertion of the supraglottic airway devices, how to use a video laryngoscope or a fiber optic. And all the time you have to stay focused and follow your schedule so that you can deliver a quality service to your patients and your surgeons. Nature of the patient. Now, this is very important because this goes a long way in building your personal relationship with the surgeon. You have to be detail oriented. You need a specific way or a specific drug. Do the PAC yourself and with enough time to prescribe and make things available accordingly. Remaining calm under pressure. You can remain calm under pressure only when you know yourself what has gone wrong and how you can correct it, especially when a catastrophe occurs, and help the surgeon if there is a surgical crisis or a distress. Technical skills, you have to upgrade and update yourself regularly, which goes a long way in maintaining your calmness in the OT. Very important is the interpersonal skills. Do not scowl or yell or shout at your supporting staff. Treat them with respect and dignity and call them by their names. It is they who help you in crisis and spread goodwill about your work. Refrain from commenting or criticizing techniques of your working styles of your fellow colleague anesthesiologist or the surgeon, or do not mention what the other surgeon is doing. No, you do not tell the story from one place to another. Sincerity. in your work, sincerity towards your work and towards your colleague goes a long, long way. It precedes more than the talent and the skill you possess. Sincerity makes the very least person to be of more value than the most talented hypocrite. Okay, helping whenever called. Now the next is helping. This is also very important. Like whenever called for anesthesia help or advice, be sincere and forthcoming in doing your best possible. Helping your fellow anesthesiologist in the crisis situation will always be remembered, appreciated, and reciprocated too. I had called, during my crisis situations once. I was in deep trouble giving anesthesia to a Don, underworld Don's kid, and there was a catastrophe occurring. When I called for help, I did not get many experts coming into and standing next to me. It was my very anesthetist friend who was just doing an ophthalmic surgery. She has stopped giving general anesthesia or even spinal, but then she came and stood next to me. I will never forget the day. She was just a moral support. Even that kind goes a long way. Okay? Better if you have like-minded people coming in together and joining hands to form a group practice. Even that is, it gives you a lot of mental peace, and the quality of your work improves, and it goes a long way in giving a competitive, healthy environment. Moreover, you can always employ yourself an anesthesia technician. Even that person takes away a lot of stress preparing your trolley, checking up the pre-op your monitors, instruments, and everything, and waiting along with you. So it goes a long way to give you a healthy environment. Now, as Dr. Gupta already told, the income, the competition is not with your colleagues. You are earning so much and your colleagues are, you are not, comparison between two colleagues is not there. It is the competition between oneself. It's always been like that. Each day we try to beat our own income. That is the most competitive thing, to push yourself to go ahead. But then somewhere you have to draw a line of contentment. Okay, initially you have a great feeling, yes, I earned so much this month, I'm doing more better, I upped my income than the previous day, I did so much. But after some days you have to draw a line of contentment around you and decide, this is what I want. The accounting, clear accounts, then and there you clear the accounts with the hospital or the surgeon from where you're working, so that it does not cause embitterment or misunderstandings and spoil your relationship. So you might feel, how do I ask the person? Paise mangna hai. It is very difficult, but you have to be very forthright and clear the accounts then and there. Madam has already spoken about RVG. RVG of ISA helps us and gives us a fair guideline of how to charge, where to charge, and how much to charge. That is a very good guideline that ISA has developed. Please do follow that. And investments, do investments regularly well, so that you can let go of cases slowly where two very nice people, like the surgeon might be also very good and you cannot just get along with them. So instead of spoiling yourself, every day getting worked up working in such an environment, you can just let go of these cases, because your investments are sound and they are giving you a good returns. It helps you in choosing places which you should be enjoying the practice of private practice, rather than enduring it and just trying to go along, and it embitters you in the long way. And only a happy person can make the surroundings and everyone feel happy. So this is the positivity, you can pass it along to your patients, your surgeons, your quality of work improves immensely. Okay. Now, coming to the upgradation and updating, private practitioners, as I mentioned, why are we lagging behind? Because we do not value ourselves to upgrade, update. Any business you take, they finally put some percentage of the income back into the businesses. But private practitioners do not do so. They invest on shares, they invest here, they do multiple things, but they do not spend on upgrading ourselves. So buy your gadgets well, do hands-on courses, attend webinars. The internet is always there to upgrade yourselves. Download apps such as Nysora app. You can purchase the app, the difficult airway app. You have coagulation, apps to follow. So follow apps and give good quality to your patients and your surgeons. There are fellowship programs too. You can attend the weekly or monthly fellowship programs. When you do a presentation, you read so much, you upgrade yourselves. No? So attend, do not hesitate to come forward and present, because you fine-tune your skills there. You can become member of many associations like Aura, the ISA, the GAS, you can TIVA, and there are pediatric, and you can do upgradation with the protocols given here, and you are in touch with the latest happening around. Now, mental conditioning. This is very important for a private practitioner, because you are 24/7 on call. You have, many a times you do elective cases and you have to drop everything, whatever you're doing at home, at the drop of the hat and run for emergency cases or fill in the gaps for other anesthetists. So you have to have a mental conditioning where you can just switch off your anesthesia mode. You develop hobbies like dancing, gardening, cycling, where you try to become fit as well as have a mental conditioning in such a way that there is, when you are doing some activity, the brain should stop, because what the surgeon has been telling you, what happened in the case, the so-and-so problems occurred. Even if you are working in the gym, your mind keeps on going. That shouldn't occur. No? So in case if you are good at dancing, singing, or something which needs full concentration, so that the monkey chattering of your brain is switched off. So develop some hobbies which will give you positivity, which can be
Madam, sound is not coming. Hello.
Time to rewind and regenerate yourselves. Give family time. Nothing like your family time to regenerate yourselves and take your de-stressing, the friend zone. That they are the best to de-stress. Keep time for your friends. Meet them regularly. Laugh along with them. Health investments. Keep checking your health investments, because you do not know. COVID has taught us so much. We first went and checked how much your health insurance is, and health investment is very important. You upgrade it time to time and keep it ready. The financial investment are it should be such that slowly you can reduce the practice of rushing. The freelancer is forever pressed for time. So financial investment should be such that in over a period of 8 years, 10 years, you can choose your area of practice. Now, summing up, positive attitude is very, very important for an anesthetist to deal with the stress given by the patient, the surgeon, and the setup every time. So you need to have a positive attitude. Competition and healthy. of course, you should compete in developing yourself, your setup, your area of practice, and take everybody along with you, making it coexistent. No, you have to coexist together and make the entire area of practice healthy. People should look at you and upgrade themselves. Ki no, he or she is doing such a good work, so I should also. So that should be the competition, so that we can, as an unit, demand what Dr. Gupta was telling. We demand the our remuneration, and more than that, without demanding, we should get it. The surgeon should be feeling proud to pay us. No, so make the competition healthy. Inspire, not perspire or conspire against your colleagues. Inspire them to come forward, move along, hold hands and go together. Do not berate or gossip or be jealous of your is perfect the first day. Try looking around you and look for how or he or she is doing, why she has so many cases, why she's so successful, or he or she is so successful, and try to inculcate good habits yourself. Upgrade and evolve yourself. Science, anesthesia is developing so fast. You have to every 3 or 5 years you have to see what you are lacking and develop the skills, train yourself towards better practice. Invest in health and wealth regularly. Keep checking everything. And thank you so much, Mpisacon, for having me. Thank you.
Thank you so much, ma'am. It was a very wonderful lecture, ma'am. Amazing presentation. It will be very fruitful to all of us. Now there will be a vote of thanks from our organizing joint secretary, Dr. Amit Jain. So, okay. Sorry, it will be after some time. If there are any question answer session, please it's hand over to our chairpersons and everyone there. If any queries are there, they may proceed.
Thank you, Dr. Dipti ma'am, Dr. Divya and Dr. Kala ma'am for your interesting and informative lectures. Thank you.
I would like to say one thing. Dr. Kala ma'am, your presentation was too good. And I am like just in awe with how the slides have been made. And I mean, if the students will see, it's like a proper PG type lecture. I mean, it was too good. The effects and the presentation, and that is what leaves the mark on the audience.
Thank you so much, madam.
Thank you, ma'am. It was really nice, and the slides and what all you said about work-life stress and all the aspects, it was amazing, ma'am. Thank you for enriching us, ma'am.
Thank you. Thank you
I
so
would
much.
also like to congratulate both of you. It was excellent. Excellent.
Yeah.
Thank you.
Very nice.
Thanks.
Thank you.
Thank you. Thank you very much.
Thank you, ma'am. Thank you.
Thank you everyone for joining us. And on this note, we'll end this session and we'll move on to our next session, that is poster presentation for 10th candidates. The judges for our poster presentation are Dr. Brijesh Kaushal sir and Dr. Shailin Davar sir. Are you there, sir? Have you joined?
Yes, yes.
Dr. Brijesh Kaushal sir, he is a DM in cardiac anesthesia and he's associate professor in Department of Anesthesiology, Gandhi Medical College, Bhopal. And our next judge is Dr. Shailin Davar sir. He is the professor and head of Department of Ratlam. Welcome both of you, sir. Can we start our session, sir?
Yes, yes, please.
Okay, so our first candidate is Dr. Ritu Tadwal. Dr. Ritu, are you there?
Yes, ma'am.
Dr. Ritu, please share your screen. Start. A reminder to all of you, you will be having 5 minutes for presentation and 2 minutes for a question answer session. So wrap it fast, okay? Okay, make it full screen, Ritu. Okay, your timer is started now. You can start now, Dr. Ritu.
Yes, ma'am.
You can make it a big screen, yeah. Okay, fine.
Hello. Hello. Ma'am, am I audible?
Yes, you are audible, Dr. Ritu. Start now.
Yes. Good afternoon, respected judges and colleagues and juniors present over here. Today, I, Dr. Ritu Tarwal of NSCB Medical College, Super Specialty Hospital, would like to present a poster on the topic anesthetic management of a brain bypass surgery. Brain bypass surgery is usually done to maintain an uninterrupted blood flow between the occluded blood vessels around the brain to prevent stroke, transient ischemic attacks, which ultimately leads to brain cell death. The main ideology behind this surgery is rerouting the blood flow around the blocked artery and then to improve the flow to oxygen deprived areas of the brain. So these surgeries can be done by 2 ways. First is taking the vessel graft from elsewhere from the body, such as ulnar or subcutaneous grafts, and connecting above and below of the blocked arteries, so the blood is bypassed through these grafts. Or else taking the healthy donor artery from the scalp or face. This can be done when a small artery is narrowed, which hampers the blood flow to the brain. And 35-year-old female, complaints of headache since 4 to 5 years, blurring of vision in left eye, and also weakness in the lower limb. She was also hypertensive and was taking tablet amlodipine and telmisartan since 2 years. She was suggested for CT angiography, and after that it was detected an aneurysm of left intercarotid artery, and she was planned for the surgery external carotid to mid cerebral artery bypass using a subcutaneous vein as a graft. When we take the patient inside the OT, we attach the monitors to IV arterial lines for intravenous lines were secured, and arterial line for intravenous invasive blood pressure was secured with transducer kept at the level of tragus. We also secured one IJV central line on the right side. The patient was preloaded. Also, vasopressors and blood products were kept ready. We also attached cerebrally oximeter on bilateral temporal region, but due to painting and draping, we were unable to get the reading. After the preparation, patient was pre-medicated with IV midazolam 2 mg, was induced with propofol 200 mg, fentanyl 100 microgram, and vicuronium 6 mg, and was intubated. She was maintained on sevoflurane with the MAC of 1 and propofol infusion. The mean arterial pressure was kept on higher side and was increased up to 110 mmHg during the clipping of the M2 segment of MCA with the aid of vasopressors, noradrenaline. And after the anastomosis, injection heparin 2500 international unit was flushed. We also used mannitol for maintaining the intracranial tension within the range, and in the end, patient was reversed and was extubated inside the deep plane. During the whole surgery, there was a careful balance between the bleeding and thrombosis, and the main concern was to provide maximum brain relaxation for the deeper vascular access. There was concern about the prevention of ischemia and infarction due to the temporary blood vessels occlusion. For this, we maintained intravascular volume and cerebral perfusion pressure. In the end, I want to conclude that during these kind of cases, we should take precautions to prevent maintaining cerebral perfusion pressure, the normocardia, and avoiding hemodynamic fluctuations. It can lead to a favorable outcomes. Thank you.
Thank you, Dr. Ritu. Over to you, judges now.
Dr. Ritu, you are using cerebral oximetry monitoring, but you are unable to record the. I am audible? I am audible?
Yes, sir. Yes, sir, you're audible.
But you are unable to record the values. So please tell me the normal value of cerebral pulse oximetry.
Sir, this cerebral pulse
Your voice is interrupted.
60. Hello.
Yes, yes.
This cerebral oximeter, it derives oxygenation from both arterial and venous transcutaneous supply. It's around 60 to 80% range.
Is the normal. What is the principle? It's based on which principle?
Also works on Beer-Lambert's law. So
Yes.
Beer-Lambert's law पे work करता है.
Okay, okay,
And
okay. Is it working in the non-pulsatile flow also?
Sir, it works on the pulsatile flow. Pulsatile flow पे work करता है sir.
No, it is also working in the non-pulsatile flow also. Okay. Dr. Shailen Davar, sir.
Okay. Dr. Ritu, am I audible? Any specific post-operative care for such cases?
Sir, basically हम after the surgery we have to see if there is not मतलब जो flow है graft के लिए वो अभी मतलब तब भी work कर रहा है कि नहीं, because क्या बोलते हैं if the artery is blocked, the graft is blocked again, it can lead to ischemia and further infarction.
Okay. What about post-operative hemodynamic monitoring?
Dynamic monitoring, sir, we kept the invasive BP monitoring for further मतलब after taking the patient out of the OT also, and NORAD support was going. If there was careful monitoring that.
Okay. Thank you.
Thank you.
Thank you, judges. Thank you, Dr. Ritu. Now we'll move on to our next candidate, Dr. Rituraj Singh Baghel from LN Medical College, JK Hospital, Bhopal. Dr. Rituraj, are you ready?
Yes, ma'am.
Okay, share your presentation. Share your screen, please.
Am I audible, ma'am?
Yes, you are audible.
Good evening, respected faculty members and judges. My name is Dr. Rituraj Singh Baghel, second year PG resident, Department of Anesthesiology in LN Medical College, Bhopal. And I'm presenting a poster on pheochromocytoma excision and anesthetic challenge under the guidance of Dr. Nukur Chakraborty, Professor and Head Department of Anesthesiology, LN Medical College. Pheochromocytoma is a rare endocrine tumor originates from chromophene cells present in the adrenal medulla or of a paraganglion cells. Clinically present as a vague symptom like headache, palpitation, and diaphoresis that can lead to hypertensive crisis due to increased catecholamine productions. And apart from that, other associated symptoms includes pallor, nausea, tremor, fatigue, anxiety, fever, pain, and flushing. Characteristically, these symptoms are paroxysmal in nature and may be precipitated by abdominal exertions as heavy weight lifting or performing Valsalva maneuver. Hypertension is invariably present in all patients. However, it can be asymptomatic and diagnosed by further workup of an adrenals. Sometimes it follows a rule of 10, in which it is 10% malignant, 10% extra-adrenal, 10% bilateral, and 10% familial, and 10% in pediatric without hypertension. And incidence is equal in both genders and usually diagnosed at the age of 30 to 40 years, but can be present earlier. Regarding etiology, it is sporadic in 90% of cases, and in 10% it is familial and associated with syndromes like von Hippel-Lindau syndrome, neurofibromatosis, MEN1 and MEN2B syndromes also. My aim is to provide anesthetic management which provide hemodynamic stability during preoperative, intraoperative, and postoperative periods. In my case, my patient is 18-year-old female, weight 38 kg, posted for right adrenalectomy under general anesthesia. Complaints admitted with complaints of dyspnea, chest pain, palpitation, and abdominal pain for past 1.5 years. On examination, heart rate was 104 beats per minute. Blood pressure is 160 by 90 millimeter of mercury. Family history is not significant. CECT abdomen reveals a well-defined round to oval heterogeneously enhancing mass lesion with internal area of necrosis and calcification seen in right suprarenal region, likely signs of pheochromocytoma. And lab investigation में vinyl mandelic acid urine in 24 hours 11.98 milligram for 24 hours, and VMA ratio to creatinine is 17.74 milligram per gram of creatinine. Metanephrine in urine for 24 hours is 320 microgram per day, and metanephrine creatine ratio is 477.07. Regarding pre-anesthetic checkup, I advise her to complete hemogram, a serum electrolyte, liver function test, renal function test, chest X-ray, 2D echo, urine RF, PTINR, 12-lead ECG, chest X-ray, viral marker, CVSG, whole abdomen, BP charting, sugar charting. And advice is given to take a tablet prazosin 1 mg OD, tablet propranolol for 20 mg OD for 5 days with strict hemodynamic monitoring. Regarding case management, a case was conducted under general anesthesia and epidural anesthesia. Patient was kept NBN for 6 hours. Operation theater monitoring are ECG, SpO2, invasive blood pressure monitoring, ETCO2. I pre-medicate the patient with IV midazolam, IV fentanyl, and IV pantoprazole. General anesthesia standard protocol was followed, and the case was induced by IV etomidate and IV vecuronium, and maintained by isoflurane. And 16 centimeters 7 French triple lumen central venous catheter was inserted in right IJV up to and fixed up to the mark of 13 centimeter. And epidural catheter was inserted in left lateral position using 18 gauge 2-way needle in L1 L2 interspace by loss of resistance technique and fixed at 11 centimeter. Infusion of dexmedetomidine, infusion of sodium nitroprusside, IV small boluses were used according to the BP before the excision of tumor, and after the excision of tumor, above mentioned infusions are stopped and infusion of noradrenaline started according to the BP of patient. And epidural top-up was done with 8 ml of 0.25% bupivacaine. Smooth extubation was done without any cardiac instability. And regarding discussion, pheochromocytoma resection. Pheochromocytoma resection is considered as one of the most challenging cases in anesthetic practice, and our primary aim is to provide stable hemodynamics, especially during laryngoscopy, surgical stimulation, and tumor handling. And dexmedetomidine is a shorter acting, highly selective alpha-2 adrenoreceptor agonist that attenuates the sympathetic responses and also reduces the anesthetic requirement, and also provides post-operative analgesia. And Dexmed contribute in hemodynamic stability during the surgery, as during intra-op, BP was maintained throughout the surgeries. And coming to the sodium nitroprusside, it is administered as IV infusion. It is a potent vasodilator, fast-acting, easily titrable, highly effective antihypertensive agent when used with intensive monitoring in place. My conclusions are pheochromocytoma patients are at risk for major adverse cardiac complications in the perioperative period. Preoperative optimization, meticulous intraoperative planning, and hemodynamic management and vigilant monitoring are the keys to make successful management of such patients. And these are my references.
आपके वो भी बताओ क्या वहां रख दो बेटा अभी हम जा रहे हैं पढ़ने
I think, hello, some background noise is coming.
Not from my side.
Yeah. Okay. Start, Rituraj. Have you finished?
Yes, ma'am.
Okay. Over to you, judges now. Sir, So over to you, judges now. He has finished his presentation, sir.
सर पूछ रहे हैं.
Am I audible?
Yes, sir. Yes, sir, you're audible.
My question is, what is the dose you are using of sodium nitroprusside during the handling of your fucroside?
So initially we were using 0.5 to 1.5 microgram per kg per minute dose.
Yes.
Yes.
And
0.5
during handling?
Yes, sir. So during handling, sir, higher doses, sir. During handling, it's around 1.5 microgram per kg per minute. We started with 0.5 microgram per kg per minute. Then we goes upper side because during handling there is a surge of catecholamine, sir.
Okay. What is the blood loss during surgery?
Sir, blood was optimal, sir. Less than 500 ml.
Less than 500 ml. Is there any requirement of blood transfusion?
No, sir. We
Post-operatively?
we precautionally give 1 BT, sir.
1 blood transfusion.
Yes, post-op 1 BT.
Or any vasopressor requirement after
Yes, sir.
that?
Yes, sir. After that, after the ligation of the vessel tumor ligation, we started NORAD infusion, sir. There is a sudden drop in the blood pressure after the tumor ligation, sir.
Okay. Then what is the time or mean time for the action of sodium nitroprusside?
Sir, after 5 minutes, sir, when we started sodium nitroprusside, we waited for 4 to 5 minutes, sir, to come into to observe that it's acting or not properly. Then we titrated the dose.
Okay. But sodium nitroprusside is acting within second.
Yes.
Okay. So there is no need to wait for 4 to 5 minutes to act for sodium nitroprusside.
Yes.
It actually acts within second.
Yes.
Okay. And preparation for using nitroprusside is?
Yes, it's sensitive to light, sir. So preparation is also amber colored, and we also wrap with the tubings and all things with.
And post-operative analgesia?
Epidural top-up done, sir. Epidural top-up.
Which dose? In which dose?
Sir, during intra-op, sir, we give 0.25% of bupivacaine, 8 ml. Then in
8
post-op,
ml boluses or infusion?
No, sir, 8 ml bolus, sir. Epidural top-up, 0.25% bupivacaine.
And then post-operatively?
Then post-operatively, sir, after 6 to 8 hours, sir, we did with 6 ml of 0.25% bupivacaine, sir.
Only boluses, not infusion?
Yeah. No, sir. No. Infusion not required.
Oh, infusion not required. Okay.
For epidural, sir, infusion. Patient don't demand, sir, pain and vitals are stable, so we didn't expect.
You required noradrenaline vasopressin, noradrenaline infusion post-operatively.
Sir, for 3 to 4 hours, we gradually titrated it, NORAD, and as the patient maintaining blood pressure by itself, we gradually tapering it.
I am asking that if you using the noradrenaline post-operatively,
yes, sir,
and there is any need for continue bolus giving the bupivacaine, is there any interference between them? Bupivacaine post-operative boluses and noradrenaline infusion?
Sir, physiologically increased physiological interaction is there between bupivacaine as
hello,
sir, because
yes.
we give bolus, sir, it will decrease the blood pressure, sir. Bupivacaine during epidural it decreases the blood pressure. Yes, sir.
It decreases the blood pressure, no? So
yes, sir.
You
Slight decrease in blood pressure, sir. Yes, sir.
That's why I'm asking. It is there will be some interference between the two drugs.
No, sir. During when we start top up with bupivacaine, at that time the NORAD was already stopped, sir. NORAD infusion was already stopped, sir.
Okay. Dr. Dawar, sir, please ask the question.
Okay, sir. Dr. Ritu, am I audible?
Yes, sir. Audible.
Special precautions taken by you during intubation?
Sir, my main aim is to avoid the responses against direct laryngoscopy to maintain the hemodynamic stability. So one thing is IV midazolam pre-medication was given judicially, sir. IV midazolam and fentanyl was given previously, and intubation was done by our most expert seniors, so that there is no laryngoscopy, easy and quick laryngoscopy. And we avoid succinylcholine, sir, because it is not advisable as depolarizing muscle relaxant.
Have you assessed intraoperative fluid therapy?
So this was we put, sir, central line, right, IJV, but we didn't give CVP guided fluid, sir.
CVP guided fluid therapy.
Yes.
Okay.
Yes.
And hemodynamic monitoring done by invasive BP monitoring?
Yes, sir. Invasive BP monitoring, sir.
Okay. Okay. Thank you.
Thank you. Thank you. Good day, sir. Good day.
Thank you, Dr. Rituraj. Thank you, judges. Our next candidate is Dr. Saleha Tabassum. Are you ready, Saleha?
Am I audible, ma'am?
Yes. Saleha, be a little louder. No?
Okay, ma'am. Okay.
Yeah. Okay, share your screen.
Yes, ma'am.
You'll get 5 minutes, okay? For presentation, 2 minutes for question answer.
Okay. My screen is visible now?
Just 1 minute. Yes. It's not, it's visible, but can you make it bigger?
Yes, ma'am.
Yeah, okay. Fine. Start now.
Yes. 1 minute. Good evening, everyone. Myself, Dr. Saleha Tabassum, and the topic for poster presentation is Enhanced Recovery After Surgery in Pediatrics. Enhanced Recovery After Surgery is a patient-centered system designed to challenge dogma and replace heuristics with evidence-based care. The origin of ERAs are rooted in the concept that patient outcomes can be improved through the modulation of physiological responses to surgical stress. In adults, ERAS protocols reduce mobility and increase patient satisfaction while reducing overall cost. Clearly defined, standardized elements applied in a consistent manner can optimize care. For an approach that has been transformative in surgical care for adults, the impact ERAS has made in pediatric surgery has been surprisingly limited. Enhanced recovery protocol includes preoperative, intraoperative, and postoperative guidelines. The preoperative protocol provide preoperative information and education. Educating families has an overall satisfaction with the surgical process and reduces anxiety. Involving older children and adolescents improve quality and the care of and aid in postoperative recovery. Optimize underlying medical conditions. Minimize the use of mechanical bowel preparation. Mechanical bowel preparation in itself has not shown any reduction in the risk of SSI when compared with no bowel preparation. Avoid prolonged fasting. American Society of Anesthesiologists guidelines suggest fasting 2 hours for clear fluid, 4 hours for breast milk, 6 hours for light meal, and 8 hours for fatty meal. However, traditionally, patients are asked to fast from night, which should be stopped. Administer non-opioid preoperative analgesic medications. Intraoperative protocol include use of standard anesthetic protocol, including regional anesthesia when possible. Regional anesthesia can be used as an adjunctive to general anesthesia and has many potential advantages, including effective means of postoperative analgesia, decreased need of intraoperative analgesics, decreased volatile anesthetic requirements, and it also attenuates pro-inflammatory and metabolic responses to stress and surgery. Apply a multimodal approach to prevent post-op nausea vomiting if more than 2 risk factors are present. Utilize laparoscopic surgery and avoid routine nasogastric tubes which are uncomfortable to pediatric patients. And without nasogastric tube, there is no increased chances of anastomotic leak or any surgical outcome. Use preoperative antibiotic prophylaxis and skin preparation. Use standardized protocol for hypothermia prevention. Post-operative protocols include avoidance of routine peritoneal cavity drainage after colonic anastomosis, use goal-directed fluid therapy or zero fluid balance model to guide post-operative fluid management, avoid urinary catheter placement or early removal of on post-operative day 1 or 2, use interventions to minimize post-operative ileus, minimize use of opioids, provide nutritional care, including screening for nutritional status, begin early scheduled mobilization on post-operative day 1, collect information on protocol compliance and outcomes. We can conclude that ERAS requires education and engagement from numerous multidisciplinary teams throughout the perioperative periods. Anesthesiologists have an essential role in the creation and dissemination of pediatric ERAS. Research is ongoing to create an ERAS guideline that will reduce adverse events, enhance quality of care, increase parent satisfaction, and improve the efficiency of neonatal surgical healthcare delivery. Thank you.
Thank you, Dr. Saleha. Over to you, judges now.
Saleha, am I audible?
Yes, sir.
My question is, what are the regional modality used as a ERAS protocol in pediatric patient?
Regional modalities include nerve blocks, neuralgial anesthesia, matlab spinal block or epidural analgesia, caudal catheters, and transversus abdominis block.
Your voice is interrupting.
Hello? Am I audible, sir?
Yes, yes, now.
So regional modalities would include spinal anesthesia or epidural anesthesia, putting epidural catheters or giving one-shot caudal block or tab block.
Again. Your voice is interrupting continuously.
Okay, sir, I'll just... Hello?
Yes.
Am I audible clearly now, sir?
Yes, yes.
Saleha, you're audible.
Okay. The regional modalities would include spinal anesthesia, epidural anesthesia, including epidural catheter and caudal block, tab block, and other nerve blocks can be provided.
Which are the other nerve blocks?
Sir, other nerve blocks will include
various nerve blocks in the newer times, for this time of anesthesia practice is evolving. Mainly facial pain blocks.
Yes, sir, facial blocks.
And brachial blocks. Is this feasible to give brachial plexus block in pediatric patient? So many other newer blocks. So serratus anterior block, erector spinae plane block.
Okay, sir.
These are all newer blocks, which can be also used in the pediatric patient as an enhanced recovery protocol. Okay.
Okay, sir.
Dr. Dawars, you can
Okay.
ask the question.
Dr. Salia,
Yes,
audible?
sir. Yes, sir. Yeah.
How you manage patient of intraoperative hypothermia?
So intraoperative hypothermia can be managed by using warm blankets or warming the patient externally by using warmers and covering the patient. Before handling over the patient to the surgeons, we can cover the patient properly.
Okay. Okay. Thank you. Thank you, Salih.
Thank you, sir.
Thank you, Dr. Saleha. Our next candidate is Dr. Sanjeev from GR Medical College, Gwalior. Dr. Sanjeev, are you ready? Hello.
Hello.
Dr. Sanjeev.
Am I audible?
Yes, you're audible. Please share your screen. Hello, Dr. Sanjeev. Yes.
वो क्या करती
Hello, am I audible?
Yes, you are audible.
Hello, good evening, judges. I am Dr. Sanjeev. I am going to present a case report on the topic of venous air embolism during the posterior fossa surgery in sitting position under the anesthesia, general anesthesia. Under the guidance of Dr. Seema Sinde and Dr. Siddha Goyal, here the introduction. Venous air embolism is a well-known entity and has already kept anesthesiologists on the edge of due to the rapid presentation and fatal consequences. Venous air embolism is the entrainment of the air from the exogenous side or from open operative field or communication with the environment into the venous or arterial vasculature, producing systemic effects. Certain positions and surgeries are notorious for the occurrence of venous air embolism, like sitting craniotomies, infratentorial surgeries, posterior cervical spine surgeries, craniosynostosis repair. However, it may also occur in the patients in lateral, supine, or prone position. A 18-year-old male with ASA grade 1 weighing 60 kg was complaint of headache and vomiting associated with the diminution of vision since 3 months. On imaging, computerized tomography, patient was diagnosed with the glioma in the third ventricle and was posted for craniotomy and tumor excision. Pre-operative evaluation and laboratory within normal limits. An informed and retained high-risk patient was taken. Hello. Hello.
Hello.
There is
Dr.
much of
Sanjeev,
noise.
whoever speaker is on, please mute yourself.
Patient was taken into the operation theater with the GCS of E4, B5, the NIVP 120, pulse rate 92 per minute, SpO2. Intravenous access was obtained. All the investigation were normal and patient had no any significant past history. The airway assessment was normal. Patient was pre-medicated with the glycopyrrole 0.2 mg IV and midazolam 1 milligram IV. Patient was pre-oxygenated for 3 minutes and was induced with the thiopentone 300 milligram, succinylcholine 100 milligram, and fentanyl 100 microgram intravenously. The patient was intubated with the 8.5 mm internal diameter cupped tracheal tube, bilateral air entry checked, and tube is secured. Patient was given atracurium 0.2 milligram per kg IV bolus and maintained on the 0.1 milligram IV. Patient was maintained on the oxygen and nitrogen 50% oxygen and 50% nitrogen and isoflurane. Right subclavian central venous catheter placement was done. Patient monitoring included ECG monitoring, SpO2, NIBP, ETCO2, respiratory rate, and urine output. After inducing patient in supine position, sitting position was gradually done with the monitoring of vitals, and head was fixed in the Mayfield head holder with the maintaining 2-finger distance between chin and chest. Surgery was going on in the sitting position without any complication. At the time of dissection of dura, sudden drastic change in end tidal CO2 was noted from 30 millimeter of mercury to 19 millimeter of mercury. In the meantime, heart rate was slightly increased and BP was slightly decreased. SpO2 remains unchanged. In this case, patient was immediately shifted on the 100% oxygen, and surgeon were duly informed to the stop surgery. Surgical field was flooded with the saline and sites were sealed with the saline soap gauges. To stabilize the vital parameters, fluid were repeatedly transfused. Aspiration of air was done through the subclavian catheter, which was already placed. Nearly 35 ml of air was aspirated. Then, after 10 minutes, blood pressure increased. In the meantime, EtCO2 increased gradually from 19 to 22 and then finally up to 30 millimeter of mercury. With the stabilization of vital parameters, patient was then maintained on 50% oxygen and 50% medical air, and surgery was allowed to proceed. No murmur was found on the chest auscultation. The vitals were heart rate 114 per minute and BP 104/6. Now the discussion. Venous air embolism is a well-recognized complication in the neurosurgical, cardiovascular, obstetric, orthopedic, and transplant surgeries. Transesophageal echocardiography is the most sensitive method used for the detection of venous air embolism, but its high sensitivity has made it highly non-specific for emboli that may cause cardiovascular compromises. Other techniques are transcranial Doppler, precordial Doppler, end-tidal nitrogen and carbon dioxide levels, ECG, and oxygen saturation. Out of these, ECO2 is the most practical and sensitive modality used. A change of 5 millimeter of mercury in the time span of 5 minutes is the diagnostic of venous air embolism. The most important factor for the sequelae of the venous.
Dr. Sanjeev, your time's up now, so wrap a little bit fast.
Oh, sorry. The most important factor of the sequelae of venous air embolism after its occurrence is the rate and volume at which the air enters in the vasculature. More than 5 ml per kg immediately causes an airlock scenario, hence right heart failure followed by cardiac arrest. Any values less than this cause a spectrum of sign and symptom of ranging from dyspnea, wheezing, coughing, chest pain in awake patients to rapid fall in the ECO2, SpO2, BP, heart rate, ST segment, and T wave changes, myocardial infarction, and arrest in anesthetized patients. Principles of management of venous air embolism are preventing any further air entrainment, decreasing the size of the already entered air emboli and hemodynamic supports. Thereafter, the surgeon should immediately flood the field with the saline and seal any open sinuses. Deploy vein in the bone of the cranium in the order to prevent the further air entrainment. For the prevention of venous air embolism, various methods have been described, such as application of PEEP, aspiration of air, inflatable cervical tourniquets, and positive pressure at the end of procedure, but none seems to be a foolproof method. Early detection by vigilant monitoring and appropriate management made the outcome favorable. The immediate intervention in the form of putting of nitrous oxide, maintenance of PEEP, flooding the surgical site, aspiration of air through the central venous catheter, and the replacing the acute losses were done to stabilize the hemodynamic parameter. Conclusion. Venous air embolism is associated with the certain surgeries and positions. Vigilant monitoring, early detection, and timely management of venous air embolism are the key preventive measures to prevent the fatal consequence. Yes, thank you.
Thank you, Dr. Sanjeev. Over to you, judges now.
Dr. Sanjeev, my question is, you are using during induction nitrogen gas. How you are using nitrogen gas with oxygen?
Nitrous oxide, sir.
Okay, you are you said at the time of nitrogen. So I thought, well, how can you use? It is nitrous oxide. No?
Ji sir, we were use sir Entonox, 50% nitrogen and 50% oxygen, sir.
Okay. You having Entonox cylinders?
We have sir central supply of nitrogen and cylinders are available also, sir.
Okay. What are the modalities of neuromonitoring during this patient, during this posterior fossa surgery?
Sir, modalities are transesophageal cardiography and 2D echo.
Neuromonitoring. I am said neuromonitoring.
Neuromonitoring.
What are the modalities of neuromonitoring? In posterior fossa surgery.
Sir, transcranial cardiography. Hello, sir. Am I audible, sir?
Yeah. Now it is. Hello.
Yes, sir.
Please tell. What are the new? Hello.
Hello, sir.
Yeah.
Hello.
Hello, sir. Voice is not coming.
Yeah. What are the modalities you are using in this patient, or you can use? Okay. Forget this question. What are the views which can detect the venous air embolism in transesophageal echocardiography? In which views we can diagnose the venous air embolism?
Sir, with the help of transesophageal echocardiography, we can diagnose the venous air embolism. It is very sensitive.
In which views? There are certain views in transesophageal echocardiography which we can use for diagnose venous air embolism. What are these views? Do you understand my question?
Yes, sir.
So you don't know the views, okay?
Yes, sir.
Okay, read it again. Then, Dr. Davar, please, you can ask the question.
Dr. Sanjeev. Hello.
Yes, sir.
Have you managed venous air embolism intraoperatively?
Yes, sir. We managed our case before. We were monitoring the ETCO2. The ETCO2 sudden fall was noted in the ETCO2. We just stopped the nitrous oxide and put on the patient on 100% oxygen, and isoflurane was stopped, and the aspiration of air was done from the central venous catheter. It was 35 ml around, which was significant air embolism. And we asked the patient, to flood the surgical site to stop the communication between the vasculature and the environment. So in that way, further entry of air was prevented.
Aspiration of blood, aspiration done in a special position?
We did it, we done in the sitting position, sir.
Okay. Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Sanjeev. Now we move to our next candidate, Dr. Seethal and Sunny. Dr. Seethal, are you ready? Dr. Seethal, are you there? Dr. Seethal? I think she is not there. So we'll move on to our next candidate, Dr. Shilpi. Dr. Shilpi Singh from Gandhi Medical College. Shilpi, are you ready? Hello. Shilpi?
Yes, ma'am. Yes, ma'am.
Shilpi.
Ma'am, I'll start sharing my screen.
Yes.
Ma'am, is my screen shared?
No, it's not
Ma'am,
visible yet.
I'll do
Yes,
it.
take your time.
Ma'am, is my screen shared now?
Yes, it has come.
Okay.
Okay, start
Good
now.
evening. Good evening, all respected judges. Myself, Dr. Shilpi Singh from Gandhi Medical College, Bhopal, is going to present my poster presentation on the topic, a study of prediction of difficult laryngoscopy by USG quantification of distance of skin to hide bone. So the major responsibility of anesthesiologist is to provide adequate ventilation to the patient. Most vital element of it is the airway, and difficulties in airway management can lead to adverse effects, and failure can even result into mortality. So preoperative prediction of patients in whom laryngoscopy is difficult would decrease the rate of anesthesia related adverse respiratory event. And the point of care ultrasound technique has been widely used in the operating room for USG guided prediction of difficult laryngoscopy. The aim of my study was to predict difficult laryngoscopy by a USG guided valuation of the distance of skin to hide bone. My study was an observational hospital based study with a sample size of 90 patients of age group 18 to 65 years of either sex belonging to ASA grade 1 and 2 who were scheduled for elective surgery and required general anesthesia with direct laryngoscopy and endotracheal intubation. Informed consent was taken from the patients, and patients of ASA grade 1 and 2 of age group 18 to 65 years of either sex were included. All the patients scheduled for elective surgery and requiring general anesthesia with direct laryngoscopy and endotracheal intubation were included in the study. The patients who refused for the study didn't give consent. Patients with anterior neck deformities and ASA grade 3, 4, 5 and emergency cases were excluded from my study. So the modified Malampati score was evaluated with the patient in the sitting position and neck held in neutral position and the tongue fully protruded without phonation. Preoperatively, patients were explained about the procedure and technique, and informed consent was taken. Patients were placed in supine sniffing position with a pillow under the occiput to achieve the optimum head extension and neck flexion. A 7.5 megahertz linear probe was used and was placed in the sagittal, parasagittal, and transverse view. Under all aseptic precautions, ultrasonography was done at the hide bone, and the distance of skin to hide bone was measured in centimeters. After the anesthesia induction, the laryngoscopy was carried out to differentiate easy and difficult laryngoscopy on the basis of the Cormack-Lehane score. Grade 1 and 2 were categorized as easy laryngoscopy, and grade 3 and 4 of Cormack-Lehane were categorized as difficult laryngoscopy. All the continuous data was expressed as means, and the categorical data was expressed as number of occurrences in persons. Laryngoscopy graded 3 and 4 were defined as difficult, and easy and difficult laryngoscopy were compared. ROC analysis was used to calculate the threshold for distance of skin to hide bone. The optimal cutoff values were calculated using Uden index as sensitivity plus specificity minus 100. The level of statistical significance was the p-value of less than 0.05, and p-value of less than 0.0001 was considered to be statistically significant. So the results were as, out of the 90 patients which were included in the study, 78 had easy laryngoscopy and 12 patients had difficult laryngoscopy. When I compared their modified Malampati score, out of all the patients with easy laryngoscopy, maximum of them had a Malampati score of 2, with 0 patients of Malampati score of 4. And out of all the patients which had difficult laryngoscopy, the most common Malampati score that was observed was 3, and 0 patients had Malampati score of 1. That means that Malampati score was also associated to differentiate between easy and difficult laryngoscopy. And the distance of skin to hide bone in the easy laryngoscopy group was, the mean value was 0.91 centimeters with a standard error of 0.01, and in difficult laryngoscopy was 1.48 with a standard error of 0.04. And the cutoff value for distance of skin to hide bone to differentiate easy and difficult laryngoscopy was 1.23 centimeters. So ultrasound imaging is has emerged as a novel, simple, portable, and non-invasive tool for airway assessment and management. There are other techniques also available like CT and MRI, but since they're expensive and unavailable in many operating rooms, ultrasonography is the most preferred one. It is inexpensive, rapid, and convenient to be used in the operating room. And most importantly, it can quantify the neck fat thickness as accurately as MRI. So to clearly visualize the glottis and smoothly finish the intubation procedure, anesthesiologist needs to place the laryngoscope blade to the base of the epiglottis and then lift it up. Therefore, in addition to the performer's skill and experiences, many factors like dental status, mouth opening, oropharyngeal space, mandibular space, neck motility are also involved in the procedure. And the anterior neck soft tissue thickness at the height bone is also important to displace the glottis by the laryngoscopy blade. In this study, we found that anterior neck soft tissue thickness measured by ultrasonography at the height bone is an independent indicator of difficult laryngoscopy. And these are my references.
Thank you, Dr. Shilpi. It was a nice presentation. Over to you, judges.
Am I audible?
Yes, sir, you are audible. Good evening, sir.
Is there you see any difference between the skin thickness? I'm especially asking about the fatty patient. You have more thick neck, fatty neck.
Yes, sir.
So, is there any difference you will see that you was see that in a heavy neck patient or a thick neck patient? Is there any difference between the normal patient which does not have fat in the neck and those who have fat in the neck in difficulty in laryngoscopy according to your this study?
Yes, sir. The patients with a fatty neck who will be having a higher BMI, the distance of skin to height bone will be more in those patients. And as a result, the laryngoscopy will also be difficult in those patients, sir.
Okay, okay. And what your linear probe size?
Sir, 7.5 megahertz probe.
Okay, okay, okay. Okay, thank you.
Thank you,
Over
sir.
to Dr. Davar.
Okay, thank you, sir. Dr. Silpi,
Ji, sir.
Your study design is observational study.
Yes, sir.
Okay, and sample size, how much sample size you taken?
Sir, 90 patients.
How you calculate this?
Sir, it was, I just chose a time slot of 3 months, and whatever the maximum number was covered in those 3 months, I took that sample size. So it was 90 patients I covered in 3 months, so I took that sample size.
Okay, okay, okay. Thank you.
Thank you, sir.
Okay.
Thank you, Dr. Shilpi. Our next candidate will be Seetal and Sunny. Seetal, are you here now? Seetal, unmute yourself first of all. Then only we will be able to hear you. You were saying that you were there, but your audio was not coming. Seetal, unmute yourself. Yeah, you're visible, Seetal. We can see you. Unmute yourself. Seetal, be a little loud. Use earphones or something. Maybe your voice is not audible. Seetal, use earphones or something. Yes, yes, but your volume is too much, very low. Maybe you're not audible properly. Okay, share your presentation at least. Sheetal, your voice, you're not audible. No. Sheetal, you want to continue or you want to first take some time to see? What do you want? You can log in through another laptop or something. Hello? Judges, can you hear her voice?
No, no, no.
No.
She is not audible. No.
Okay. Okay, Seetal, you'll log in after again from the different device, okay? And we'll take you after some time. We'll move on to our next candidate, okay? Next candidate is Dr. Shreya Bagadia from MG Medical College. Dr. Shreya, are you there?
Good evening, respected seniors.
Yes. Shreya, please share your presentation. Shreya, are you sharing your screen?
Yes, I'm sharing. Good evening, respected seniors. Is the screen visible?
Only half of the screen is visible, Shreya, not full.
Yes,
Can you make it bigger?
Yes, ma'am.
Okay, you are using your mobile phone or what?
Yes, ma'am.
That's why your poster is not visible. Okay.
Ma'am, is it visible now?
You can make it horizontal so that it is visible, because right now it's not visible, way less.
Okay.
Make it horizontal so that, and then you scroll it down. Yeah,
good
okay.
evening,
Yes, right. Good. Continue. Your time starts now.
Good evening, respected teachers. My poster topic is kyphoscoliosis and anesthetic challenges, a case of intestinal obstruction for exploratory laparotomy. Kyphoscoliosis describes an abnormal curvature of spine in both a coronal and sagittal plane. Kyphosis is a curving of spine that causes bowing of back. Scoliosis is defined as lateral rotation of the spine greater than 10 degrees accompanied by vertebral rotation. Effect of kyphoscoliosis on various organ systems. Respiratory system. Abnormalities in pulmonary function test. We will be seeing restrictive pattern, decreased vital capacity, decreased TLC, FRC, inspiratory capacity, and ERV. FEV1 is to FVC ratio remains normal. In blood gas abnormality in scoliosis, arterial oxygen desaturation, PCO2 and pH remains normal. Arterial hypoxemia is mainly because of ventilation perfusion mismatch, leads to respiratory failure if not surgically treated. In cardiovascular system, it may be associated with increased pulmonary resistance and pulmonary hypertension and can lead to right ventricular hypertrophy and right ventricular failure. It can be associated with mitral valve prolapse and cardiomyopathy. Antibiotic prophylaxis should be given before catheterization and laryngoscopy. Effect on joints and difficulty in general anesthesia. There can be associated temporomandibular joint ankylosis and restrictive flexion and extension of neck, which can lead to difficulty in endotracheal intubation. My case. A 54-year-old male patient came to outpatient department with severe pain in abdomen, abdominal distension, and vomiting since period of 15 days. He was diagnosed with intestinal obstruction and was posted for emergency exploratory laparotomy. On general examination, it was noted patient was conscious, oriented to time, place, and person. Pulse rate was 100 per minute. Patient was febrile with temperature of 100 degree Fahrenheit. Respiratory rate was 38 per minute. Blood pressure was 100:56 mm of Hg, taken in right upper limb in supine position. Saturation noted was 88% on Romeyer. His urine output was 200 cc over 10 hours and IELTS 2 was in situ. On investigation, spine examination of patient was noted to have severe thoracolumbar kyphoscoliosis with gibbous to the left side. Corpse angle measurement in our patient, corpse angle was greater than 100, which is suggestive of severe kyphoscoliosis. Corpse angle. It is the maximal angle from the superior end plate of the superior end vertebrae to the inferior end plate of the inferior end vertebrae. Hematological investigation were within normal limits. Urea was 60 milligram per deciliter, creatinine 1.45. Grading of severity of kyphoscoliosis according to Pope's angle. Less than 10 degree is normal curvature. More than 25 degree, echo finding of increased pulmonary arterial pressure will be noted. In more than 40 degrees, surgical intervention required. In more than 65 degree, restrictive lung disease. In more than 100 degree, dyspnea on exertion. And in more than 120 degree, alveolar hyperventilation will be seen. This is X-ray changes. It showed increased bronchiovascular markings suggestive of severe restrictive lung disease. Plan of anesthesia. Considering the respiratory status, it was decided to employ epidural plus spinal anesthesia as the anesthetic technique. Epidural anesthesia, after preloading with 1 liter of pistoloid and CVP measurement, which was 6 centimeter, epidural anesthesia was given. Epidural anesthesia given at L2, L3 interspace was selected, and loss of resistance to air technique was employed by paramedian approach. Epidural space was found at 4 centimeter and fixed at 9 centimeter from the skin. In spinal anesthesia with 23 gauge Quincke's spinal needle, 3 cc of bupivacaine and 25 microgram of fentanyl as adjunct was given and level achieved for T6. Epidural test dose of 3 cc of 2% lignocaine adrenaline was given. Then 6 cc of 0.25% of bupivacaine was given to achieve level of T6. Hemodynamics was monitored closely. Mean arterial pressure is adjusted between 20% of its baseline. When blood pressure dropped to 20% of baseline, injection mefentermine 6 mg was given. Then low dose of noradrenaline infusion started at 1 ml per kg to achieve mean arterial pressure of 60 mm of Hg. At the end of procedure, there was development of bowel edema, and it was difficult for the surgeons to close the abdomen. So surgeons requested for relaxation. Then we intubated the patient, and patient was mechanically ventilated for a period of 24 hours in ICU. Discussion. Anesthetic concerns for surgery included several restrictive lung diseases, ventilation perfusion mismatch leading to hypoxia, difficulty to extubate at the end of surgery if electively ventilated, difficult to wean off from ventilator. So regional anesthesia is the preferred anesthesia for such patients over general anesthesia. Pain management can be achieved by epidural analgesia and is very important as it facilitates early weaning off from ventilator and reduce ventilatory dependence. Conclusion. Anesthesia for patient with kyphoscoliosis is a great challenge to anesthetists, and anesthetists should be prepared with all the various suitable anesthesia options to effectively manage such patients. Here we effectively manage a case of severe kyphoscoliosis posted for exploratory laparotomy with balanced anesthesia techniques. We electively ventilated the patient for 24 hours in ICU, and patient was given epidural infusion for pain relief and for achieving good hemodynamic stability. Because of difficulty in conventional regional technique like epidural and spinal anesthesia, an anesthetist should employ techniques such as USG guided epidural and spinal anesthesia for better visualization of epidural and spinal spaces and to achieve great success rates in such patients. These are references. Thank you.
Am I audible?
Yes, sir. Yes, sir.
What is the grade of your patients in this case?
Sir, it is included under grade 5, sir.
Grade 5. Okay, you are saying in conclusion that it should be balanced anesthesia. Okay, you give epidural, you give spinal, and then finally give into the GA. Is this ideal? Is this ideal for this patient as a balanced anesthesia?
No, sir. It is because there was no relaxation as per surgeons, so it was required at that time to. It was not included under balanced anesthesia. Just spinal and epidural would be
also given the epidural anesthesia already. You can giving the supplemental dose. So abdominal relaxation can you achieve because you did the well level of epidural anesthesia L2 L3.
Yes, sir.
So that is this epidural is feasible or not a good choice for the patient?
Yes, sir. Epidural was combining CAC.
Is this working in the post-operative period also?
Sir, for
Epidural.
yes, sir, epidural 1 day, 1 to 1.5 day we have kept. Matlab, the catheter was there, and we have given infusion, sir.
And you are in infusion. Which infusion?
Sir, bupivacaine 0.065%.
0.65% is not for the such a big surgery for analgesia. You should use some higher doses. Okay, is there any difficulty you are facing during the intubation in this case?
Sir, we intubated with small sizes, size ET tube, sir. And restrictive length.
There is no need to do the small size. I am asking about the during laryngoscopy, patient have kyphosis also and scoliosis also.
Yes, sir.
So there is maybe need for manipulation. Some during laryngoscopy. Doesn't mention the difficulty in laryngoscopy. So I am asking about the what are difficulty you are facing during the emergency laryngoscopy or emergency intubation at the time of closure.
Sir, there would be restricted flexion movement and extension of the neck. So, by asking our colleague to manipulate the cord and to have bougie ready with us, we have intubated, sir.
You should mention intubation also in this poster because it is much more important than your regional anesthesia at the time of closure. Okay.
Yes, sir.
It is also a more important point in your case. Okay.
Yes, sir.
Okay. Over to Dr. Dawar, sir.
Okay, sir. Thank you, sir. Dr.
Hello,
Shreya.
Dr. Dawar, sir.
Yes, sir. Thank you,
Okay,
sir.
sir. Dr. Shreya.
Yes, sir.
What is blood gas abnormality in such cases?
Sir, we will be seeing saturation percentage.
No, I am asking blood gas abnormality, ABG. Have you taken an arterial blood gas sample?
Yes, sir. We have taken. We have just. We have seen saturation in ABG as well, but rest of the other findings came normal, sir. The PCO2 and pH was normal.
Okay. How you check validity of ABG sample?
Sir, by seeing SPO2 percentage.
No. Okay. Okay. Thank you.
Okay. Thank you, Dr. Shreya. Our next candidate is Dr. Srishti Chandravanshi, and she is from MGM Medical College, Indore. Dr. Srishti, are you ready?
Hello.
Hello.
Hello. Good evening, ma'am.
Yes, Srishti.
Ma'am, am I audible?
Yes, Srishti, you're audible. Please share your screen.
Yes, ma'am. Ma'am, is screen visible?
Yes,
Hello?
it's visible. Okay.
Ma'am, can I start?
Your heading is not visible. Okay, start.
Good evening, respected judges and seniors. Today, I'm presenting poster on anesthetic considerations for post-COVID-19 mucormycosis surgery.
Shreya, your
known as zygomycosis or phycomycosis. It is an uncommon. Hello.
Hello, Srishti.
Yes,
You were not audible.
Hello.
Okay.
Ma'am, am I audible now?
Yes, please. Continue.
Shall continue, ma'am?
Continue, Srishti.
Is a opportunistic, aggressive, fatal fungal infection caused by fungi of the order Mucorales. Rhinoorbital cerebral mucormycosis is an aggressive, lethal, angioinvasive fungal infection that has presented as an opportunistic.
Hello. Dr. Srishti, you are not audible.
In the background of highly infectious and severe second COVID-19 wave in India and predict rise in hospital admission with moderate to severe. Hello? Hello, I'm
Yes,
audible now, sir?
Shrishti, actually, in between you are something, your voice goes down, or because of the net or something. Okay, start, continue, na? Be a little fast then.
Yes, ma'am. Yes, ma'am. Risk factors for mucormycosis is poorly controlled diabetes, use of corticosteroids in severe COVID pneumonia, interleukin therapy, primary or secondary immunodeficiency, hematological malignancy, solid organ transplant, and iron overload. How we'll see patients. How we'll evaluate patients of mucormycosis, we'll see in three different headings. First is pre-operative evaluation. We'll take history of comorbidity, hospital ICU admission. We'll take history regarding medication. Medication like steroids and immunosuppressant. We'll ask for routine blood investigation. We'll do 6-minute walk test, fresh chest X-ray, CT thorax, ABG, TROPI, ECG, echo, MRI brain for infarct or NCCT head for bleeding. We'll see normal blood. We'll see blood sugar level, HbA1c, blood electrolytes, D-dimer, PTINR, and platelet count. We'll do fresh. RT-PCR before taking patient into the OT, and most importantly, we'll also do airway assessment and front of neck assessment. Now, how we'll manage preoperatively? We'll since all the patients are ASA grade 3 and above, we'll take written and informed consent. We should have a difficult airway cart ready. We should stop aspirin and continue aspirin and stop clopidogrel. We should do appropriate bridging therapy with heparin, and we could also do insulin infusion to maintain sugar range of 140 to 180. And if potassium levels are if potassium levels are low, then we could preoperatively supplement with potassium infusion. Intraoperatively, we can manage intraoperative by we can give two mode of anesthesia to the patient: general anesthesia for extensive debridement, maxillectomy, and CNS involvement, and regional anesthesia with sedation for endoscopic debridement and minor debridement. For general anesthesia, opioid and IV anesthetic should be administered as per the ideal body weight. Induction with intravenous and inhalational agent. Difficult airway cart should be ready. Intubation with video laryngoscope or flexible fiber optic bronchoscope. Neuromuscular monitoring and administration of adequate muscle relaxant. Nasopharyngeal airway till extubation should be kept, and we should extubate after the return of reflexes like swallowing reflex, gag reflex, and after patient is fully awake. For minor debridement and endoscopic debridement of nasal sinuses, we could, first of all, difficult airway cart should be ready, and we could sedate patient with pentazocin, either dexmedetomidine or promethazine, with regional nerve blocks like anterior alveolar nerve block, middle alveolar nerve block, and posterior superior alveolar nerve block. And during the procedure, we could oxygenate. We will oxygenate patient through nasal prongs, and we'll do monitored anesthetic care. Post-operative management, CPAP machine post-operative could be required for ventilation and oxygenation. We should keep eye on the blood loss during the surgery and replace post-op or inter-op, or there could be requirement of post-operative ventilator and intensive care unit. Hypokalemia and hypomagnesemia should be managed post-operatively. Delayed or inadequate reversal should not be done. Adequate reversal should be done, and post-operatively analgesia should be adequate for the patient.
Thank you, Dr.
Thank you, ma'am.
Over to you, judges.
Okay, Dr. Srishti. what are the significance of 6-minute walk test in this patient?
Yes, sir.
Am I audible? What are the significance of 6-minute walk test?
Sir, 6-minute walk test.
6-minute walk test.
Sir, as most of the patients are post-COVID recovered patient, so 6-month walk test is very important to assess. We cannot assess cardiovascular or lung function by a routine pulmonary function test or exercise tolerance test. So 6-month walk test is used to see their pulmonary and cardiac function are adequate or not, and how easily a patient are going into fatigue.
So in which unit we can use the 6-minute walk test?
Sorry, sir.
Sir,
can you repeat?
What are the unit in which you can measure the 6-minute walk test, positive or negative?
Sir, generally we take 12-meter space and ask patient to walk there, and we multiply 12 by how much patient like 20 rounds or 30 rounds we calculate by multiplying them. So for normal patient it is 40 rounds or more than 40 rounds.
Okay. Dr. Davar, you can ask the question.
Okay. Dr. Srishti?
Yes, sir.
Any difficulty you face during intubation?
Yes, sir. Most of the patients have generally the mucormycosis starts from nasal cavity and it goes then from here it goes to maxillary sinuses, and so the palates are usually infected, and most of the patients have facial deformity due to COVID, and extensive sinus and palate involvement can cause difficulty. Plus nasal airways. Nasal cavity is also first involved. So nasal intubation is also difficult in these patients.
Okay. And debridement with, hello, am I audible?
Yes, sir. Yes, sir.
Debridement with regional and under sedation, what specific post-operative care you suggest for such cases?
Sir, post-operative, sir, vital monitorings are important, and since if we excessive use such sedative like opioids or dexmedetomidine, so they can cause respiratory depression. So vital monitoring is very important, and vital monitoring and saturation are most important in post-operative with sedation.
Okay, thank you.
One more question.
Yes, sir.
What is the need of using nasopharyngeal airway in this patient?
Sir, since so the airway is very difficult, so after until extubation, we should keep nasopharyngeal airway in situ, so that if a patient is not like at end of surgery, if patient efforts are not adequate, so we could secure our airway.
Actually, I am asking this question. Actually, these patients also have mucormycosis in the nasal mucosa, which was damaged the palate. So, is this feasible to place the nasopharyngeal airway in this patient?
Yes, yes.
Sir, in some patients with
your statement is your statement is applied to every mucormycosis case. So, is it right to use in specific cases? No? Not in every cases.
Yes, sir. Yes, sir. Not in every cases.
Yes, right. Oh, thank you.
Okay, sir. Thank you, sir.
Thank you. Thank you, Dr. Srishti.
Thank you, ma'am.
This one will be the last poster presentation. The remaining 3 candidates will have to go to Hall A because we are running late for GBM session. So they'll be informed. The last one is Dr. Seethal. Are you there now? Are you ready?
Ji ma'am, I'm ready. Am I audible now?
Yes, you're audible. Please start.
Thank you, ma'am. Can I start?
Yes, you will start.
My screen is visible, ma'am?
Yes, your screen is visible.
Thank you, ma'am. Good evening, respected judges. Myself, Dr. Sheetal and Sunny from GR Medical College, Gwalior. Here I'm presenting a poster on the anesthetic management of a child with giant occipital encephalocele under the guidance of Dr. Seema Shinde and Dr. Dilip Kothari, head of the department. Coming to the introduction, the congenital defects in the bony cranium leads to protrusion of the intracranial contents beyond the normal confines of the skull and give rise to either meningocele, meningoencephalocele, or at times meningoencephalocystocele. And airway management in newborns with craniofacial disorders remain as a great challenge to the anesthesiologist. Many factors like disproportionately sized head and body and unstable head and neck creates difficulties in tracheal intubation. It becomes more difficult if it is compounded by a huge occipital mass, which is almost double the size of the head. In such cases, difficult or failed tracheal intubation is anticipated. Coming to the case report, here we have a 25 days old male child, male baby weighing 3 kg, and it presented with a giant occipital encephalocele for surgical excision and repair. And history and clinical examination revealed no other congenital malformation associated, and the mass was situated in the occipital region with a size of 25 into 18 centimeter. And the investigations and biochemical parameters were within normal limit, and the baby was posted for surgical excision. On the day of surgery, baby was shifted to the operating room. No sedative premedication was required, and baby was kept in lateral position. All the vitals were attached, and a pediatric difficult airway cart was kept ready to deal with any possible airway emergency. We decided to go ahead with induction in lateral position, keeping in mind the possible need to turn the baby supine with cyst support in case ventilation or intubation was not possible in lateral position. Intravenous premedication was carried out with atropine 0.02 milligram per kg, and we were able to ventilate the baby in lateral position. So after inducing with injection thiopentone sodium 5 milligram per kg, we have given the baby succinylcholine 2 milligram per kg, and tracheal intubation was attempted in lateral position. And 2 attempts of direct laryngoscopy, short tip of epiglottis, and we could not intubate the baby. The child was then put in supine position with body on a platform made by keeping pillows on the top of each other until the height matched to that of encephalocele, and the swelling was being kept inside folded drapes which were made into donuts since we were not having appropriate sized head ring. And laryngoscopy in this position improved the visualization, and we intubated the trachea with a 3 mm uncuffed endotracheal tube. And the anesthesia was maintained with oxygen, nitrous oxide. There were no intraoperative complications, and at the end of the surgery, we reversed the neuromuscular blockade with neostigmine 0.05 milligram per kg. And once the baby was fully awake, extubation was done, and the child was shifted to the postoperative ward. Coming to the discussion, there are many studies showing difficult tracheal intubation in child with encephalocele. So there will be a frequent association of Chiari malformation, coexisting hydrocephalus, craniofacial abnormalities, micronathia, and reduced mouth opening, neck mobility, and this can lead to restriction to the movement of the head and neck. So endotracheal intubation in lateral position
There is no voice of candidate.
Hello.
Yeah.
Hello, Dr. Sita. Hello. You're not audible.
Not audible.
Not audible. She's again gone, sir. Hello, Dr. Seaton. Do you hear us? So, can we move on? So this was the last poster presentation for Hall A. As we are running late for GVM session, so you have to start with the GVM session. Thank you, judges, so much. Thank you, Dr. Vijay sir. Thank you, Dr. Shalin sir, for joining us in this session.
Thank you. Thank you. Thank you.
Thank you so much, sir. We'll be starting with the general body meeting session in Hall A, which will be hosted by Dr. Amit Jain sir.
Hello. Good evening to all. I am audible. Hello.
Yes, you are audible, Amit.
Yes, yes. Sir, thank you, sir.
Dr. Amit, you are audible.
सर मैं आप ही को बस ढूंढ रहा था सर कि आप मिल जाओगे तो जीबीएम मैं करवा पाऊंगा. दिस इज द फर्स्ट टाइम मुझे ये अपॉर्चुनिटी दी गई है. तो जैसा जैसा मुझे मेरे सीनियर्स ने बताया, फर्स्ट थिंग वेलकम टू ऑल ऑफ यू. और अब सेशन ओपन है, जो भी जनरल बॉडी के एजेंडास डिस्कस करना चाहें हम वो कर सकते हैं. मीनवाइल ऑल द पीजी स्टूडेंट्स आर रिक्वेस्टेड टू जॉइन दिस जीबीएम फॉर अ announcement of the all the results except the poster session 3 and poster session 4 which are going right now. So sir, if any discussion on a general topic for a MP purpose, so it is open for now.
Amit, please hand over to president or secretary.
Sir, right now.
ISM state.
Okay, sir. Sir, right now we have Lalit Pandey sir with us, which is right now present secretary for us. President is not available. The past president also is not available with us, and present president is also not available
Give
with
it
us.
to Jiten.
Sir,
Dr. Jiten Agarwal. Hand it over to Dr. Jiten Agarwal.
Ma'am, Dr. Jiten also sent a video to me, and he was saying he will be here, but as much as I am able to look the session, he is not here. Just give me a minute. I am requesting him to join the thing if he is able to do.
Sir, good evening.
Sir,
Pranam, sir.
Sarvancharesh.
Agnihotri sir, pranam.
Namaskar, namaskar. I am waiting for your meetings. Don't worry.
Sir, good evening. Pranam, sir. Aurora, sir, pranam, sir.
Sir, good evening.
Sir, namaskar, sir. Sir, VM, sir, good evening.
Good evening, Bhaiya. Good evening. I am just waiting to see how nicely it is conducted.
Sir, good evening, sir. VM, sir, good evening. कल आप आए नहीं, sir?
Sir, I talked to Dr. Jiten sir. Right now he will be joining the meeting within a few minutes. But he requested to Dr. Lalit to take over and to start the conduction of this meeting.
Hello. Hello. Is my voice is audible?
Yes, yes, you are audible.
Yes, you are audible.
Good evening, everybody. First of all, I should thanks to the Sagar ISA Sagar Society. Hello.
Hello.
You are audible, sir. You can continue, sir.
Please continue.
And I want to congratulate them for conducting such a nice conference. I have discussed with Dr. Jiten, so he told me he has already sent a secretary report in video form, and he has told me that he can continue the further proceedings. First of all, he announced for this thing executive post. There were 3 posts. He was confused, but there were 2 posts only of 2017, and 2 posts got vacant, and the resignations were accepted at the time of election. So there are total 4 posts of executive members. I discussed with Dr. Sudhakar Devegi also. So he told that on my behalf, he can take the decisions and he can conduct the meeting. So, hello. Hello.
You please start with the agenda, not with the introduction in between.
Achha. So, sir, I invite the members of ISA MP State Chapter to, if anyone wants to contest for the post of executive, they are welcome.
Ravi,
Ji,
how
sir.
you are declaring the things?
Yes, sir. Yes, sir.
You declare any city branch is interested to conduct the next conference, please welcome. Falana, what you
Achha,
do?
sorry, sir. Sorry, sir.
That's
Sorry,
why I request Dr. Arora, please follow the agenda which was circulated amongst governing councils. Please.
Okay, sir. Sorry, sir. So, as Dr. V.M. Agnihotri sir told us that is any other city branches in the coming year is interested to conduct MPIC State Chapter Conference, they are welcome.
Whose turn it is now?
Actually, Viva has told that if it is physical, they are going to take this opportunity of conducting a conference next year.
Last year they conducted, Riva conducted last year, this year Sagar conducted.
No,
But Sagar
webinar,
came in
webinar.
between.
No, people have asked about them that are they going to conduct for the webinar, this thing, virtual conference. So they say once they have conducted, now they are more interested in the physical
Their turn
conference.
is over now. So next turn, whose turn is next?
Oh, they told that they will conduct in a physical form. Whenever there will be a physical conference, they have not
Let their
refused for
turn
that.
come now.
Okay, then if it is Riva is over and Sagar is over, then I think now it is the turn of Gawaliar.
Yeah.
Now
Okay.
it is the turn
We'll
of
ask Gwalior people to conduct the conference next then.
Gwalior or Jabalpur, I think.
Jabalpur.
No, sir. Gawaliar, then Bhopal, then Jabalpur.
Okay.
Okay.
Okay,
Gawaliar, then
fine.
Bhopal.
Then we'll ask Gwalior to conduct the next conference then.
Jiten is there on
So, anybody from Gwalior City branch president or secretary?
Any office bearer from Gawaliar?
Nobody is seen.
Then anybody from Bhopal?
You are from Bhopal?
Yes, sir, I am
Dr.
not office.
Akbar is there.
I am not office bearer, madam. I am just IS member, madam.
Yeah.
New governing body has formed yesterday.
When the governing body is not there, one of the person who is representing Bhopal can take care of that and then conduct it, convey it to the office bearers.
No, no.
How the oath of the new governing council members has taken without the general body.
Okay.
Now the general body will approve the election petitions and then they were declared as elected. Now they can take the oath. Otherwise their oath is invalid.
Right, sir. But there is nobody from the office bearer except Dr. Lalit Pandey.
Then accept their resignation just now.
No,
throw
sir,
them
sir,
out
sir.
of the
No, they are there. They are there. Dr. Sudhakar has got some problem in conducting the meeting. He
I
cannot.
agree with individual,
Yes,
but in general, if they are not there, throw them out of the council.
No, sir,
And
everybody
keep
is there. Everybody is
simple.
there.
It is a job of
Everybody is there.
secretary.
Vice President is there. Dr. Ruchi Kannan is there, and Dr. Manta Mahobi as a treasurer is also there in this one.
Any person from Bhopal is coming out for the consent for the conference, yes or no? Simple.
Sir, I am present, Dr. Vikas Gupta from Bhopal, sir.
Yes, welcome.
Sir, if we can take, sir, we are ready to take the conference for the next year, sir.
Okay, then I second it. Then
I accept it, but subjected to the refusal by the Gwalior.
Yes, sir. If Gwalior
Dr. Jiten, then who will decide when they will send the refusal?
Ask Dr. Jiten to join.
Dr. Jiten has joined us, so we can ask that to Dr. Jiten sir. Dr. Jiten sir.
Please ask him. Please ask him.
Sir, Dr. Jiten sir. Hello. Dr. Jiten sir, please tell next turn is supposed to be a Gwalior one of a state conference.
And now it will not be virtual, it will be physical. Don't
Yes,
worry.
sir.
it is offline.
Dr. Jiten sir, please unmute to yourself and please tell us what is the status of a Gwalior for next state conference.
Amit, one should clear. Yeah.
Yes, sir.
Jitendra is office bearer representative or not?
Sir, right now, I
office,
can say.
is office bearer of the Governor City branch.
Sir, I have no idea whether sir is office bearer or not, sir.
So we are giving conference to the city branch.
Yes, sir.
Dr. Raikwar, he can take consent from the office bearers, and on behalf of office bearers, he can convey it to us here.
Okay,
in
madam.
The GBM.
Okay, madam. No problem.
Because
They will never accept it.
Yes, sir.
I hope now the Bhopal is to be given outright consent to continue the conference. Simple. Because you will never get the reply from Gwalior.
Hello.
Sir might be
Sir,
more
can
sure
I
about
talk?
it.
Hello.
Hello.
Can I talk? Sir, I am Dr.
Yes.
Ashish Mathur from Gwalior.
Okay.
I just had a talk with Dr. Jitendra Agrawal as he is not able to connect, but he gave the consent to organize the state conference in Gwalior in next year.
Fine.
Okay, fine.
Accepted.
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 Simple, no problem.
Okay, thank you, sir.
Thank you, sir. Thank you.
So next state conference will be held at Gwalior.
Okay.
ISS City Branch, Gwalior. It's okay.
And
Congratulations, team Gwalior. Sir, please. PM sir कुछ बोल रहे थे, please.
Sir.
Hello.
May I ask one thing?
Yes.
Can he, in the as per the rotation, if Gwalior is accepted, is most welcome. But can you allot the next conference also? So next
That
will
is
be
Bhopal,
prepared
sir.
for that thing.
Sir, that is Bhopal.
Sure,
Next is
sure, sir. I think as per nature, we should also plan for next 2 years. No?
Yes. What is wrong in that?
Yes.
If they accept it.
No problem, sir. No problem, sir.
There
After
is
that,
always
the term of
problem
Bhopal is
subjected to that, you accept it. That's all. No, because my person is this. Suppose the same thing is decided in the last conference, this problem would have not occurred to us.
Yeah,
somebody
actually, sir.
Yeah, yes. हाँ यदि लास्ट ईयर रिवा में वो ज्यादा डिसाइड किया अभी इस साल इतना वो डेट वो नहीं होगा.
If they give tentative consent, what is wrong in that?
Yeah.
Yes.
So 22 Gwalior, 23 Bhopal.
Yes.
Bhopal.
Yes,
Yes,
agreed. Finish.
23 Bhopal. Sir.
Sir, I have got a video from the secretary side and president madam. Can I show the video in front of you, sir?
Yes, please.
Jiten, good evening.
Sir, now Jiten sir is live, so I hope so Jiten sir can give whatever the blessing he was given in the video, you can give directly, sir.
Whatever I have given, that's already you have organized a well-planned conference with a good topics. And so what can I say now? You have already done a good job. Now my best wishes for you to have a good city branch, doing good academic work ahead, and best of luck.
Thank you, sir, for your kind words, sir. Sir, now I would like to play the video given by the Dr. Meenu Chadda madam. Whatever she told to us and for that other thing.
Hello.
What is next agenda?
I'd like to congratulate the Sagar City branch for holding such an amazing conference. My best wishes to the City branch for their future endeavors. And with this note, I would like to hand over my charge to Dr.
What is this here? What is next agenda?
Hello.
Just
Hello.
video of Minu Chadha madam is coming.
No,
for the-
all this should come to the vote of thanks, right?
This is validatory function. This is not GBM.
So it
Madam,
is GBM.
Madam, validity and GBM combined, we have done. Madam, the vote of thanks from the Minu Chadha madam also. And
You clear first part, then second part, or second part, or first part. Whatever you decide.
Sir, I have got a one video only from her side.
Don't
Sir.
overlink.
Sir, I have got a one video from her side, having a both things, sir. That's why, sir.
If you are managing both the things, thank you. You manage it.
No, sir, I am not managing.
The main problem of the state is not to be discussed. You want that thing.
Sir, I am waiting
Because
for
the other problem. No. Please listen. It is general body. The first priority is to
Problems
discuss
of the-
the state problems.
What are the state problems,
Which
sir? That's
the
why.
other members or other wants to talk. They should come forward.
Yes,
You
sir, I am
will
waiting,
get
sir.
all the best wishes. There is no doubt about it.
Sir, I am
And
waiting
you
for
have done
all the
the
problems, sir.
commendable job. There is no doubt.
I am waiting for all the problems to be discussed here, sir. I will be very happy.
I think Dr.
Agenda-
Akwar should take the initiative in this terms. What I am suggesting, okay, please go ahead with the problems of other city branches and all the things. So matter should be in the continuation. In between, it is disturbing the channel. Otherwise, it is the job of secretary to take over. I have got nothing to against anybody. Please go ahead as you wished and as you have planned.
I think all the agendas like what the expenditure, balance sheet, and what is the further planning for the states, and like वो MOU sign हो रहा था कुछ वेब कॉन के लिए
मेडिकल लर्निंग हब
हाँ जो भी कुछ है तो बेसिकली या तो लास्ट जो अपना आउट गोइंग सेक्रेटरी है वो एजेंडा वो अपना सेक्रेटरी रिपोर्ट
It is his job only. It is his job.
हाँ इट इज हिज जॉब
Yeah.
या तो वो करें या फिर अपकमिंग जो है उनको कुछ उन्होंने मैसेज कन्वे किया हो तो ये कर दें दो में से कोई एक कर सकता है
Okay, it has to be done by Dr. Jiten.
Madam, if
He has to give his secretary note.
if he is not giving, so he told to the Dr. Lalit he will present
Yeah.
on behalf of Dr. Jiten of last year, last 2 years, whatever they did for the states.
Apart from secretary report, the MOU with the medical learning hub has already been done. We are already doing the workshop with the medical learning hub, and rest of the things I have already mentioned in the secretary report. As I cannot speak so much.
Where is secretary report? Because you have signed the MOU without passing in the GBM. How it is possible?
Sir, at the time of COVID, there was only medium of communication was only webcons.
I don't think so. You can arrange one webcon or Zoom meeting for that.
It was with the discussion of treasurer and president.
No, not at all. Not at all. You can before signing anything, you should call for the GBM.
Sir, how it was possible in last year 2020?
Okay. If you are signed that, so you should take anumodan from the GBM.
And this can be done, sir. This I understood. This should be done.
This is not the right way to sign anything before putting matter into the GBM. I don't think so. This is the right way.
So last year this was not done.
So what? If it is last year not one, so why you have signed the MOU?
But because we want to do the communication via the virtual platform. And nobody was giving us the virtual platform. It was also only.
I am not accepting this. I am against this.
In the last 1.5 years, there are so many platforms available now, and we are so used to it. But at that time, nobody was available.
I am against this. I am not passing this because when you are doing election or anything, you can arrange a Zoom meeting for any. Zoom meeting is going on in between. So you can call any meeting.
Sir, this is you are saying because in the last 1.5 years you are used to the Zoom meetings, but at that time when the COVID started, there was no platform like Zoom meeting was not so common, and we we have not done so कि agenda में ऐसा कुछ नहीं है उसमें MOU में. We have discussed with the president, with the treasurer, and with the executive member of the state, Vikas Gupta and Subodh Chaturvedi.
Your office bearer has decided, na?
Yes, sir.
So what about the general body? If you are taking any major decision, it should be passed in the GBM. I don't think so. This is the right way. I don't think so.
Sir, जब कुछ हो ही नहीं रहा था, तो GBM कैसे होती?
तो फिर वो भी नहीं होता, फिर वो भी नहीं कराना था.
तो सर वो तो 1 साल का था, अपन उसको वो कर सकते हैं अगर आपने वो कैंसिल करना है तो.
नहीं करना नहीं, वो तो हमारे हिसाब से तो हुआ ही नहीं है, फ्रैंकली स्पीकिंग. एज ए IAS मेंबर वो तो हुआ ही नहीं है, क्योंकि आपने उसको पास ही नहीं कराया, तो कैसे मानने की हुआ है वो?
पास तो GBM में ही होगा ना.
हाँ, तो कोई भी GBM में मीटिंग में होगा, आप ये कह सकते हैं. अगर आपने कर लिया तो उसको कैसे बोल सकते हैं कि वो हो गया? आई डोंट थिंक सो. BM सर, आप कुछ बोलिए सर इस पे.
He should have taken the consent in this GV for the
That's I am telling.
Okay. So I'll hand over it to Lalit Pandey, sir.
No, Charles handover is not a problem. Problem is that you should have taken the consent. Now you should have declared that you have taken the consent in your report. That would have been easy and comfortable for the association.
So I have taken consent of the office bearers.
Yes, I agree with you. I agree with you in that field that you have taken the consent of governing council. But when the matter of finance exceeding comes, it is the general body which finally endorses the requirement. Please. Understand?
Yes. Okay, sir.
There is no harm. Now you ask it. What is there?
Okay, sir.
You request to the president that this is what has happened, and now please grant me the permission. Past permission is to be endorsed. That's all.
Okay, sir. So right now, can I put this agenda?
You take the permission of president.
So current president or the Meenu madam?
If you say current president, then you are not secretary.
Yes, sir. Already I have handed over the charge.
But you have to take the permission of Madam Meenu Chadda.
President.
Sir, वही तो मैं कह रहा हूँ सर. पांडे सर ने कल ही चार्ज ले लिया मेरे से.
Sir, actually
चल गया. Past is past. आपको मीनू चड्डा से ही परमिशन लेनी पड़ेगी to put up this thing in the lieu of this deficiency.
सर लास्ट टाइम मीनू चड्डा मैडम से तो परमिशन ली. अच्छा, उनसे बोलूं कि अभी GBM में परमिशन लेना है.
Yes, you asked just now because it is modification now.
Okay.
You have not declared. It is the fault or it is the overlook of the secretary that you have not informed the members. That's why the things are occurring. So there is no harm. You ask them, I am taking such permission, and you go ahead, finished. I presume she will say yes.
Okay. मैं मीनू मैडम ऑनलाइन नहीं है. मैं मैडम से फोन पे बात करके आपको दोबारा बात.
No, you go ahead. You go ahead with the request. Na? What is wrong in that?
I request Meenu madam that last year.
On behalf of Meenu madam, you are requesting that last year such things are happened. Kindly grant the permission of my past deeds. That's all.
Okay.
And it should be the writing. It should be endorsed in the minutes of the meeting.
So on behalf of the madam, the permission of MOU with the medical learning hub that we have done in the past, but I have not taken the consent of the members of the GBM. So I am putting this agenda in the meeting right now.
He approved it. That's all.
Thank you, sir.
You ask your secretary, present secretary, to approve it. He will ask the general body members will say give the approval. That's all.
Lalit sir, आप present हैं? Lalit sir.
So right, sir.
Lalit is not seen. Dr. Lalit is not seen.
Lalit sir.
Anyway, this is my
I am
This
there.
is
I am
my
there.
objection, and I am trying to overcome this
Who is there?
objection.
I am there. I am there.
Okay, go ahead now. You accept that?
Sir, please give the permission of this thing MOU signed by Dr. Jitain and Dr. Meenu ma'am to continue with the medical learning hub in future also.
So you are approving endorsement by the general body.
हाँ.
यार बोलो भाई.
हाँ, hello.
हाँ सर, आप approve कर रहे हैं?
I need the members' approval, please. Hello.
There is nobody to raise the hand, so it is presumed that it is accepted.
It is presumed that it is accepted.
Thank you, sir.
Thank you, sir. Thank you.
Now Dr. Rakwar should take over.
I think Dr. Jitendra or Dr. Lalit Pandey, they will decide, sir, because outgoing and incoming secretary they are. Otherwise, next
And
agenda
to be continued or not to be continued will be decided by the present team. That's all.
okay. Okay, sir, it's okay.
That's fine.
Yes, sir.
That they have already done. So what to do? You cannot reverse it.
No, we can.
accept it.
We can.
Yes. So now it is the decision of the president, current team to decide it to continue or not to continue with the same person or new form, whatever they like.
Accepted, sir. Accepted.
Okay.
What is the next agenda, Dr. Lalit or Dr. Jitin?
Hello.
They don't know. I want the strength. Total registration this year than last year of ISA MP chapter. New members. And how many members we have lost? I don't know the statistics.
Dr. Dr. Jitendra Agrawal will be telling
Answer,
us,
definitely. He will give answer, but he is not.
but he's not there. I knew I lost my teacher, Dr. K.P. Chansoria, sir.
Yeah.
One member.
This is general body meeting, Rakwar.
जी सर एक्चुअली सर वो प्रॉब्लम इज दिस कि वो इनकमिंग और आउटगोइंग सेक्रेटरी का जो हुआ है सर तो उन्होंने प्रॉपर
how they have accepted hand over the secretary charge, I can't understand.
Sir,
it was a national body.
There is a two reports then actually, last year report and this year report.
Actually, sir, what happened when the election is notified, they have decided, they have declared in the notification, जहां जहां इलेक्शन हो रहे हैं वहां पर चार्ज हैंडओवर और टेक ओवर 16th of October को होगा 2021 को सर. They have decided, they have notified this.
Yes.
So that's why
Agreed.
That's why yesterday the societies उन्होंने हैंडओवर टेक ओवर कर लिया सर.
Okay, I accepted it. Now how you will know how many persons are survived, matlab joined as a member, and how many is confirmed as a life member, how many we have lost with our colleagues, how you know, and how many persons are endorsed in the family benefit scheme.
I think, sir, this is the duty of the past secretary and upcoming secretary.
They should coordinate, no? That is my question.
Definitely.
That is my question.
They will
should have
coordinate.
coordinated it.
They will coordinate.
They should coordinate and let the member should know within 15 days.
Okay,
Yes, sir. Yes, sir. I will do it, sir. I will do it. Within 15 days, I will call a Zoom meeting and will let you know.
My dear friend, why I am asking is very simple.
Yes, sir. Yes, sir.
Because Dr. Rakwar is already requested to upgrade your membership in the head office.
Yes,
if you don't know this much, then there is no fun of doing this and by the time is over and it will not be updated and the members will be denied their voting rights.
Yes.
It's very simple.
No, sir, I have tried my best.
MP will be lagging behind by miles.
Yes, sir. You're right, sir. You're right. I have tried my best that day. I had a discussion with you regarding the associate life members or inactive members to support to become the life members, but somehow some people have taken interest and
I wish you should coordinate with Dr. Rakwar and update the list and then only you will know.
yes, sir. Yes, sir. I will do it, sir. I will do it. I will do it.
I will help definitely.
I had a discussion with
Because
Dr.
I
Subu.
don't think, Dr. Akbar, this is my apology to you that you are not aware of the things. That's why you cannot upgrade it.
Yes, definitely, sir. I know.
That's what I am. That's what I am requesting to the President Secretary. Please take some steps as early as possible, so the members should be not be denied for the rights of voting.
Please activate ALM or inactive member to a live member. It is my request to upcoming secretary.
No, sir, we have to find a way out because
Dr.
communicating
Lalit, now in few days we will be having national elections.
no, for that
So
it
we
is
should
not
have more
possible.
members from our side.
Yes, sir. Yes, ma'am. Yes, ma'am.
So please
I have
update
tried
the
my
list as
best.
early
I
as
have tried
possible.
my best, but somehow the other members are not getting it. They have tried. Sometimes they got the screen hang, and once or twice they have also sent the papers. So they have tried their best, members, and later on they said, sir, it is not getting done. So we have to make some easier way to get their associate life members or inactive members to become the life members. Similarly, few members.
May I request Dr. Sadhana, you are elected president.
Yes, sir.
Take responsibility of this thing, so the member of MP should not be denied from this thing. Please.
Right, sir. Right, sir. I'll do that.
You
I'll coordinate
contact
with
and
Dr. Lalit and
coordinate
do
the
it.
things as early
Thank you,
within a
ma'am.
week.
Right,
It should
sir.
be updated.
Right.
Any cost.
Accepted. Accepted.
Thank you very
I'll
much.
do that.
Thank you, ma'am. Thank you. I have tried for ISABF also for my teacher, Dr. Chansoria sir, because he was the oldest member. I talked to Dr. Subu Varghese also, but he told that no, we cannot go for it because Sarkar membership बहुत पहले वो हो गया था, expire हो
He
गया.
was defunct in the
Yes,
payment.
sir. Yes, sir. Yes, sir. Yes.
Yes, sir. I don't think a association knows, MP chapter knows how many members are in the family benefit scheme in MP.
So there are very few members, very few members.
There is in English, it is few, but there is a count known as the 17, 18, 30, 50.
Not more than, hardly, sir.
No question of hardly. I want statically how much.
No, you will
That's
get
all.
it. You'll get it. I've got that list.
Sir, we should accept that GVM is not been properly planned out and we are been just haphazardly moving around with each
No,
agenda
madam,
actually.
madam, listen one thing. You are sitting on the responsible post. You have to fulfill some constitutional criteria of ISA.
Right, sir.
And this is the part of Indian Constitution of ISA. And I am sorry, I am interrupting all these things. Being a senior person, I cannot digest the things so lightly.
No, so we apologize for that, sir. Yeah.
Because ultimately, who is responsible? You are a post holder. I am not post holder. I am just trying to guide you what things are going and how should it go. That's all. My intentions are very clear. That's why I am involving Rakwar. He is the only worker in the MP at present who is updating all these things. Please help him. So other members should get the benefit of everything. There should be a coordination of the city branches. They should immediately report the things to the Rakwar.
The same thing, the problem with the Indian Journal of Anesthesia, many people are not
You
receiving.
see, ISA is always running with the problems only.
Yes, sir.
We are
Yes.
there to solve it. That's
Yes,
all.
sir. Yes, sir. I have tried my best, but somehow the on-screen alert, some alert comes, and after that they cannot go ahead with it.
Dr. Lalit sir, within 7 days, please take all the charge from the past secretary.
Yes, sir. Yes, sir.
And,
Yes, sir.
and make a list of inactive or active member
Yes, sir.
or,
Yes, sir.
or family benefit,
Yes.
everything.
Yes, sir. Yes, sir.
And then we will discuss after 15 to 20 days.
Okay. Okay, sir. Okay, sir.
Or
Yes, sir.
immediately
Rakwar,
after.
by the time your 30th is lost.
Sir, actually problem is this, अपन उसको upgrade कर भी नहीं सकते हैं, वो date is over.
My dear, you give 15 days, they will take 2 months. If you give the 2 months, they will take 1 year. So you have to be very calculative now. You have to work ultimately.
ठीक है ललित सर, आप चार्जेस जल्दी से जल्दी लीजिए तो अपन लिस्ट कर पाएंगे उसको.
Because they are not getting the generals, they are not getting any information,
Yes,
and
yes,
this
sir.
is what is happening.
Yes, sir.
You cannot submit your report of the general body to the head office. Who is going to represent in the Ahmedabad?
Yes, sir.
Your achievements. None.
Actually, for last 2 or 3 years, the newsletter, secretary report or conference report.
You see, nowadays it is very simple. You put, everybody has got the email, you put on the email.
Yes, sir.
Yes, sir.
None is doing it.
It is the duty of the secretary, no, sir. Then
whatever, if you discuss the past, nothing will come out right.
Okay, sir. Okay, sir. Okay, sir.
I will do my best. I will try my best.
That what I am trying to
And I'm
suggest,
really
please go ahead as early as possible. So
Yes, sir. Yes, sir.
before
Yes.
conference in November, things
Yes, sir.
should be submitted to the head office
Yes,
to
sir.
your optimum.
Yes, sir. Yes.
So they should report the MP working is a sufficiently or satisfactory.
Lalit, sir.
You don't have any CPR meeting conducted in all over MP, how many this and these all the things are recorded and to be reported to the head office every year for the statement.
Sir, sir.
And my most humble request is one thing.
Yes, sir.
I don't know how much money is repatriated from the life members from the head office to the states. With best of my knowledge, since last 3 years, there is no money repatriated from the head office to the state. All money is dumped. And after 3 years, you are invalid to get that money.
No, sir. In 2019, we received the money, sir.
How much? Did you
So
put
that I have
the,
to see.
Dr. Agarwal, please, did you put the balance sheet?
Sir, 20
Are you
जो
ready
19
with
में
the
मिला था वो
balance sheet?
20
You
की
put it now, just now. What is there?
सर 19 में जो मिला था 20 की बैलेंस शीट में मैंने पुट अप किया था सर लास्ट ईयर और अभी 20
This
का
year
21
amount,
का
no, this year amount, you have got any record, please?
दिस ईयर का भी सर कोई रिकॉर्ड नहीं आया सर अभी तक कोई वो नहीं हुआ दिस ईयर कोई अपने को पैसा नहीं मिला 2021 में सर
That's what I am asking. How many members are enrolled?
That means अपने पेंडिंग पैसे हैं वहां पर.
हाँ सर 2021 के होंगे 19 में मिले हैं सर अपने को लास्ट पैसे
19 में मिले हैं और 28 के नहीं मिले 2021 के नहीं मिले.
हाँ सर 21 के तो वो कहते हैं कि जब 21 का पूरा जीबीएम हो जाता है उसका खत्म करके हम 22 में देते हैं तो मतलब 1 साल का पैसा अपना बचा है सर.
ओके. और अपना आईटीआर वगैरह सब क्लियर हो गया है अपना कब तक का स्टेट का इनकम टैक्स जो भी कुछ था बैलेंस शीट
क्या? हाँ सर वो हो गया वो है सर वो सर
कब तक का क्लियर है?
सर 1920 का है 20 से 21 का भी नहीं ये फाइल कर रहा है सर क्योंकि वो अभी डेट बढ़ गई है ना उसके बाद अभी नहीं कर रहा 2021 का.
अब अप टू 21 का नहीं है अप टू 28 का है
सर 20-21 का 31 मार्च 2020 तक का है और 31 मार्च 2021 तक का करना रहता है सर जो जुलाई रहती है.
तो यार
पर अपनी जो उसको रहती है उनकी सितंबर होती है तो सितंबर आवाज नहीं आ रही.
हाँ तो जितेंद्र इसको तो मेल पे तो डाल ही सकते थे ना एटलीस्ट की बैलेंस शीट ये चल रही है सारे आईएसए के मेंबर तुम्हारे पास हैं स्टेट के जो लिस्ट पूरी बनी हुई है तो अपन को सिर्फ सेंड करना सेंड टू ऑल चली जाती है उसको चलो अभी कर लेना कोई बात नहीं.
Submit it as early as possible, so it should not be pending.
Yes, sir. Anything new agendas, new ideas for upcoming year?
सर एक रिक्वेस्ट थी सर जो न्यू मेंबर्स बनते हैं अपने पास अभी फिलहाल गवर्नमेंट कॉलेजेस 13 हैं और प्राइवेट भी एटलीस्ट नॉट लेस देन 5 or 6 तो इतने कॉलेजेस हैं तो मेरा एक रिक्वेस्ट है कि अगर जो हेड ऑफ द डिपार्टमेंट है जब भी स्टूडेंट ज्वाइन करता है तो उसको एक तो लाइफ मेंबर तुरंत बना उसको एसोसिएट लाइफ मेंबर बन जाए और जैसे ही वो पास आउट होता है तो उसकी डिग्री वगैरह सब भेज कर उसको लाइफ मेंबर के लिए एक्टिवेट कर दे क्योंकि एक बार वो एएलएम बनता है सर तो वो फिर कहाँ जाता है ये पता नहीं चल पाता उसका मोबाइल नंबर बदल जाता है उसका मेल बदल जाता है एंड दैट थिंग्स बिकम्स वेरी डिफिकल्ट टू मेक देम अ लाइफ मेंबर.
तो आप फिर एक काम करिए एचओडी को लिखिए लेटर. रीजन इज दैट कि कॉन्फ्रेंस में पेपर पढ़ना एंड पोस्टर प्रेजेंटेशन के लिए रजिस्ट्रेशन इज मस्ट आईएसए मेंबरशिप रजिस्ट्रेशन इज मस्ट. तो वो एक्टिव लाइफ मेंबर तो रहते हैं एएलएम कन्वर्ट नहीं होता लाइफ मेंबर में. आप उस टाइम आप उनको कंसल्ट करिए कि सर ऐसा आप लोग करिए तो ठीक रहेगा क्योंकि ये तो डेफिनेटली होता है कि बच्चे जब पास होकर चले जाते हैं तो वो फिर प्रॉब्लम तो आती है. मैं भी कई लोगों को ट्रेस कर रहा हूँ मिल रहे हैं कुछ लोग नहीं मिल पा रहे हैं.
Can I tell you a solution for it?
Yes, sir. Yes, sir. Yes, sir. Please.
The simple way is that they should have two addresses. One is the permanent address from which place they belong.
Yes, sir. Yes, sir.
And secondly, where they are working.
Yes, sir.
Only working will change. Permanent address will never change.
Never change. Never
So,
change.
in the fault of it, you can
Yes, sir.
communicate to them.
Yes, sir. Yes, sir.
You can send a copy to the present address and copy to the old address.
Yes,
The
sir.
old address will redirect to them for
Yes, sir.
response.
Yes, sir. Yes.
That is the only solution.
Yes. Thus, similarly, we should promote for the Family Benevolent Fund also. I had a discussion with Dr. Subbu Varghese. He told that we are behind 5,000 members. So, in future, if this will continue, then it will become very difficult for the Dickies, for the family of the Dickies to pay them a handsome amount. So, it is at least go for a drive for ISAFPF.
नहीं, अपन ऐसा क्यों ना करेंगे? अपन सारे सिटी ब्रांचेस के सेक्रेटरी और प्रेसिडेंट को टारगेट दे दे कि भैया आपको मैक्सिमम लोगों को मेंबर इसमें बेनिफिट करना है, मेंबर बनाना है।
यस सर।
तो वो मीटिंग करते हैं तो उसमें वो अपनी मीटिंग में सर्कुलेट करते नहीं है एजेंडा, सिटी ब्रांचेस वाले भी,
स्टेट सिटी ब्रांचेस।
हाँ, सिटी ब्रांचेस एटलीस्ट वो ऑफिस बेरा सेक्रेटरी।
Require, I had a discussion with the president about the Chansuria case.
जी सर।
The main problem is that why not a member which is going to be registered for life membership should be the member of family benefit scheme.
Yes, agreed, sir.
One.
Yes, sir.
Secondly, when he is life member, he can pay in the 2 installment.
Yes, sir.
Why this gentleman cannot pay 3 installment in 3 years?
Yes, sir.
So at least the responsibility of HOD will be over.
Yes, sir.
And once he will leave, automatically what I suggested, old address, automatically you can communicate through that family benefit scheme. So he will continue. Otherwise, he will never continue the same scheme.
जी जी जी। ललित सर, आप ये सब मिनट्स नोट कर रहे हैं ना?
हाँ सर, नोट करो।
If you agree to this suggestion, I think that will be easy for you to promote the cause.
Yes, sir. Yes. So similarly, we the Indian Resuscitation Council is constantly going for the international ILCOR society also, and there is a lot of this thing pressure to get at least 1 million these thing demonstrations all over the country. So to conduct the compression only life support, we are not getting the volunteers also. So is there any solution for that?
This is the responsibility of the secretary city branch.
Yes, sir.
They should promote first, and the medical colleges should take the individual district of their zone for training.
Yes, sir.
That is my suggestion.
Yes, sir.
Suppose it is a Khandwa or it is Ratlam.
Yes, sir. Yes, sir.
Nearby districts are about Harda and Burhanpur. They can
Yes,
go
sir.
there,
Yes, sir.
send their team for the demonstration.
Yes, sir.
And I request you kindly ask for more dummies, demonstration dummies free of cost from the head office.
Yes, sir. We will ask our secretary, ISS Secretary National, Dr. Malhotra, sir.
And teaching material for
Yes, sir.
distribution.
Yes, sir.
With the purpose that we want all the paramedics should be also trained.
Yes, sir. Yes, sir. Thank you, sir. So, any
How much
other
balance is with you?
No, sir. I have not got anything, sir, till now, sir. I'm not
At
having
present, you don't have any balance now.
nothing, sir. I'm not having an agenda also to discuss actually.
Okay.
I'm really feeling very
Take
sorry
care.
for that.
Take care when you take the charge. It should
Yes,
be
sir.
properly charged. There should not be any due to be paid by you
Yes,
in their
sir.
account from their time of their time.
Yes, sir. Yes, sir.
अभी अपन का जो अकाउंट है वो अभी क्लियर नहीं हुआ है जीबीएम में।
जी सर।
जब वो आप पुटअप करेंगे उसके बाद ही क्लियर होगा वो।
हाँ हाँ।
नहीं तो he should take proper accounting, otherwise it will be manipulated.
Yes, sir.
If it is the check is paid in that year and they are counting in this year, it should not be permitted.
It is not permitted, sir.
Then
It should be given before 31st of March.
yes.
Yes. After
That's
that,
what I'm asking. That's what I'm asking.
Yes, sir.
Because I also made little bit of the 7 years. I also make the balance sheet. So, one thing is record. This is my personal feeling. Did you reported the Society Act in our association is endorsed in the Society Act? Did you send your general body minutes and balance sheet to the society office in the MP?
नहीं सर अभी तक तो नहीं भेजते हैं सर.
You should send or revoke it.
Okay, sir.
And get no dues of Society Act.
Okay, sir.
Otherwise, you will be penalized whatever amount you are going to take from any company or any donation.
Okay, sir.
Who will be penalized? President and secretary under prosecution of law of society.
Yes, sir.
It is mandatory. All the society should submit their balance sheet plus annual report.
Yes, sir. GBM report.
GBM annual report. That is known as the annual report.
Yes, sir.
And उसमें जो positive things रहती हैं सिर्फ वही लिखी जाती है उनके लिए.
Yes, sir. And
all the details. It should be nicely
edited.
It should nicely edited. No negativity should go there.
Yes, sir.
And you should ask more facilities in relation to the palliative care in the cancer.
Yes, sir.
And CPR training.
Yes, sir. Work for the society basically.
Society, no, don't dilute the things.
Yes, sir.
CPR should be endorsed with the society and the palliative care should be endorsed with the patient care.
Yes, sir.
Because the WHO pay you for the patient care in the cancer patient,
yes,
not
sir.
for CPR.
Yes, sir. No,
The company head will put into the cancer.
Yes, sir.
Even the ventilators, they can be put into the cancer patient care.
Yes, sir.
So please, first you have to submit all these things to the
registration
office.
Yes, sir.
There you have registered. I think during
Bhopal.
your time
Yes, sir.
only registered.
Shikha madam time.
Yes,
2006.
time. You know it. It is somewhere
Yes,
in
sir.
old secretariat.
Yes, sir. Yes, 2006.
Please get it coordinated and get it done.
Yes, sir. Yes, sir.
Okay. Go ahead.
Go ahead, ladies, sir.
I am unnecessarily taking a lot of time.
No, sir, not at all, sir. We are blessed with it, sir. As sir, now can we go for this thing? We have got 4 vacant seats.
Definitely. Abhi aapko to both.
Any other agenda from the members? The permission of the members.
Arora sir or madam.
Arora sir, please, sir. Arora sir.
Nothing.
No other agenda from my side.
Yes, sir. Yes, ma'am. Any agenda, ma'am? Any discussions?
Then go for election, I think. Nomination.
Nomination.
Actually, sir,
Declaration of the JA Memorial and all those nominations, no?
Yes, sir.
Yes.
Yes.
Results.
Results I'll declare. I have been given the charge of declaring.
Madam, I would hold you. Just I would like to announce the name of free paper from Dr. Lalit Pandey sir. Then you announce the TNG and MTVT.
Okay.
So
Okay,
Dr.
okay,
Lalit sir
okay.
is requested to announce the award for the free paper. Actually, there was we have arranged a session of 11 to 12 papers, and we have given just one prize for each session, sir. So, sir, Dr. Lalit Pandey sir, please announce the name.
Yes. So, first of all, I must congratulate the winners and best wishes. So, from session 1, Dr. Ashish Mathur for GRMC Gwalior. Session 2, Dr. Saladi Venkata A from GMC Bhopal. Session 3, Dr. Y. Geeta Sorte from PCMS Bhopal. And session 4, Dr. Richa Pandey from GMC Bhopal and Dr. Saurabh Srivastava from GRMC Gwalior. Thank you very much.
So there was a tie in a session 4. That's why 2 first prize was there. And now I requested Dr. Sadhana Madam to announce the name of Dr. M.T. Bhati and Dr. T.N. Jha.
Good evening, everybody. It's pleasure to announce the M.T. Bhatia Award paper winner. There is a tie between three people have got the same marks from the 3 judges. Congratulations to all of them. Dr. Madhiya Mahmood Ansari from People's Medical College, Bhopal. Dr. Anita Radhakrishnan, BMC Sagar, and Dr. Karthik Vamsi, NSCB Medical College, Jabalpur. Congratulations to the winner and all the best for your future pain management. Now it's time to announce T.N. Jha and K.P. Chansoria award paper. The second prize goes to Dr. Tulsiram Sundar, NSCB Medical College, Jabalpur. And the first prize to Dr. Priyal Srivastav, GMC Bhopal. Congratulations to the winner. And in this, the first one will go for T.N. Jha representation in the national conference. And if the first one is not able to go, then it will be second person who will go to represent the state. Am I right, sir?
Yes, yes, yes.
But they must be registered member of ISA.
Yeah, sir, for state also they are to be registered member of ISA.
I don't think they have taken care so much. That's why I'm giving the warning. They must be registered.
I think for state also we have put the same rules.
Yes, sir.
That they should be registered for ISA.
Agreed, but did you verify it?
No,
it
not
should be verified.
Not.
But it's not followed. In last year also in RIMA, many non-ISA members presented poster and paper, and it was not verified, and they presented poster and paper.
But
so
That's what I'm asking. That's what I'm
Sir,
requesting. Don't send the unregistered member there.
Sir, now it is the head of the department's responsibility to get them registered to send it to a national body. So we have announced
none
the
of
results.
the witness of HOD, none of the, it is now candidate responsibility to
Okay.
present himself.
Right. Right.
Then he is a body, not the head of department. So he should take care of, and the member, those who are sponsoring, they want all these things, minimum requisites. Otherwise, he's not participate there.
Agreed, sir. That's true.
At the time of accepting by organizing committee, they should see the ISA number or applied for ISA.
They should have the ISA number. Without ISA number, they should not accept the paper.
Yeah,
or
paper should not be accepted.
Ask Mr. Tripathi to endorse this thing in future. All papers submitted for anything must have the ISA member on the top of it.
Right, sir. Agreed. So are we left with anything else in the valedictory function? Dr. Amit Jain, where are you?
Madam, I am here only.
Yeah. So the results are announced now. So anything else is left?
Madam,
Or should we wind up?
No, madam. Result of posters.
Sir, result of poster of just one session is with us, sir. Two sessions are with us. Third and fourth session is going on right now, sir.
Okay, third and fourth is
going on. It will be take approximately 1.5 hours to finish third and fourth session.
Okay.
But we can announce a poster winner of first session. I would like to call the Dr. Satyendra Vike, ISA President, Saga City Branch, to announce the name of free poster from session wise. So,
Where is service?
Good evening, sir.
Where is service, Jain? You busy in the practice?
Where is
No, sir. Service sir is have some personal problem, because of that he is not available here.
Practice is also a personal problem, no?
Sir, for free.
Any extra award? I think it was supposed to be the nomination of Dr.
Sir, session, the
as
poster
a
winner.
CPR, coordinator of national level in MP.
Dr. Sarvesh was to announce some award on his father's name. He had put it in the.
No, madam, that was not approved from the body. That's why it's not announced that award.
Okay, okay, fine.
The winner of poster presentation in first session is Dr. Aditi Dugya from Shri Arvindo Medical College, Indore. And the winner of poster presentation in second session is Dr. Akshay Kumar Khairwar. He is from Gandhi Medical College, Bhopal. I congratulate all the winners, and the winners of third and fourth session will be announced later on as soon as the session will end. I congratulate all the winners. Dr. Amit, over to you.
When now session 3 and session 4 is going on, so we have to wait for the results. We will be communicating to the candidates and to the respective IAC official various. I have got 2 videos from President and Secretary sir, which I would like to play if the GBM permit me.
नहीं अभी तो ये जीपीएम के वो थोड़े से बजे हैं, एजेंडा हो जाने तो उसके बाद
आराम से सर जब तक आप ना बोलें
लास्ट में
जी सर।
अभी डॉक्टर ललित बच्चे हैं, जैसे अब ये पॉइंट हो गया। अभी एग्जीक्यूटिव मेंबर पे एक्चुअली इलेक्शन जब हुए थे तो उस समय कुछ एग्जीक्यूटिव मेंबर की पोस्ट खाली थी और उस समय नॉमिनेशन में आए नहीं थे, वो अपन ने नोटिफाई नहीं किए थे उनको, तो उसको जीबीएम में करने के लिए बोला था आईएसए नेशनल ने कि आप जीबीएम में उनको कर लेना। तो अब डॉक्टर ललित पांडे सर बोलेंगे।
Sir, there were 4 seats, two were announced, 2017 seats, and 2 seats got vacant because of the elections conducted. So there are total 4 seats. So I think nominations.
I propose the name of Dr. Satyendra Vike from Sagar sir.
Okay, I second it. सत्येंद्र is there ना? सत्येंद्र is there. सत्येंद्र आप हाथ उठाएं।
Dr. Satyendra, please.
Where is Satyendra?
Yes, sir.
So I second it.
Thank you, sir. Thank you very much, sir.
Dr. Any for the next executive member. Hello.
Who all are there earlier?
There were Dr. Deep, one from Bhopal and one from Rewa.
Okay.
And 2 from Indore.
Okay.
Hello. Sir, Ratlam. Dr. Dawar is also wants to this thing.
He's a professor rank. He is contesting for governing council member.
सर एक्चुअली उनको कुछ आगे बनना है तो पहले जीसी मेंबर बनना पड़ेगा। ही इज फर्स्ट टाइम।
Then make him.
Sir.
Then make him. Lalit? What is wrong?
Dr. Lalit?
जी sir.
Dr. Lalit?
हाँ, yes ma'am, yes sir. I'm listening.
इंदौर से कौन है 2?
इंदौर से हाँ
वही है, continued है?
No, they are not continued. They have resigned from the post.
So who are there?
मैडम मैं बता रहा हूँ,
किसी को अगर आना होगा आगे तो आएगा।
नहीं मैडम पहले मैं बता रहा हूँ अभी कौन कौन है एट प्रेजेंट।
हाँ वो बता दो।
डॉक्टर आशीष माथुर फ्रॉम ग्वालियर फ्रॉम 2019 से है, इनका अभी 1 साल का टेन्योर बचा है। देन डॉक्टर तपन शर्मा फ्रॉम उज्जैन 2019 से है। देन डॉक्टर जयदीप सिंह फ्रॉम भोपाल एंड डॉक्टर अरविंद राठिया फ्रॉम रीवा 2019 एंड डॉक्टर देवेश गुप्ता फ्रॉम जबलपुर 2019। इनका टेन्योर है मैडम, अभी जिसका टेन्योर कंप्लीट हुआ है वो है डॉक्टर विकास गुप्ता फ्रॉम इंदौर, डॉक्टर सुबोध चतुर्वेदी Dr. Deepesh Gupta from Bhopal, Dr. Subhas Agrawal from Rewa. इनका अभी हुआ है मैडम। तो अपने पास अभी वर्किंग जो है 5 हैं, तो 4 पोस्ट हैं अभी।
4 में 2 सत्येंद्र का और उसका दावा का आ गया।
जी सर।
Now we are left with 2 seats only.
2 seats only.
I agree.
You
Hi, Dr.
joined.
Tower.
I think
I agree, sir.
in Udaipur.
So can we have 1 seat from Bhopal, Dr. Ashika Rathore?
She is there. She is online abhi at present.
I think she was interested.
No, she is there in the GBM.
I am not.
नहीं है सर वो।
नहीं
Sir,
है।
I propose the name of Dr. Yashwant Davle from Bhopal.
So I second it.
Remember, those who are in the GB, they should be the only member. Absentees should not be endorsed as a member.
सर मैं अब्सेंट नहीं हूँ, मैं हूँ अभी यहाँ। डॉक्टर यशवंत
नहीं कह रहा हूँ, मैं बता रहा हूँ रूल जो कहता है।
Yes sir. Yes sir.
Yes sir. Yes sir. Yes.
So Dr. Yashwant Davle, I second it.
Thank
From
you, sir.
Bhopal.
Now we are left with 1 seat.
Anyone from Indore? I think Jabalpur, Gwalior, Ujjain, Rewa, Sagar, and Ratlam. Okay,
Nobody
Indore
is there on me in meeting also.
from Indore.
कोई है ही नहीं ना मीटिंग में, कोई नहीं है तो किस-
क्यों डॉक्टर रायकवार इन एब्सेंसिया किसी को कर सकते हैं क्या?
नहीं सर, अभी
यदि वो
VM सर
consent
ने
है।
अभी सर ने बोला ना, अभी VM सर ने बोला मैडम, जस्ट तो बोला।
No, it is invalid as per the constitution. If you are not physically present, your nomination is invalid.
Yes sir.
सर योगेश तिलकर
From
डॉक्टर योगेश तिलकर फ्रॉम रतलाम आई थिंक सो।
तो रतलाम से एक हो गया ना यशवंत ऑलरेडी।
खंडवा?
यस सर, खंडवा से कोई भी है क्या ऑनलाइन? खंडवा और शहडोल और
दतिया,
शिवपुरी, दतिया,
विदिशा, भेलसा,
कोई है ऑनलाइन अभी?
भेलसा, विदिशा में।
विदिशा से भी कोई है क्या?
अरे ऑडियंस में पूछ लो, who is online from any other than this place?
Sir, as much as I am able to look about the participant, there are 37 participants. No is from the Khandwa, no one is from the Vidisha, sir. Maximum are from the Bhopal, Jabalpur, Sagar,
and
few from the Indore also.
So shall we take 1 more member from Sagar? If your permission is granted, we can have 1 member from Sagar.
Mayank Masand, I am contacting, just a minute. Just a minute, I am just contacting Mayank.
Hopefully, Mayank sir has joined.
And make the Amit Jain as a member.
Mayank.
Yes sir, Amit Jain is definitely deserving it.
Mayank Masand.
But
Mayank
Mayank was not in GBM
online आजा
meeting.
GBM में executive member बनने के लिए। जल्दी आ। अरे यार।
हम लोग फोन क्यों कर रहे हैं? जो ऑलरेडी जो
ले लेना। स्टेट से ले ले।
मेरा ख्याल डॉक्टर अमित को।
फटाक से आजा।
हाँ देव।
अमित सर, अमित जैन फ्रॉम सागर।
ऑनलाइन आजा।
Yes, I second it.
Mayank Masand.
अमित जैन सर। फ्रॉम सागर।
इसीने बोला था ना।
So Dr. Lalit, it is Amit Jain or what?
Amit Jain is there. Amit Jain is there.
Mayank Masand is coming. Just a minute, Mayank Masand is coming online.
मैम जो पर्सन है ही नहीं है, आप उसको फोन कर रहे हो, तो अमित जैन क्यों नहीं मैम?
अमित जैन तो है ना, बोल दिया ना, हाँ हो गया ना अमित जैन।
तो 4 हो चुके मैडम 4 हो गए हैं।
मैडम
इट्स ओके देन।
मैडम आई कैन विड्रॉ। मैं चाहूंगा कि हर
मैं भी आ गया हूँ।
मैडम हर सिटी का रिप्रेजेंटेशन रहे मैडम। आई कैन विड्रॉ वेरी इजी सर। मैं वोट करता हूँ।
अमित लिसन अमित, आई एम
अरे अमित सुन, मयंक भी है, मैं भी आ गया हूँ यार, सुन तो ले। हेलो।
हाँ सर, मैं आपको वोट करता हूँ सर।
अरे अमित ऐसा कुछ भी नहीं है, क्या डिसाइड हुआ है? जो भी अगर एग्जीक्यूटिव कमेटी में आना है तो आ जाते हैं दोनों।
नहीं, there were already 4 bodies and अमित का कर दिया था मयंक, है ना?
अच्छा
ठीक है,
नेक्स्ट ईयर कर देंगे, नेक्स्ट ईयर
हाँ,
अभी
नेक्स्ट ईयर हो जाएगा, नेक्स्ट ईयर
सीट-
खाली होगी एक सीट, फिर आप कर देंगे।
2 सीटें आएंगी।
सर एक हम्बल रिक्वेस्ट है, सागर छोटी सिटी है, 2 का
Okay.
रिप्रेजेंटेशन ज्यादा हो
Okay,
जाएगा।
Amit, okay.
छोटी बड़ी कुछ नहीं है।
इंदौर इज अ बिग सिटी।
Okay, Amit, okay. Okay, Amit.
बेटर टू हैव अ वन।
Amit, all the best.
1
Okay.
2 2
ठीक है। So Dr. Satyendra VK, Dr. Amit Jain from Sagar, Dr. Davar from Ratlam, and Dr. Sir, one more name is there, na? Dr. Bhopal.
Yashwant.
Dr. Yashwant from Bhopal. Congratulations and best wishes to all of you.
Congratulations.
Thank you, sir.
Thank you. Thank you very much.
नेक्स्ट ईयर 5 सीटें आएंगी।
Thank you, sir.
हाँ हाँ,
Thank you, sir.
thank you.
Thanks.
Nothing, I think vote of thanks के साथ आप ललित सर क्लोज कर सकते हैं अब जीबीएम।
Dr. Amit Jain,
Yes, sir. Sir,
you may continue the vote of thanks, please.
Yes, sir. Thank you so much for all my senior and respective in this good evening. मुझे इस विशेष अवसर पर आप सभी का धन्यवाद ज्ञापित करने का अद्भुत अवसर प्राप्त हुआ है। यह 16 और 17 2 दिन हमारे बुंदेलखंड चिकित्सा महाविद्यालय के स्वर्णिम इतिहास में दर्ज हो गए हैं, जब हमें निश्चेतना विषय का प्रदर्शिक सम्मेलन करने का अवसर मिला। यह हमारे लिए प्रथम अवसर था। महाविद्यालय और आईएससी सागर सिटी ब्रांच की ओर से सर्वप्रथम मैं आईएससी नेशनल एवं आईएससी नेशनल गवर्निंग काउंसिल के अध्यक्ष डॉक्टर मुरलीधर जोशी, उपाध्यक्ष डॉक्टर सुरेश के भार्गव सर, सचिव डॉक्टर नवीन मेहता सर, कोषाध्यक्ष डॉक्टर वीरेंद्र शर्मा सर, डॉक्टर वेंकटगिरी सर, प्रेसिडेंट इलेक्ट, एडिटर इन चीफ डॉक्टर मेहंदी दत्ता सर, डॉक्टर बाला भास्कर सर को दिल की गहराई से धन्यवाद ज्ञापित करना चाहूंगा। हम सभी पर अपने आपका आत्मविश्वास दिखाया और हमें मार्गदर्शन दिया। अब मैं संस्थान और सोसाइटी की ओर से आईएससी एमपी चैप्टर को धन्यवाद ज्ञापित करूंगा कि जिन्होंने सागर सिटी ब्रांच को स्टेट कॉन्फ्रेंस कराने की अनुमति ही नहीं बल्कि पूर्ण सहयोग भी प्रदान किया। मैं आज विगत 2 दिन से वेबिनार में आए हुए सभी गेस्ट स्पीकर, चेयरपर्सन, मॉडरेटर, जजेस का धन्यवाद करना चाहता हूँ। आप सबके ज्ञान के उद्गार, प्रेरणादायक व्यक्तित्व और विशिष्ट व्याख्यान से इस कार्यक्रम को अविस्मरणीय बना दिया है, जिसके लिए मैं आप सभी का हमेशा ऋणी रहूंगा। जब मैं ऐसे व्यक्ति को धन्यवाद देने जा रहा हूँ जिन्होंने हमारे आत्मबल और मनोबल को हर बल बढ़ाया है और हमारे साथ मिलकर हमारी कमजोरियों को दूर करने की मदद की है, ऐसे अधिष्ठाता प्रोफेसर डॉक्टर आर.एस. वर्मा सर को धन्यवाद देता हूँ। कभी कभी ऐसे भी समय होते हैं जब आपको किसी सर्वश्रेष्ठ, अतुलनीय, अद्भुत, प्रतिभाशील, सर्वोत्तम लक्ष्य को पूरा करने के लिए किसी के हाथ और सबके साथ की जरूरत पड़ती है। ऐसे हमारे आदरणीय आयोजक मंडल, विभाग के सभी प्रबुद्ध चिकित्सकगण और आईएससी सागर सिटी ब्रांच के सभी सदस्यों का शुक्रगुजार हूँ, जिनके बिना इस स्टेट कॉन्फ्रेंस को करा कर पाने की कल्पना भी संभव नहीं थी। हमारे इस कार्यक्रम में हर छोटे पड़ाव में वे मेरे साथ रहे और हमेशा आगे बढ़ने की प्रोत्साहित करते रहे। अपनी सकारात्मक सोच और आशावादी विचारों से उन्होंने मुझे अपनी लक्ष्य की ओर बढ़ने के लिए प्रेरित किया। ऐसे आदरणीय डॉक्टर एस.के. रकवाल सर, डॉक्टर जावेद खान सर, डॉक्टर अवतार सर, डॉक्टर जितेंद्र सर, डॉक्टर मीनू मैडम, डॉक्टर ललित सर, डॉक्टर टी.सी. प्लानी सर को मैं धन्यवाद देना चाहूंगा। मैं हमारे इस कार्यक्रम में स्वयं सेवकों एवं चिकित्सकों टीम में डॉक्टर हिमांशु, डॉक्टर नेहा और इंटर्न डॉक्टर तेजस, डॉक्टर कीर्ति, डॉक्टर हर्षित, डॉक्टर अरुणिमा का धन्यवाद करना चाहूंगा, जिन्हें इस कार्यक्रम के आयोजन करने के लिए अपना सहयोग प्रथम क्षण से अंतिम क्षण तक दिया। मैं अपने डिजिटल सहयोगी फिनिक्स नेटवर्क भोपाल के यूसुफ, नवीन, अजय, विशाल, गोपाल और फार्मा कंपनी नियोन और थेमिस को धन्यवाद देना चाहूंगा। अब मैं उनकी बात कर रहा हूँ जो हमारी ब्रांच की तरह है, एनेस्थीसिया जैसे, जो आपके सामने नहीं है, न मंच, न माइक, न माला, न मीडिया, फिर भी अपने आयोजन में कदम से कदम मिलाकर साथ देने वाले सभी ओटी के स्टाफ और डॉक्टर एस.पी. सिंह, उपाध्यक्ष का धन्यवाद देना चाहूंगा, क्योंकि अगर वो नहीं होते तो हम इस कार्यक्रम को इतने हर्ष और संपूर्णता से समाप्त ना कर पाते। कार्यक्रम में उपस्थित सभी श्रोतागणों से जो हमें ऊर्जा मिली है, उनका मन से आभार व्यक्त करता हूँ। अंतिम भावना डॉक्टर अमित जैन की, चूंकि हमारा प्रथम अवसर था, गलतियां होना मानवीय स्वभाव है और हमसे भी हुई होगी, शब्दों से, व्यवहार से उनकी क्षमा चाहता हूँ मैं दिल से, पर आप सभी के सानिध्य में हमें परिपूर्ण किया। हम आगे भी ऐसा अद्भुत अवसर प्राप्त हो, इसी कामना के साथ अपनी वाणी को राम देना चाहता हूँ। लॉन्ग लिव आईएससी, जय हिंद, जय भारत। So this is all from my side.
Well done, Dr. Amit.
Thank you, Amit. Thank you very much.
सर बस 2 जो पोस्टर चल रहे हैं उनके रिजल्ट्स रह गए हैं, तो as soon as they will be finished, we will be declaring in the list to the all the ISC official areas, and हमने एक बच्चों का ग्रुप बना के रखा, उसमें हम ओपन कर देंगे।
ठीक है, ठीक है.
Any other topic with the permission of the chair?
Now I think
Or Aurora sir.
Fix if it is a physical, then fix the registration charges.
Yes, sir. Yes, sir.
I think 2,000 rupees for early bird or 2,200 for.
How many days conference? According to that, you have to settle it.
Sir, 1.5 day or 2 days conference. We have started from.
That I think you know better than
yes,
me.
2 days conference, sir.
You declare it, so person should not get apprehension ki for 1 day 2,000 why we should pay. They will talk like that, no?
Yes,
they should be aware of the duration. Okay.
I think 2,200 is okay. Because today nowadays the breakfast, lunch, dinner they are costly.
This is only for early birds, sir.
Or how much for early birds?
So early bird 2,200.
Okay.
Because workshop, CME and conference.
Then that is extra.
That will be extra.
Oh, definitely. Workshop वो सब extra ही रहता है.
हाँ. Workshop will be a separate, CME will be a separate, and a conference 2,200 only.
Only. For early bird and 2,500. Then after for 3,000. Before 15
on
days.
On the spot, the money will be increased.
3,000.
Yes.
22, 25 and 3,000. ये कर सकते हैं अपन.
Yes.
I think for 2 days. Excluding workshop.
If I am not mistaken, earlier conferences were only 1.5 days, if I'm not mistaken.
That is a very thing.
No. It actually, no. What about the postgraduates? Is there any concession for the postgraduates?
Yes, sir. There will be, sir.
They declare it.
1,500, 2,000, 2,500, I think.
Sir, 1,200.
1,200 for 2 days. Yes, one.
1,200 रुपए काफी सर.
2 दिन के लिए.
It will be too less, I think. Yeah, it will be too less, yes, sir.
1,500.
Let it be 1,500 because everybody is getting a good amount of salary. They're getting.
Stipend. And 1,500 is
15, 2 and 25.
Yes,
Yeah.
yes.
They can afford. They can afford.
15, 20, 200, 2 and 225.
Fix the duration of the early bird and the last in between.
So 3 months will be the early bird, sir. 3 months. We'll declare it.
Date of declaration 3 months prior to the conference. Early bird, or what is the duration of the early bird registration?
I think our state conference will be held in the month of September. So early bird up to March.
You declare it, please. So there should not be any confusion.
Yes.
I think up to April. Up to April is early bird. Then up to July.
No, up to 30th June then.
Okay, sir.
Early bird things become changed after, you see, your financial budget comes in January. So early bird in March is satisfactory. But
yes.
After that, things changes according to the range. Cost of the living goes up and down.
Yes, sir.
So you should come up in that little background of the things, please.
Yes,
I think ideal is 30. You make it 30th July finished. Last, उसके बाद तो फिर they have to equivalent to the spot registration.
Spot registration.
Yes.
And what is my feeling, if you make it total virtual conferences or physical. If it is a virtual, then this registration fee will not be valid.
Definitely.
So you have to make another set of the information also.
So just 50%.
This is not my suggestion. This is what my feeling. If they are physically coming, then they have to pay that much. If it is only on that, you have to reduce it.
सर एक्चुअली क्या होता है ऑनलाइन कॉन्फ्रेंस में भी एक्सपेंसेस होते हैं सर. अभी इस कॉन्फ्रेंस में भी मुझे मालूम
I
है.
am not denying expenses. What I am suggesting, those who are registered, they will get only the attendance and presentation certificate. Others can enjoy the conference virtually.
Yes, sir.
This is my feeling. So when they want certificate, they have to pay. Simple.
Yes,
This is a good idea. This is a good suggestion, as I said.
Yeah, I
But
think.
sir, but
You
sir,
should
then no.
declare this thing. What I feel, you
Nahin.
should declare.
Sir,
If you want poster presentation, you have to register. If you present the
I-
paper, you have to register.
but sir, then everybody will go for a virtual only, and nobody will. The attendance will be very less in physical conference.
My dear,
Yes, sir.
remember one thing,
Yes, sir.
that nowadays conference and paper presentation is must for the postgraduate also. So
Yes,
they
sir.
have to attend.
Yes, sir.
Sir, secondly, registration for a speaker is also mandatory now.
This is all the organizer's choice.
Sir, there is a small suggestion. Can I?
Yes,
May I
yes, yes,
speak?
ma'am. Yes,
please,
ma'am.
Sir, the thing is that since the faculty is presenting and they are getting an opportunity to present, right? It is the choice of the organizer. That is okay. That is absolutely okay. But they are getting a chance to present.
Hmm.
I think they should be registered.
Yes, I agree.
Whatever it can be 400, it can be 500, bare minimum 500. But they should be having some charges to present. It is just the consideration by the seniors. Just this is my point of view.
So, sir, any other?
No, what my dear colleague has suggested, I feel it. You may get the difficulty in finding the good speaker out of state for registration. They are not going to pay.
Yes, sir.
Sir, that is absolutely okay. With due respect to your experience, sir, that is absolutely okay. If we are not getting speakers outside the state, at least we will promote the speakers from within the state who are
Promotion
young.
is not, my dear. There is some basic aptitude of the academic feast, that you want the best of the best
Yes,
to be
yes.
presented there.
Yes, yes,
And
definitely. sir.
I am not denying the quality of our state speakers, but you have seen yourself in this conference itself. The quality of presentation differs very much. And if you are inviting outsiders from the state, that's why I said, let this choice should depend on the organizers. That is my request. Rest is your choice. You see, you call a orator, you pay for it, you felicitate him. That's why they came. They are not going to donate it, that money, what they get. So there is a personal beauty out of it. But I want my members should be exposed to the best academics. That's why I said, organizer, if they have got enough fund, they can condone it.
नहीं,
Otherwise, they can charge it. What is there?
I think I agree with the VM sir. क्योंकि सर अगर अपन को अच्छे स्पीकर चाहिए तो हो सकता है आउट ऑफ स्टेट जब अपन को मिल रहे हैं वो रजिस्ट्रेशन ना कराएं, वो रिफ्यूज कर रहे हैं.
They will not pay the fee.
Yeah, definitely. So yes sir.
Either you make either you make the rule out of state.
जी सर बोलिए रही सर.
मैंने कुछ किए वैसे मैं रजिस्टर फी उनको पढ़ो.
जी सर.
मेरे व्यास से पढ़ो जरा.
अच्छा रजिस्ट्रेशन must for faculty also.
सब पढ़ो पूरे पढ़ो.
All speakers are ready to pay now, sir. Now the speaker will not pay. Is a old school of fraud. Now you are ready to pay. ठीक है सर.
उनको सबको चांस दिया.
sir is requesting कि शुरुआत से पढ़ें. Conference registration can be increased to the easy 3,000, 2,000 for the PG. The other states have much more, and Kerala has 5,000 plus. All states are much higher. Why we are keeping it so low? For a virtual also, there should be at least 50%, at least nothing to be given free. Virtual also has a lots of cost involvement. Registration must for a faculty. Dr. Edward, please read out my suggestions. All speakers are ready to pay. The speaker will not pay in an old school of a thought. Now all are ready to pay. These are all are the suggestions suggested by the Dr. Mehndi Datta sir.
We welcome all these suggestions.
भैया महाराष्ट्र में 11,000 रुपए फी किए थे मैंने.
Yes, 10,000 you have written here, sir.
11,000 I have paid.
Okay, sir.
Please read it out. Please read it out. Backward, please read out the suggestion of the Dr. Mehndi Datta.
जी sir, just a minute.
अमित को बोल दीजिए, अमित पढ़ देगा.
Okay, sir, I am repeating on the behalf of Mehndi Datta sir.
अमित तुम पढ़ रहे हो ना?
Conference registration can be increased up to 3,000 for early birds.
I can't understand his voice. It's a very low tone. Please speak loudly, yaar, Amit.
Conference registration can be increased to 3,000 easily for early birds, 2,000 for PG. The other states have much more. The Maharashtra is more than 10,000 for early birds, and Kerala has a 5,000 plus. All states are much higher. Why we are keeping it so low? For a virtual also, there should be 50% at least. Why free? Nothing to be given free. Virtual also has a lots of cost involvement. Registration for faculty is also. Dr. Ekbar, please read out my suggestions. All our speakers are ready to pay. The speaker will not pay is an old school of a thought. Now all are ready to pay. These are the suggestions given by Dr. Mehndi Datta sir.
Welcome. He is having more experience. He is visiting in so many places nowadays. And what is the trend is going on? What is he has said just now in Kerala it is 10,000 for the registration of a state conference.
Yes,
Then,
yes.
So I think you apply 3,000 and that thing and see to it what he suggested.
In Kerala, the state conference is for 3 days. 3 days state conference.
So you are it comes to 6,000 to you.
Yes, sir.
Then he's suggesting only 3,000 and above.
So it is बहुत ही कम है, sir. Definitely. Okay, sir.
And regarding speakers and that thing, controversies will always be there. They are, you see, their attitude is academic attitude. They are to get the chance, a platform to talk. They are dying for it. They are willing to pay. In my place, we have to beg. Please come and give the lecture. That is the difference.
अभी अपने आप ही आदमी पे करेगा, आदमी के पास प्लेटफॉर्म आज नहीं है, अपना बुलाएंगे सब आएंगे, आप चिंता मत करिए.
I am not denying Mehndi Datta. I wish for it. I want good lectures. That's all.
अगर उनको हम इधर दे रहे हैं वो क्यों नहीं पे करेगा, इसलिए पे करेगा.
Okay.
हाँ, रजिस्ट्रेशन जो अपन किसी को बताएंगे, रजिस्ट्रेशन के लिए अपन नहीं लेंगे, नहीं लीजिए, लेकिन नॉर्मल स्पीकर्स को सबको पे करना पड़ेगा.
I am not denying that thing. I want the quality fees of the academics in MP. This year, they have managed few lectures, fantastic lectures. I have listened on 2 days. And I appreciate their contribution in that way. And my wish is that let the state speaker should come out. Why Kripalani has not talked in this conference? I can't understand all these things. In my time, it was they are the best speakers of the time.
We have requested Dr. T.C. Kripalani sir. That was the first invitation from our side.
Agreed. Agreed. No. This is virtual conference. That's why you have called them. That is one thing I know. But if there is a possibility, why to block the possibilities? Rekwar, please go ahead and see to it. Whatever is suitable to our state, I act according to that.
जी sir, जी sir.
Simple.
जी sir.
And let the decision should be taken by the president and secretary.
जी sir.
Because they have to carry out. You discuss with them in the detail about all the suggestion, everything.
जी sir.
It will help them. Please guide them. I think they are not in position to understand all these tricks of trade.
Yes sir, definitely.
Go ahead. So virtual it is 2000, non-virtual it is 3000 onwards. Finished.
Yes sir. 3,000, 3,500 and 4,000.
Whatsoever you decide.
Yes sir.
Yes.
The cost of everything has gone up drastically, sir. हर चीज की कॉस्ट इतनी हो रही है जिसका कोई हिसाब नहीं.
Yes sir, definitely.
कॉन्फ्रेंस ऑर्गेनाइज करना इज नॉट अ जोक.
Definitely sir. The
और
break.
जिस हिसाब से कॉन्फ्रेंसेस हो रही हैं आपको स्पॉन्सर्स कम होते जाएंगे. आपको खुद ही
सर एक्चुअली सर क्या हुआ, स्पॉन्सर कम है और ब्रेकफास्ट, लंच और डिनर और दूसरे एक्सपेंसेस भी बहुत ज्यादा हैं. इवेंट मैनेजमेंट के खर्चे बहुत ज्यादा हैं. तो इट इज वेरी डिफिकल्ट नाउ डेज टू कंडक्ट ऑफलाइन कॉन्फ्रेंसेस with minimum registration.
And everybody is earning very good money. 3,000-5,000 रुपए किसी के लिए मायने नहीं रखता.
Yes, yes, बिल्कुल सर, agree.
आज पीजी को भी 5,70,000 रुपए मिलते हैं.
जी सर, जी सर.
बाद में 2,000 रुपए कम से नहीं लगता.
No, I agree with Manidatta that now the remuneration to the postgraduate and the staff and the practitioners are quite good. And they can spare some mini percentage, there's no percentage, practically it is a fraction of their earning for their academic acumen. That's all.
Yes.
Go ahead, please.
The request, sir. Any other discussions? We have discussed about the conference venue. It will be in Gwalior and then will be in Bhopal. We have discussed about the, I think, the fee structure of early bird and on the spot. And I think all members are ready for that. They are agreed for that. To have good and eminent speakers, because our main purpose of the conference is to have a nice academics. That is very important, apart from all other activities. Sir,
May I suggest one thing?
Yes, sir. Yes, sir.
In the virtual conferences,
yes,
if they provide all the lectures in the compact form in the JAMA or some pen drive, or dispatched pen drives to the registered members, that
Yes,
will
sir.
be an asset to the participants.
Sir, we will sharing
If you accept, it is good.
We will be sharing a Google Drive link of all the data to all the registered delegates, sir.
Yes, that
the
I want.
previous session which was there. We will be sharing all the data with a Google Drive, and as we have said, there will be prizes for each session. In that session, we are giving just only academic fees. We are giving all the digital books, access to the review journal articles, and few notes to all the PG students who are the winner.
Good.
I have one more suggestion regarding this. When you are sending any recorded lecture, the audio should be very clear. What happened this time, basically, some event manager has complaining me कि सर वो 360 की उस पर उन्होंने दूर से कैमरा मोबाइल रखकर रिकॉर्ड कर लिया और मुझे भेज दिया. उसको मैं डबल कर रहा हूँ, एडिटिंग में प्रॉब्लम आ रही है. तो रिकॉर्डिंग शुड बी वेरी क्लियर एंड स्पीक लाउडली, आई थिंक.
Sir, for that thing, we should always send our data through the mail, not through the WhatsApp, not through the Telegram, because that compresses the audio and video quality.
Don't send through the WhatsApp or Telegram or Signal. Always send through the email.
Mail.
Otherwise, also the WhatsApp doesn't accept more than 100 MB data.
Yeah.
We have to send it via mail.
They can make in the pen drive and send the pen drive there for the uploading.
ये भी ठीक सजेशन है सर.
Hmm?
ये भी ठीक है सर.
They can have the one pen drive, load it properly, set it, and virtually speak it out and see the time allotted is same and send it. They will load it and then will display it.
Sir, good suggestion. This is good suggestion.
Then why to WhatsApp and all that thing? Simple. If you get the pen drive with the organizer, he will put it in the record it and just check it whether it is properly recorded or not. That's all.
Yes.
And secondly, lecture should be called 7 or 8 days before the conference, not at the
Yes.
11 hours.
And my humble request to the presenter that just now I have saw the poster presentation. It is a clumsy. You cannot read anything in that. So please make it like that. It should be readable, presentable, practical. And there are so many spaces wasted. Who is guide? Who is this? And 5 minutes time is allotted. 1 minute they have wasted to introduction.
Yes, sir.
That is not permissible. Please see to it that, and I request to all HODs, they should guide their postgraduate how to present the paper. And they should follow particular format of the presentation. It is not like that whatever they like. They are presenting pheochromocytoma, agreed, but there is no CT, there is no MRI report, there is extra what type of surgery done, intraperitoneal, extraperitoneal, no mention of it, but the paper is accepted. And there is I am old man, I don't know what is anesthesia, but there is a definite difference between the extraperitoneal surgery and intraperitoneal surgery. If they learn only pass the tube and ventilate manually or mechanically, I don't know if it is an academic paper. This is my just observation. Please guide them in proper format. They should come up. Simple way is that after 8 feet away from the screen, if you can read without with spectacles and pointed it out properly, it means your paper size is word size is accurate. It will be visible to the all audience. This is a simple formula we have adopted to present a paper. Anyhow, this is not the part of it, but that is my feeling. There are so many things which I got disturbed. And in the background, there is a shouting of the wife, kids, and everything during the presentation, the poster. It should not be there. So the best format is they should come with pen drive, submit it, finished. And as soon as their pen drive is over, presentation is over, the judges can ask the question and they should available physically to reply the question answers as soon as their term comes. Rest is your choice.
No, sir, it's a good suggestion, sir. I accept.
Because here the judges was asking something and they don't understand what is the question. And they have to give marks. 30 seconds are wasted. Are you in position to listen me? Are you in position to listen? 7 minutes time you are wasted like anything. This is my request to the organizers. Please see to it all these things in proper format. When you allot the time, you should be very particular about the timing. Simple.
Proper protocol has to be made and followed.
Yes, sir.
I'm sorry, Mandidatta, I can't understand what you are talking.
Sir, proper protocol has to be made and followed.
I appreciate everything if it is a clear presentation.
Yes, it has to be in the proper protocol, and that protocol has to be followed.
Yes.
Yes,
definitely.
this
It's
is my
protocol.
that's what I am thinking. That's all. You see, there is a two different concept is going on. One, our postgraduate classes by the ISA National, and one classes by the Kerala. They are very precise in their distribution of time of lecture and paper presentation and question answers. I wish we should learn from them.
We'll definitely go for it. So we'll learn it. Sir.
And I have a suggestion for the new team. Dr. Lalit, you
Yes,
should
sir.
have one meeting every month.
Yes, sir.
The MP State Council and all city branches, president and secretary.
Yes,
To
sir.
attend.
Yes. Yes, sir. Yes. Sir.
Every month.
Yes, sir. Every month I will do it, sir. Every
And
month.
secondly, you have to formulate a proper constitution of MP State
Yes, sir. Yes, sir.
and proper protocols for the conferences.
Yes.
These have to be formulated.
Yes, sir.
You don't have any constitution of MP State. This has to be done.
Yes, sir. Yes, sir. Yes. Sir. Sir, your phone is muted, sir. Mandiratta, sir.
Yeah, I've given my suggestion. So
Yes, sir.
please try to follow this.
Yes,
We
sir.
are all there to help you in making the constitution of Madhya Pradesh feasible.
Yes. Yes, sir. Yes.
Our rule book.
Yes.
And in the next GVM, get it approved, passed by the GVM.
Yes.
When you do, you can implement it.
Yes, sir.
Thank you.
Thank you, sir. Thank you.
Now I think Lalit sir, meeting can call off.
Yes. So, I think Dr. Mandiratta, sir.
With the permission of Dr. VM sir, Arora sir, and all, Lalit sir.
Sir,
If there is no other agenda and no point, then we can conclude the meeting. Lalit.
yes, sir. Yes, sir. I think there is no other agenda left, and we have got a lot of suggestions and a lot of queries, and there are so many things we have to go with with the help of your guidance. I will be there every month with all of you. I will try my best to take the ISMP state chapter to new heights. Thank you, Agnihotri sir. Thank you, Arora sir. Thank you, ma'am. Thank you, Ekwar sir. And all my seniors. Thank you, Mandiratta sir. And all my seniors and patrons, colleagues, and dear friends. Thank you very much for participating in general body meeting and giving your suggestions. I hope the next conference in Gwalior will be very nice and we will coordinate with each other. Please give your blessings and guidance. Thank you, sir.
Lalit sir, one more suggestion.
Yes,
Please
sir.
send conference report to the national headquarters as
Yes,
early
sir.
as possible within
Yes, sir.
5 days.
Yes,
You
sir.
will
Yes, sir.
draft tomorrow or day after tomorrow.
Yes, sir. Yes,
You
sir.
know,
Yes,
because national conference is nearby.
yes, sir. Yes, sir. I will send, sir. I will
So
send.
you will send within 2 or 3 days.
Yes, sir. Yes, sir. I will send. I will send.
I wish now the president-elect, president should talk, give the blessing to the new members, governing council members. Introduction.
Madam, please. Sadhana, madam, please.
That is a protocol. That is the protocol. After
Yes, sir.
secondary closing of the secretary,
Yes.
the
Yes,
president
sir.
gives the final remark.
Yes, sir.
Actually, it should be before you, but when you have already delivered the lecture, now she should give the vote of thanks to the and
Yes.
welcome the new year to the members. Is she if she is there?
Ma'am?
Yeah, I think she has left.
Okay. Nothing to worry. You are whole responsible for all the deeds. Take care and do work hard.
Yes,
That's all.
yes, sir. Yes. Thank you, sir. Thank you very much, sir.
Chalo,
Thank you, sir. Thank you. Okay. Sir.
Thank you. Long live ISA. Jai Hind.
Long live ISA. Jai Hind. Jai Hind.
Long live ISA. Now the Amit is there to wait for
Yes.
some time. Amit will show you some videos, na, what he thinks.
Yes, sir.
Ah,
Yes,
oh,
sir.
yes, yes, sir. Yes.
Yes, sir.
Amit.
Thank you, sir.
ये जनगण मत करो भाई.
Good afternoon. First of all, I'd like to congratulate the Sakar City branch for holding such an amazing conference. My best wishes to the City branch for their future endeavors. And with this note, I would like to hand over my charge to Dr. Sudhakar Dwivedi, and I hope the new team will take MP State to greater levels. Thank you. Jai Hind. Long live ISA.
This was the video from Dr. Neershudha madam, and now I would like to show one more video from our ISA City branch.
Please just speak loud. हमें जरा जोर के बोलें.
Dr. Amit, please speak.
Just a video from production of all the whole society. So this was the society members which were involved in the Mpisacon, and just one last photo from our side. Sir.
हमें थोड़ा सा तेज बोलो.
Sir, this was the video.
तेज बोलो.
This was the video in which all the members of ISA Society Sagar City branch was there, and there's just last one photo to share our emotions in front of all of you. You have to wait 30 to 40 seconds for it, sir. Just wait. Sir, there will be one photo Dr. Ajay will be sharing with you.
Amit, please speak loudly.
Sir,
You're
Dr.
not audible.
Ajay. Sir, now I am audible.
Yes.
Sir, Dr. Ajay will be sharing a single photo with you with all our emotions which we want to express right now at the end of this conference. He is in a meeting, just assembling the thing in a to how can he share the screen. So just apologizes for this few seconds delay.
Okay, go for it.
We are with us, sir.
Okay.
Sir, I was saying about hello. I was saying about this photo. Dr. Ajay, please share the same photo, please. This is a video. I'm not saying about this video. Okay, this was the photo, sir, which was I want to say all from all our heart. We are sorry from what we have done by the words, by the deeds. All are the seniors, so please forgive us, and whatever we have done, please tell us frankly so we can improve ourselves, and we try ki next time we will bounce back better than this time.
I mean, you did an excellent job, no doubt about it.
Thank you. Thank you. It was too excellent.
Amit from our side.
A big clap for you.
Sir, this clap should go for the whole society, sir, not for the Amit. This is the whole team which is responsible for me.
Yes.
I'm the
I congratulate and best wishes for the whole team.
Yes, sir. Thank you, sir. Thank you so much, sir.
Sagar and ISA MP State. Team Sagar
Yes, sir.
and ISA MP State.
Yes, sir. Thank you, sir. Thank you. Thank you.
Absolutely, sir. If I may, it was a fledgling society of anesthesiology, the Sagar City branch. But they have done such a wonderful job in a very, very short notice of time. And they have done wonderfully well. I congratulate everyone who has participated so thoroughly in the conference to make it such a big success. Congratulations, all of you, Sagar City branch, PMC.
Thank you, ma'am. Thank you so much from my all team.
Thank you very much, Dr. VM sir, Dr. Arora sir, Dr. Sadhana Sambatsarkar madam, Dr. Lalit Mahindra sir, Dr. Ruchi, Dr. Lalit Pandey sir, and all my seniors,
sir,
colleagues and my juniors.
Dr. Mamta madam, Dr. Mang sir, Dr. Rekwa sir, Dr. Lalit sir, Dr. Dhavle sir, Dr. Brijesh Kaushal sir. Sir, so thanks to all of you from my side, sir. सर ने अपने सीनियर को रिस्पेक्ट किया, मेरे सीनियर रह गए थे सर आपके कारण, so that's why I stopped you in between. Thank you, sir. Thank you so much to all of you, sir.
Thank you, everybody. Thank you.
Nice presentation, Dr. Amit. Well done. All the best.
Sir, thank you, sir.
Thank you.